country. To have a competent anesthetist, we need to have a good training program, continue medical education, continue professional development in all aspects of related fields of anesthesia. Karachi chapter of Pakistan Society of Anaesthesia has still retained its leading role by providing organizational as well as academic guidance to other branches of country, and 41st annual conference is evidence of it. Modern anesthesiologist is a consultant and a primary care provider. As a consultant, he or she owns the patient, and as a primary care provider, look after patient in immediate perioperative period. The captain of ship doctrine, which held surgeon responsible for every aspect of patient perioperative care, no longer valid. Surgeon and anesthetist function together effectively, but both are ultimately answerable to patient rather than to each other. As a theme of this conference is perioperative anesthesia care, medico-legal implications. The lack of adequate perioperative documentation has legal implications and can potentially affect the quality and safety of patient care. The scientific program of conference is made looking at theme and hope in these 2 days, today and tomorrow. Other than other topics of anesthesia related recovery area, cardiac, neuro and others, the medico-legal problems related to perioperative period will also be discussed and their solutions will be addressed. And definitely that will have a positive impact on patient care and also the practicing anesthetist. This is very important because this topic is chosen. There has been a lot of medico-legal problems in the Healthcare Commission. Tipu Saab remained the chairman of that one, and in the newspapers you come. So lot of things are which can be avoided and which can be addressed in very simple way. So this is very important because nowadays things are not just like you are just going to put the patient sleep and just to come out. Anesthetist is responsible whatever. Very simply, it is हम लोग जब practical life में आते हैं तो हम कहते हैं 5 रुपए सुलाने के हैं, 95 रुपए जगाने के हैं. So you are paid for the goodwill of the patient, for the recovery of the patient, and that starts from the pre-op assessment. It is just not to put the patient on sleep. So you have to optimize before taking to the ORs. And problems start there, especially in our other tertiary, other cities like even in the Karachi, in the peripheries of Karachi or Hyderabad, Sakhar, Larkana. So we have to address those things. Because now anesthetists are qualified. You will find a lot of qualified anesthetists and they are doing good practice, but still a lot to be done. In the end, once again, I thank you all for sparing time to attend this inauguration session, because there are few plenary lectures in between, so we have to just go quickly. Thank you very much.
Anesthesiologists, technicians, and healthcare workers all around the world take patient as the sole top priority. Everyone is working from the past few decades diligently to improve anesthesia patient safety. Dr. Asma Abdul Salam, General Secretary, PSA. Ma'am, kindly please join us on stage for a presentation of the annual report.
Assalamu alaikum everyone. Honorable Chief Guest Dr. Suhail Rajput, respected Guest of Honor Dr. Fauzi Anis Khan, Patron PSA Professor Tipu Sultan, Patron Karachi Professor Saida Haider, President PSA Karachi Professor Amin Khwaja, respectable guests, ladies and gentlemen, I welcome you all today and it is my honor to present the annual report of PSA Karachi on the occasion of PSA's 41st annual conference. This year, under the auspices of Professor Tipu Sultan, PSA Executive Committee and Cabinet members decided to keep the theme of the conference, Perioperative Anesthesia Care, Medico-Legal Implications. The Society has always tried to ensure and maintain the parameters of safety in patients coming for surgery. The background of this year's theme included few serious incidents followed by drug events. We, as anesthesiologists from all over Pakistan, not only got concerned, but our stake also came on halt in the provision of safe anesthesia care. PSA Karachi chapter anteceded in not only discussing this serious problem in the cabinet meetings, but also taken up the matter to discuss it at anesthesia session in the Confederation of Medical Association of Asia and Oceanic, and along with Pakistan Medical Association, SEMAO PMA joint conference, which was held on 24th of September 2022, in which the safety of neuraxial block was discussed from all aspects. On the educational side, this session was among many other workshops and hand-on sessions conducted throughout the year 2022. At different times in the year 2022 through 2023, different academic activities were organized and conducted by different institutions across Karachi. Primary Trauma Care Foundation and PSA conducted a workshop on airway management at Janassan Medical University on 3rd May and 21st September 2022. Similarly, workshop on basic and advanced airway management was conducted at Fazaiya Rootfau Medical College on August 26, 2022. Another workshop on point of care ultrasound in ICU was held in October and later in February 2023 at NICVD. A workshop on ultrasound guided nerve blocks was conducted in collaboration with PSA in the preface of World Anesthesia Day on 14th October at Fazaiya Rootfau Medical College. Lastly, basic life support workshop at Hamdard College of Medicine and Dentistry was also held in October in 2022. This is besides the 73rd postgraduate course for anesthesia residents at Dow University of Health Sciences and Civil Hospital, which was held in collaboration with PSA, and it was held between 15th to 24th of August 2022. The Basic Assessment and Support Intensive Care course, which is also known as Basic course, was also conducted at the Indus Hospital from 25th to 27th of October 2022. Now, taking it a little further, PSA Karachi also takes pride in the initiation of the online lecture series based on the recent guidelines and evidence. 20 out of 25 lectures have already been held since 6 June 2022, with the attendees from not only Karachi, but keen learners from less resourced areas in Pakistan and outside, including countries like India, Nepal, Nigeria, and Middle East. From next session onwards, faculty members from other cities and countries will also be joining us in carrying forward this mission. On the recreational side, annual iftar dinner was organized at the Creek Club DHA on April 20th, and the 40th annual conference PSA Workers Brunch was held at DHA Creek Club in May 2022. PSA celebrated World Sepsis Day with the 11th Sepsis Symposium at Movenpick Hotel, Karachi on 13th September 2022. Let's not forget, it was not only a celebratory event, there was a full-on academic session on that day. World Anesthesia Day, like every year, was celebrated with full zeal on 16th of October at the Beach Luxury Club, in which the memories associated with the voyage of anesthesia in Pakistan were recalled. 3 newsletters have been published in year 2022 to keep the colleagues updated. PSA Karachi has been conducting regular cabinet and general meetings. In 2022, 1 executive meeting and 4 cabinet and general meetings were held apart from the meetings which were held specifically for the conference preparations. For the organization of this 41st annual conference, 8 formal meetings, multiple informal meetings, and in the last few days till yesterday, frequent Zoom meetings were held, starting from December 2022 till March 2023. Different committees were formed and tasks were assigned to each committee member. This year as well, PSA Karachi has taken the lead in organizing 11 pre-Congress workshops which were held in different institutes of the city with good audience. Today and tomorrow, we will be having different sessions, plenary lectures, free papers and poster for residents, the details of which will be shared by Professor Zahid Rao, who is the chair scientific session, soon before the start of the next session. I'm delighted that today and tomorrow, we are having speakers from outside Karachi, and a very warm welcome to all of you to the City of Lights, Karachi. We have no conference activities without the daily volunteering of PSA members and our clinical faculty, a commitment of whom exceeds expectations every time. I'm grateful to every one of you for your tireless efforts in organizing this conference. I will see you all in a bit at the launch of the YouTube channel. Thank you.
Professor Dr. Saida Haider, the woman I aspire to be. Patron PSA Karachi, former Dean Faculty of Anaesthesia CPSP, Chairperson Department of Anaesthesia Indus Hospital, and former HOD Civil Hospital Karachi, has joined us today for a plenary lecture on anesthesiology practice and safety standards.
Thank you very much. Many thanks to Brigadier Zahid Akhtar Rao for giving me this opportunity. To talk my heart out on this subject of anesthesia practices and and safety standards in reducing. I can add one word to that perioperative anesthesia care, medical legal implications. I think a more important word that should be added over there is a lot of heartache that is associated, that can be associated with perioperative care if we don't do what we are supposed to do, if we don't look into things that we are supposed to. I have no conflict of interest. Today with Dr. Rajput sitting here, and I was expecting the CEO of the Healthcare Commission also here, and a lot of administrators, and of course colleagues. I thought this would be the right forum to say things, to sensitize the stakeholders about anesthesia. It is no longer putting the patient to sleep and waking him up. It's a vital component of basic health care. It is inherently complex and potentially dangerous. It is pivotal to patient care of most specialties. Anesthesia means comprehensive perioperative care. It does not mean putting the patient to sleep and waking him up. If you're going to make anesthesia safe, you are making the patient safe of all specialties. An internist can only kill an internal medicine patient, but we can kill patients from all specialties, so I think it's very important. All of us have taken this Hippocrates oath. We may pronounce it in Latin, primum non nocere, or in English, primum non nocere. But it makes the fundamental basis of healthcare, that please do no harm. And around us is so much harm, and we sit and watch. I don't know if it is fair. The first lesson, on my first day as a novice to anesthesia, which is an acute, dangerous care that I was given, was that while the patient you may lose on the table may be one of the thousands you manage, but remember, he or she is 100% to his or her loved ones. And we talk about this topic while in the world, anesthesia has become the safest specialty. It is way back that this paper was published in the Canadian Journal of Anaesthetists, which says that the anesthetic mishaps have reduced 50 times. Like if 1 in 5,000 were dying from anesthetic mishaps, today 1 in 250,000 die. It is the safest, and we are still talking about how to have anesthesia standards. Anesthesia actually leads in improving patient care in the developed world, and the basic reason is that the sources were identified and preventive measures were implemented it's not a difficult deal. So, and these global initiatives in the Western world or in the developed world reduce the anesthetic mortality to 1 in 250,000 from 1 in 5,000, while unfortunately in the lower and the middle income group, it still looms around 1 in 300. And of course, things are bad in Pakistan. Why it is still unresolved in Pakistan? Because resolution comes from determination. The policymakers, do they identify issues? Do we identify issues and find solutions for them? There's a simple example of this confidential inquiry into maternal deaths. They realized that lots of deaths were happening, maternal mortality, the rate was very high. It was 90 per 100,000. They took steps and reduced down to 10 per 100,000. While in Pakistan, it is supposed to be a human right issue. It is 500 per 100,000. We should be ashamed of it. Well, this slide says a lot about anesthesia. Anesthesia has no test dose. The medications that we use are dangerous. The high vulnerability comes from, this is what is happening in the OR. There are a lot of interventions. There is a constantly changing technology. You have to keep up with it. You maybe forgot to check the machine. There are long working hours, workload, fatigue, noise, too many teams working, too many medications to be given, to be handled, were they labeled or not. Patients are there with comorbidities. There are system failures, oxygen aani band ho gayi, vagera, vagera. Can we contribute? So today we sit here and see that can we contribute as professionals and policy makers? Yes, we can. Why don't we look into the global efforts and approach, and then maybe look into our own dilemmas and possible solutions, both clinical and non-clinical. It has to be an out-of-box solution. Declaring gaps in anesthesia services in Pakistan as a healthcare emergency. Most countries are there. Why can't we reach there? One, the concepts and attitudes have to change. We need a jolt from choti si surgery and thoda sa anesthesia to comprehensive perioperative care, which starts in preoperative period and concludes in the post-anesthesia care unit or the post-ICU discharge. And secondly, so much research has been done that this is international, the Institute of Medicine, that they realized that most of the errors that happened in anesthesia and the sentinel deaths that happened were due to human error. So they realized that and they tried to address it. And we should also learn from our tragic events. The recognition of this human factor and ergonomics may be the key to reducing morbidity and mortality and a lot of heartache and litigation. Let me share some of the tragic events that I have recently been involved with in their inquiries, and I'm really, they touch my heart. A young girl, ASA1, goes in for a minor surgery under GA and has a table death, anesthetic mishap. An anesthesia consultant, one of us, goes in for non-OR anesthesia, small procedure, ends up vegetative. Middle-aged man has an emergency. These are not imaginary cases. These are all cases that have happened recently. Emergency appendectomy, becomes a vegetative and dies after a few months. And can all the anesthesiologists sitting here ever think that an emergency cesarean section in a patient with dengue, a platelet count of 12,000, and getting a spinal anesthesia? Placenta accreta, massive hemorrhage with inadequate blood, it's not required. Typical surgeon attitude in a peripheral hospital has a table death. They say that for an event to happen, at least there are 8 barriers to that for that event to happen. If it had been stopped here, this would not have happened. And it's a Swiss cheese model that if there are always holes, you must have had Swiss cheese, and there are holes in the Swiss cheese. If all the holes get aligned, that is only when that last thing happens. So it's no use pinning the blame on that anesthetist in whose hands it happened. It is really all of us are responsible. So solutions, what can be done? So many things can be done. They say if you can't do great things, do small things in a great way. So each one of us can do a small thing in a great way. So the PMDC, CPSB, Healthcare Commission, Ministry of Health, PSA, hospital owners, administrators, managers, surgeons, all of us can do something. So what can the PMDC and CPSB? When I joined anesthesia, I did not know that it is such a lovely evil because we are not exposed to anesthesia at the undergraduate level. Can we add it to the curriculum, assess the national needs, and then counsel the candidates कि भाई इस वाली field में जाओ, इसमें requirement है. The suggested anesthesia workforce is 20 per 100,000 by 2030. This has been suggested by the WHO and WFSA. We are 1 in lakhs or maybe, I don't know. Facilitate by increasing the training slots, increase the number of supervisors and mentors, find ways to increase the human resource pool. And this is no easy task. We have to have out-of-box solutions. We must promote training programs. CPSP can promote training programs. The major, I mean, there has to be some principles. The major hospitals should have major diploma holders, peripheral hospitals can have minor diploma holders, and rural hospitals can have anesthesia providers who can at least recognize and resuscitate the patient and are able to refer. That, I mean, this would save so many lives. The Healthcare Commission and the Ministry of Health can do so many. They can also, like I'll be sharing what levels of healthcare facilities mean. We can also have different levels of healthcare facilities, and the scope of practice of each facility can be known, and we should do it expeditiously and efficiently. We should get it implemented, the best practices to be implemented, and this has to be done in the form of human resource, equipment, basic infrastructure, documentation, etc., etc. Can we, as PSA, play a role? Yes, why not? The WFSA, the Association of Anaesthetists of Great Britain and Ireland, all of them play very important roles. We should also be a voice. We should be a voice, we should brainstorm, give our input to the hospital admins, to Ministry of Health Service Planning, if they listen to us, of course. There's the CPSP, as well as, train the public to ask questions. Have implementable suggestions. Now, there is this program, Emergency Obstetric Care, that has been designed by Johns Hopkins, in which they have a lot of out-of-box solutions. We can also have documents like that and get them implemented. Encourage training programs for anesthesia and for paramedics, because if we want कि हर जगह एक FCPS बैठा हुआ anesthesia दे रहा होगा, that will never happen. So it is best to start training, thinking on other lines, on task force, and then have public awareness programs. My word of advice to the hospital owners and to the managers and to the administrators sitting here, please consider the OR to be the most dangerous place of your hospital. Take all the measures to make it safe. This is the most neglected area, especially in private small hospitals. Show no compromise on the anesthesia and monitoring equipment, adequate staffing with properly trained and qualified healthcare workers, dedicated pre-op holding areas, post-op care, the culture of documentation, and then have something like critical incident monitoring reporting, incident reporting for a root cause analysis, not to pin blame, but to find out कि कहाँ problem हुआ था so that we can address it. Now, this is this WHO surgical safety checklist. It is such a small thing. Get those printed, have it there, do a timeout before the patient goes in on the table, and maybe you can save so many deaths. The surgeons, the primary physicians, inform the patient about this very important person that is going to be there, the anesthetist, Remember, most table deaths, the surgeons should remember this, they will not kill the patient on the table, we will. Remember, most table deaths result from anesthetic mishaps. They should not undermine anesthesia. Do not compromise care of money. The problem is that the patient comes to the surgeon and the surgeon has a direct dealing with the patient. So they never let the patient know that जो तुम्हें मारेगा या तुम्हें ठीक रखेगा वो एक और आदमी है जो वहाँ होगा और वो बहुत important होगा. And now coming to the anesthesiologist or the anesthesia provider. You are the clinical wizard. Anesthesiologist, of course, has a better understanding of clinical physiology, and that gives us that edge. And we are looking after the patient as a whole, the cerebral perfusion. Look at that position. We have been dealing patients in that position, airway, hypoxia, all that, it's all in our hands. And the surgeon never lets the patient know that, there's somebody who's going to be managing all this. They just talk about that surgical procedure that is going to happen. There is this very nice message from WFSA for the year 2023 for all the anesthesiologists. And this year, I believe Chinese have declared this year to be the year of rabbit. And it is interesting, it was new for me also. I knew rabbit as only as a very big breeder, but I learned that rabbit often has a quiet personality that hides confidence and strength. It has good reasoning skills and attention to detail, making it a great scholar. Perhaps rabbits and anesthesiologists share the same personality traits. And the year of the rabbit, let it be our year. My word of advice to the anesthesiologist is please take the ownership of the patient. Be a perioperative physician. Take a leadership role. Be the captain of the OR. No compromise on drugs, disposables, and equipment, which we keep doing in these small peripheral hospitals. Documentation and record keeping. In all those cases that I mentioned to you, there was no documentation. And later on, it was whatever you write, it doesn't really matter. And do not cave into the surgeon's pressure. Remember, apart from being clinically very strong, anesthesia personnel need a lot of non-technical skills of communication, coordination, and OR discipline. Now, about the OR discipline, I'll tell you, like one of those cases that was being discussed, that the anesthetist had not changed the dress. And the family was saying that he was never there because when we saw him, he was not in the OT dress, he was in his regular dress, and maybe he was not there at all when my patient died. And then he said, so when we were questioning him, he said that, please tell me, did the death occur because I was not wearing the dress? Of course, that was not the reason. But then I asked him, will you climb a plane, an aeroplane, in which the pilot walks into a shalwar kameez? Would you like to be on a plane like that? You wouldn't. So there's something like OR discipline. Be a coordinator of services at the hospital level. Talk to the admin, ER. You can talk both ways, primary physician, transfers, intensive care. As far as the media and public is concerned, media can be used to create awareness about anesthesia because the surgeon doesn't. Patients should exercise their basic right. They should know their anesthetist and they should question the facilities of the hospital. It's no use बाद में आके कहना कि हमें नहीं पता था वहाँ पे ये नहीं था वहाँ. You should ask before that. Anesthesia can be associated with death and debility. It is not a much ado about nothing. Anesthesia in the past was simple and not safe. Today, this is what anesthesia is. I mean, it's very complicated. It has changed, and we have to realize that this change has occurred. We have to have policies and priorities according to these changes that have come into the infrastructure, education, and awareness. Now, the WHO, WFSA initiative was taken in 2008, and the landmark publication came in 2010. And the two things that they identified was that safe surgery saves lives. And by that, they meant was that, 1/3 of all the burden of the disease, TB, malaria, HIV put together, is surgical. So you can make 1/3 of the whole patient population safer if you have good anesthesia and surgical facilities. And then they also decided that we'll have a group which will make standards, and they will have a periodic review. The two aspects that were highlighted were that most of the patients died in the lower and middle income countries was because they had lack of access to the facility. What they meant was that, hernia is being done in Civil Hospital Karachi or Indus Hospital, but that intestinal obstruction that needs to be done in a tertiary care hospital, or uske liye jagah nahi hai, time nahi hai, the patient is refused because the hospital is full. So appropriate premises, equipment, healthcare professional, the scope of surgery is defined for each category. And the lack of discipline was the other thing, the attitudes was the other thing that they have highlighted. It's a patient right. Access to surgery is a patient right. And if we plan divide the workload, we will increase the healthcare, and a healthcare commission can play a major role. How they have divided, and it's so easy for us to do that, is that the level 1 should have just most minor surgery. Some cases may require anesthesia, so very basic things should be there. Level 2, all bellwether surgeries, like sectional laparotomies, open fracture. And level 3 may be restricted for subspecialty anesthesia, complex surgeries, education, research. We have to adhere to safe perioperative practices like a routine preoperative or a pre-admission, maybe telephonic assessment, but you must know your patient. Explain and counsel, get an informed consent, optimize, refer if the patient needs referral. Qualified, trained, supervised anesthesia providers, adequate numbers of skilled, trained help, clinical vigilance, presence, and monitoring. I think I cannot never overemphasize on that. So there was this project that goes on by the WFSA, which is known as the Lifebox project, in which they provide pulse oximeter to these lower and middle income countries if you give them कि हमारे यहाँ ये cases होते हैं and we need a pulse oximeter. There should be safe transfer policies to PACU and to the intensive care hospital. So what is the way forward? The commitment of all stakeholders to safe surgery and safe anesthesia. Realization that anesthesia is as important as surgery. Anesthesia should take a leadership role and be a perioperative physician. We can have a forum, a safe perioperative care in Pakistan, because one death due to negligence is one too many. And I would end my talk here by saying anesthesiologists are lifesavers. This is someone I really admire, Admiral Hadzik. He's known for regional anesthesia. A good surgeon deserves a good anesthesiologist, but a bad surgeon needs one. Thank you very much.
An anesthetist bailiwick is patient. From head to toe, from his NPO hours to feeding initiation, from calculating blood loss to replacing it, from ample amount of sleep to awakening him at the right time. An anesthetist is God's apprentice in the OR room. It's a tricky and risky business. A perfect outcome is our relief. I will now invite respected Professor Fawzia Anis, Professor of Anesthesia, Aga Khan University, member of Safety and Quality of Practice Committee of World Federation of Society of Anesthesiologists, for a plenary session on steps to improve perioperative patient safety.
Slideshow again. Slideshow. Assalamu alaikum, everyone. My topic for today is, again, it refers to anesthesia safety, steps to improve the perioperative patient safety. There is going to be some overlap with the previous speaker because we're both talking about the safety of the patient. Now, I have no conflict of interest to declare, apart from being, as the introduction said, a current member and former chairperson of Safety and Quality of Practice Committee of the WFSA. Now, the concept of patient safety, as defined by the WHO, is that patient safety is the prevention of errors and adverse effect to patients associated with healthcare. And as Dr. Saida mentioned, the concept of patient safety has originated from anesthesia, and they've been the leaders in doing work in anesthesia safety, and it was popularized by the anesthesia practitioners. Now, providing anesthesia is an intrinsically hazardous activity. This just shows the operating room. There are many, many things that can go wrong. There are multiple teams working in the operating room, and there may be lack of communication, a non-availability of equipment, non-availability of drugs, etc. But perioperative safety refers to much more than that. It's not just the operating room. So it depends on the preoperative planning and evaluation, induction and airway maintenance, then maintenance of anesthesia, emergence, and the postoperative care. Now, when we talk about perioperative safety and refer to these periods, then some of the key issues or key elements that emerge are the safety standards, adequacy of the workforce, training of anesthesiologists, medication, equipment, resources, what data is available, and the quality culture. And I'll talk about some of these, where we are, and what we need to do. Now, just one or two slides about evolution of safety in anesthesia. For many years, anesthesia mortality was taken as a surrogate measure of anesthesia safety. So first, anesthesia death was published by John Snow in 1849, and this was a young girl, 15 years old, who received a chloroform anesthetic for removal of a toenail and died. Unfortunately, such things are still happening here, as Dr. Saida pointed out. Following this, there have been many changes in anesthesia safety. There have been studies on anesthetic deaths and severe morbidity. There's been improvement in delivery systems and equipment maintenance. Syringe labels have been introduced. Standards of that are available. Extension of anesthesia training programs. Initially, the programs began with 1 or 2 years of training. Most of the programs are 3 or 4 years in the world, or even longer. Improvement in monitoring, reporting systems have been improved, performance standards have been introduced, and newer equipment and techniques have been introduced. Now, this was a recent paper published in Anesthesia and Analgesia, which talks about anesthesia patient safety, next steps to improve worldwide perioperative safety by 2030. So they took opinion from anesthetists from different parts of the world, which included high-income countries and lower and middle-income countries. And the gist or the summary of the article, they've talked about the top 10 anesthesia patient issues worldwide. Now, I'm not going to read through the whole slide. I would request all of you to look at the paper and see what people are talking about. And some of these issues are common to us as well. So, taking up the key elements, Dr. Saida has again touched upon the standards. This was the latest publication on standards. This was a joint publication by the World Health Organization and the World Federation of Society of Anesthesiologists. And this was published both in Canadian Journal of Anesthesia and Anesthesia and Analgesia from States in 2018. These standards are recommended by WHO and WFSA for all anesthesia providers throughout the world. They are not just meant for high-income countries, but can be applied to lower middle-income countries and lower-income countries as well. What they say, you take up these standards and you look at your own resources and you can modify these standards accordingly. And there is grouping of standards, professional aspects, facilities and equipment, medication and intravenous fluids, monitoring, and conduct of anesthesia. So they're giving standards for each of these steps. And they've divided these standards, as the previous speaker said, the level of facility has been defined, a basic facility or intermediate or level 2 facilities, or in the level 3 facility. And then they say that the basic facility, they're recommending the highly recommended standards or mandatory standards. They've used the term highly recommended because that is the term that WHO prefers, but they also mention in the paper that these are mandatory standards for a lower level or level 1 facility. For level 2 facility, which is hospital with 100 to 300 beds, they say that the highly recommended standards plus the recommended standards should be there. So they've combined 2 lists there. And then for the level 3 facilities, which is a tertiary care hospital with a basic ICU, they're recommending that the highly recommended standards, recommended and suggested standards should be there. So it is something which is applicable for all hospitals in many, many countries. Where are we at present? I think that there are different steps that you can relate to these standards. There is awareness, there should be a commitment by the government, by professional organizations, and also institutions, and there should be resources and inspection and review on an ongoing basis. I think we're still at the awareness stage. We're still talking about these standards, but we have not been implicating it even in institution or at a national level. Secondly, coming to workforce. Now, improvement in anesthesia safety requires investment in training and training capacity of anesthesia providers with an assessment of need in terms of numbers required for the health system. We need to know what are the numbers required, how many anesthetists do we require. This was again a WFSA initiative. They did a survey of anesthesia workforce, and this was again published in 2017. And this is available to all on the WFSA website. If you use a pointer on the website towards a country, then the ratio, the density, work density, or the number of anesthetists per 100,000 comes up. And for Pakistan, the ratio is 1.64 anesthesiologists per 100,000 population. The number that is recommended by WFSA is a minimum of 5 anesthesiologists per 100,000 population. I tried to get some information. I got the information from 2021. I couldn't get the 2022 information. The number of MBBS doctors, which is registered with the Pakistan Medical Council or PMDC now, is 252,336. and the number of registered anesthesiologists is 3,393, which is 1.34%. It is said that if you want a good anesthesia service, this number should be about 5% at least. The number of anesthesia trainees who are registered with CPSP, again, this is a 2021 figures, for fellowship training, approximately 929, and membership training, 494 candidates. There may be a little increase in last year. So we are only adding about 1,500 anesthetists to this pool, and many of them are now moving out of the country. So we really don't know. The ratio would be 1.6 anesthetists per 100,000, maybe much less than this because of the movement. Now I just took it from the newspaper, again a supplement. Professor Khalid Bashir published this in 2015, and he's again highlighting the severe shortage of anesthetists, and he's giving several reasons, especially in government-run institutions, of why there is a shortage. And so the problem is being discussed, but what are we doing about it? There are many options to close the human resource gap in anesthesia in Pakistan. Anesthetists with higher professional qualification or equivalent, anesthetists with middle grade qualification at a membership or a diploma level, physicians with no anesthesia background, nurses, non-physician or non-nursing pathway. And we did discuss this in quite detail in our last annual meeting, but unfortunately nothing has happened after that. What we need is some baseline data. As I said, how many anesthetists are there in the country? We've done a little effort regarding this, at least in Sindh, and we've done a survey on the assessment of anesthesia workforce capacity in district and tehsil or taluka hospitals in the Sindh province of Pakistan. And the idea just happened when Dr. Amin and myself, we were sitting in the CPSP and during the exam, and we started discussing this. And he offered his help in conducting this. And there have been we've involved other anesthesiologists from Sindh province. This survey was carried from 1st September 2021 to 30th January 2022. And our objective was to determine the current availability of human resource at the secondary care hospitals in the Sindh province, and to identify the gaps in terms of appropriate number of anesthesiologists available for delivery of safe anesthesia care. So there were a total of 90 taluka and district hospitals, and there were 201 operating rooms in 80% of the hospitals, with an average of 3 operating rooms per hospital. The overall anesthesia physician workforce density per 100,000 population in these hospitals was found to be 0.26 if you divide it with the province, with the population of the province. But what was, the red mark? Only 54 hospitals had a full-time anesthesia physician. I can't go through the details of the whole of the survey, but this is, one of the issues. And this just shows the population of different divisions of Sindh and the number of anesthesiologists versus the number of surgeons and number of obstetricians. Ideally, this number for every for every surgeon and every obstetrician, for the 2 of them, there should be 1 anesthetist present. So you can see there is a disparity between that. And having 1 anesthetist, 1 full-time anesthetist in 1 hospital, covering day and night for 7 days a week, that compromises safety severely. So what is important at this stage We should not leave it to the administrators and government functionaries to decide the future fate of our specialty. As a professional body, we need to unite on a strategy. We should have plans for both short-term and long-term solutions. We should identify a committee with representation from all branches of PSA to liaison with the health services in each province on this issue. I think that there's a big need and an urgent need to do this. Now, coming to other safety issues, there are challenges in anesthesia education and training as well. There is lack of standardization in our undergraduate education, the choice of anesthesia as a specialty, there are limited number of seats available, especially in government hospitals. There is shortage of trainers and teachers in many hospitals, and there is lack of academic partnerships, curricular deficiency, and then, of course, there's been the effect of COVID-19. There is a big problem with retention of trained workforce. Access to continuing professional development, ongoing clinical supervision, acceptable working conditions, career progression, and adequate remuneration are all essential if a trained healthcare workers are to be retained in the country. Now, what about medication and equipment? Again, drug shortage is a universal problem, but shortage of anesthetic drugs particularly can have a wide effect implication on the patient's safety. Again, we did a survey on this, and this was a national survey. We looked at the shortage of anesthetic drugs as a major hurdle in delivering quality care. And this has again been published in the Canadian Journal of Anesthesia very recently. And this is, I'll show one or two slides of the result. We had asked a question, how has anesthesia drug shortage impacted your patients? And 4 of the anesthesiologists answered that it has, according to them, it has resulted in death of their patient. Then there have been increase in post-operative complications, increase in post-operative nausea and vomiting, and it has resulted in longer operating room timings. Another question was, how has drug shortage impacted your practice? And 58% said they had to use an inferior drug, and 17% said they had to use less familiar agents. 11% said they had to postpone their cases. 6% said they had to cancel their cases, or 7.9% said they witnessed a drug error as a result. Now, just 1 or 2 slides about lack of equipment. With the help of WFSA, we got a grant for this. We did mapping of anesthesia services for maternal and child health in the Sindh province of Pakistan. And this was again published in Anesthesia and Analgesia in 2022. I had a lot of colleagues from PSA working with me, including Dr. Saida and Dr. Nigat Abbas and others from the teaching institutions of Sindh. And this is one of the slides which looked at the availability of monitors in the surveyed institutions. And for example, pulse oximeters, though they are present in the private-run institution, one of the government-run institution did not have any pulse oximeter. And this, we are just referring to the presence of a pulse oximeter, does not mean that pulse oximeter is present in every operating room. It is sometimes carried from one room to the other to the third. Then availability of other equipment. Now, this survey was related to pediatric anesthesia and obstetric anesthesia. So you can see there was lack of non-invasive blood pressure monitors for children, pediatric ECG electrodes were missing, and there were other deficiencies. So also anesthesia machine and circuits with provision for pediatric and neonatal ventilation were available in only 66% institutions, and TP circuit was available in 91% of the hospitals. Airway equipment, disposable, were available in pediatric sizes, but a pediatric video laryngoscope was only present in 2 institutions, one public and one private. So basic essential equipment was missing in some of the hospitals, and lack of basic resuscitation equipment, especially airway equipment for handling obstetric cases. So anesthesia safety in Pakistan, what do we need to do? We have to change our attitude. We need a culture change with emphasis on safety, and we need low-cost quality initiatives. We need to collect safety-related data so that we have a baseline data telling us what's actually happening. We've been talking about it at different levels, but what is actually happening? We need more data. We need information on infrastructure. We need analysis of that data. And we need collection of data on perioperative safety issues like analysis of death, analysis of intraoperative cardiac arrest, analysis of critical incidents. There is a role of national professional societies in improving perioperative safety. We need to have a strong PSA center with representation from all regional branches and regular meetings. There should be a national quality and safety committee. There should be endorsement of guidelines from PSA. There should be ongoing activity to emphasize patient safety. There should be liaison with the government and increasing professional self-esteem. WHO safety checklist Saida has already referred to. Advocacy or WHO Patient Safety Day is one way of sensitizing your patients about the importance of anesthesia during surgery. And I'm glad that we are celebrating the Patient Safety Day. So what more do we need to do? We need a buy-in from the government. As I said earlier, we need to collect data. We need to implement the international safety standards and agree on the minimum anesthesia provider density. A safety committee at hospital and at departmental level, safety curriculum in the training of anesthesiologists, include patient safety as part of our anesthesia meetings, then World Patient Safety Day, and then quality improvement projects as alternatives to dissertation in FCPS examination. So in conclusion, although measures to improve patient safety and implementation and organization of QIC activities does have an additional cost, but this should not be used as an excuse for maintaining status quo. There are many simple measures that are not too expensive. But all this also requires commitment, dedication, change in behavior and practice of not just anesthesiologists, but also by organizations, hospitals, policymakers, and other providers. And remember that our ultimate goal is to improve outcome for our patient, and still a lot more needs to be done to make anesthesia safer for our patient in this country. Thank you very much.
All our dreams come true if we dare enough to pursue them. The only goals we are unable to achieve are the ones we never set. Here is to the people who have spent their lives working tirelessly for anesthesia in particular and healthcare profession in general in Pakistan to make it better. I would invite Professor Safiya Zafar to read citation for the Lifetime Achievement Award for Dr. Mirza Ali Azhar.
इसमें नहीं चाहिए
वो मुझे एक्सेस देना है आप कर लें स्विच ऑन
Thank you for inviting me to say something about our elder brother, Mirza Sahab. Dr. Mirza Azhar, popularly known as Mirza Sahab, is a law graduate. According to his autobiography, Baatein Mirza Ji Ki, he was born in 1954 in Karachi. He was never interested in going to school and ran away from 5 different schools. Finally, he was admitted in private Mohalla school in class 4. After passing, he removed to government boys secondary school, Jail Road for class 5 and 6. Then left to Khipro for class 7 and came back to Karachi and passed class 8 from GBSC Jahangir Road. Then again he went to Khipro and done his matriculation from Government High School, Khipro. After intermediate, from National College, Karachi, he got admission in Daw Medical College. After his MBBS final exam, he joined Department of Anesthesia, worked for few weeks, but after exam result, he could not get paid house job and left the department. He came back to the department in 1992 as a PG student and done his MCPS in 1995. Apart from being a doctor, he is a poet, writer, singer, human rights and political activist. He is working with Pakistani Medical Association in different capacities for last 4 decades. Currently, he is an elected commissioner of Sindh Healthcare Commission, regional vice president of Pakistani Doctor for Peace and Development, and coordinator for Concerned Citizens Alliance. Mirza Sahab, please. Now, I would like to invite our chief guest, Dr. Suhail Rajput, for giving a shield to him. Please.
Now I would like to invite Dr. Hamid to come up on stage and read citation of Lifetime Achievement Award for Professor Noorul Haq.
Assalamu alaikum. Professor Dr. Syed Noorul Haq was born on 20th September 1959. He graduated from DMC Daw Medical College in 1984, did MCPS in February 1987, trained in the Department of Anesthesiology, Civil Hospital Karachi under the supervision of Professor Syed Tipu Sultan, joined Abbasi Shaheed Hospital in 1987 as a consultant anesthesiologist, did his fellowship in 2002. Then appointed as an assistant professor in October 2002 in KMDC, Karachi Medical and Dental College, promoted to associate professor in 2007, and then promoted to professor in 2010 in Karachi Medical Dental College. Became in charge of surgical ICU and pain management in 2010 and worked till his retirement in September 2019. During his tenure, all of the patients were provided free medical care, and he is one of the founder pain consultant of Pakistan and has established pain clinic in Abbasi Shaheed Hospital since 2002. He has more than 25 research articles in national and international journals. He is instructor of BLS and PTC. He is reviewer of different journals of Pakistan like JPMA, CPSP, and Annals of Karachi Medical and Dental College. After passing FCPS in 2002, he started taking part in PSA and became Joint Secretary, then General Secretary and President of PSA Karachi chapter. He also worked as a President of PSA Center from 2018 till 2022. At the same time, he also worked as a President of SARC from 2018 till 2022. He is a regular examiner and paper setter of MCPS, Intermediate Module, and FCPS since 2005. He is examiner of FCPS, pain medicine. He is one of the few supervisors of CPSP who are examiner of both anesthesia and pain medicine. At present, he is working as a head of Department of Anesthesia and Pain Medicine at Hamdard University Hospital. Dr. Syed Noorul Haq. I invite Dr. Syed Noorul Haq to come on the stage. Now I invite Dr. Suhail Rajput to come on the stage to give momentum. Thank you.
Professor Shahab Naqvi to kindly join up on stage to read citation of Lifetime Achievement Award for Professor Brigadier Dr. Zahid Akhtar Rao.
Thank you so much. Bismillah ar-Rahman ar-Rahim. It is a great honor for me to talk about one of my dearest friends and colleague, Professor Brigadier Zahid Akhtar Rao, who is Professor of Anesthesiology and Director of Postgraduate Medical Education at Fazaiya Lutfa Medical College, Karachi. Since his graduation in 1984 from Liaquat Medical College, Hyderabad, his journey to excellence has been a story of hard work, commitment, and dedication to the profession. He joined anesthesiology in 1986, and from the day one, he was into it. I know him since 1988. He's a very social person and likes to remain active amongst the friends, but still he never regretted joining a specialty that limits his mobility to operating rooms while working for long hours. While in Pakistan Army, he had to keep moving from one city to the other, but wherever he went, he made an impression by developing new departments, improving systems, and promoting postgraduate medical education, creating extracurricular opportunities for the colleagues to enrich work environment. His last leg of Army service was at PNS Shafa, Naval Hospital, Karachi, where as head of department, he made substantial changes in surgical intensive care and emerged as a leader. During this stay, he worked for CPSP as examiner, paper setter, secretary of the faculty, and contributed in developing the curricula. In the same time frame, he rendered his services to Pakistan Society of Anesthesiologists, Karachi chapter, and PSA Center. He remained its secretary and president on different occasions, and organized a number of national and international conferences of anesthesiology and intensive care. After his retirement from active Army service in 2016, instead of slowing down, he kept his energy levels high and initially joined and started trauma center at Civil Hospital, Karachi, and then joined Bahria Town Hospital and started their anesthesia and intensive care system, and now he is working at Fazaiya Medical College for last 4 years and looking after his their anesthesia and CME CPD department. He regularly runs BLS courses, ACLS workshops, primary trauma care courses, HOPE course, and basic intensive care courses as part of his continued medical education and professional development program. On this day, 11th March of 2023, he is being bestowed upon with a Lifetime Achievement Award from Pakistan Society of Anesthesiologists for more than a decade of leadership, of teaching, development of curricula, engagement, and learning for anesthesia postgraduate trainees, for introducing immersive learning, peer teaching, and creative extracurricular opportunities for his anesthesiology colleagues and other staff members, and inspire anesthesiology students to enhance their learning outcomes. For translating all this teaching, learning activities, and system developments into better patient care. Now I request Professor Dr. Brigadier Zahid Akhtar Rao on the stage, please. And may I also request Dr. Suhail Rajput, the chief guest, for giving away the award. Thank you.
Now I would invite Professor Tipu Sultan, patron PSA Center, to share his views with us today.
थैंक यू वेरी मच। मैं सबसे पहले तो खुश आमदीद कहना चाहता हूँ सुहेल राजपूत साहब को कि हमारी खुशनसीबी है कि राजपूत साहब चीफ सेक्रेटरी भी हैं और फिर हमारी खुशनसीबी है कि डॉक्टर भी हैं। मैं सोच रहा था कि इतने 2 लेक्चर इनको सुनना पड़ा और वो भी इतना सकील किस्म का, तो कुछ हाजमा ना ख़राब हो जाए। मैंने पूछा चुपके से, तो कह नहीं कोई मसला नहीं है, कुछ अच्छी एजुकेशन हो रही है। थैंक यू वेरी मच सर। सबसे पहले तो मैं इस बात पर अपनी खुशी का इजहार करना चाहता हूँ कि 46 साल पहले जो पौधा लगाया गया था वो इतना बड़ा दरख्त हो गया है कि इसमें से इतने बहुत सारे रंग बिरंगे फूल आ गए हैं और 3 की एग्ज़ाम्पल आपने देख ली। और हर साल ये अचीवमेंट अवार्ड होता है अगेन टू अप्रिशिएट आवर कोलीग्स जो कि एक लर्नर, हाउस ऑफिसर, पीजी की शक्ल में आकर के हाईएस्ट पोजीशन, प्रोफेसर एंड टीचर, बिल्कुल उस तरह जैसे कि कहावत है कि अपनी इल्म, अपनी तालीम को खूब फैलाओ, खूब बांटो, इससे पहले कि तुम्हारा ट्रांसफ़र फ्रॉम दिस गैलेक्सी टू दैट गैलेक्सी हो जाए। मौत का लफ्ज़ इस्तेमाल नहीं कर रहा हूँ, लोग ज़रा नाराज़ हो आते हैं उससे। तो ट्रांसफ़र ऑफ गैलेक्सी है फ्रॉम दिस पार्ट टू अनदर पार्ट। बहुत ज़रूरी है इस बात पर, स्पेशली एनेस्थीसिया के हवाले से। 2 खूबसूरत प्रेजेंटेशन अभी हमने देखी रिगार्डिंग द सेफ्टी। थैंक यू वेरी मच डॉक्टर सईदा, थैंक यू वेरी मच फौजिया। ब्यूटीफुल प्रेजेंटेशन एंड ब्यूटीफुल सर्वे। और इस मौके से मैं फ़ायदा उठाना चाहता हूँ चीफ सेक्रेटरी साहब को कि इस सर्वे को मैं आपको भिजवाऊँगा, प्रेसिडेंट साहब भिजवा दीजिए, इसलिए कि वी आर वेरी शॉर्ट ऑफ एनेस्थेटिस्ट। सारी दुनिया में प्रॉब्लम है लेकिन पाकिस्तान में भी बहुत ज़्यादा है एंड वी आर लूजिंग आवर पेशेंट्स। क्वालिटी ऑफ एनेस्थीसिया इज़ अ प्रॉब्लम एंड क्वांटिटी इज़ अ प्रॉब्लम। वी आर प्रोड्यूसिंग अबाउट 1400 to 1500 एनेस्थेटिस्ट पर ईयर फ्रॉम CPSP। छोटी छोटी बात नहीं है, 1400 एनेस्थेटिस्ट। लेकिन अनफॉर्चुनेटली बिकॉज ऑफ द पोस्टिंग, बिकॉज ऑफ द मनी, बिकॉज ऑफ अदर फैक्टर्स, they leave the country. हर साल FCPS जो पास होते हैं 3-4 महीने मुझे यहाँ नज़र आते हैं, उसके बाद वो अनका हो जाता है, कहीं निकल जाता है इधर उधर। और जाहिर सी बात है बैकयार्ड ऑफ पाकिस्तान, मिडिल ईस्ट इज़ उनको फ़ौरन बुला लेता है ऑन ए मैसिव सैलरी। उसके बाद वेस्टर्न वर्ल्ड है, इंग्लैंड खास करके, दे आर शॉर्ट ऑफ एनेस्थेटिस्ट, तो वो भी किसी न किसी बहाने उनको बुला लेते हैं। एंड ऑफ कोर्स वी हैव गॉट नो राइट टू ब्लॉक देम टू गो, दे हैव गॉट ऑल द राइट टू गो। मसला इस बात का साहब कि वी मस्ट प्रोड्यूस क्वालिटी एनेस्थेटिस्ट एंड गिव देम इंसेंटिव, मोटिवेशन, सो दैट ये जो गए हैं वहाँ से तालीम हासिल करने के बाद वापस आ जाए। आई विल रिक्वेस्ट यू सर, पूरे रेस्ट ऑफ द कंट्री, खास के पंजाब में और प्रोविंस में एक अलाउंस मिलता है, VC साहब बैठे हैं, राणा साहब सर हिला रहे हैं, और स्पेशल अलाउंस मिलता है प्रोफेशनल हैजर्ड के हवाले से एनेस्थेटिस्ट को, which is a good amount. So that should be given in Sindh also, otherwise we will keep on losing anesthetists. और बहुत बड़ी रकम भी नहीं है, बहुत बड़ी रकम नहीं है, लेकिन इट इज़ अ बिग इंसेंटिव। तो MCPS, FCPS एनेस्थेटिस्ट को इस वक्त अच्छी सैलरी मिलेगी तो रुकेगा। मार्केट रेट इस वक्त MCPS जैसी को कर लेता है 1.5 लाख रुपए महीने, उसको प्राइवेट सेक्टर फौरन ऑफर करता है, सरकार में ये पैसे नहीं है। FCPS जो कर लेता है रिजल्ट आने के फौरन बाद उसको 2.5 लाख की नौकरी अगले दिन से मिल जाती है, प्राइवेट सेक्टर। सरकार में ये नहीं है, लेकिन जाहिर बात है देयर आर अदर इंसेंटिव ऑल्सो। सो आई वुड रिक्वेस्ट चीफ सेक्रेटरी साहब कि हमारा बड़ा फ़ायदा है, आप डॉक्टर भी हैं, तो इसको कुछ मैचिंग किया जाए ताकि वी डोंट लूज़। क्योंकि जैसे डॉक्टर फौजी ने कहा कि वी आर लूजिंग इन मैन पावर, चले गए यहाँ से, वी आर लूजिंग इन क्वालिटी। क्वालिटी के लिए आई विल नॉट ब्लेम एनीबडी एल्स एक्सेप्ट आवर ओन कोलिग्स, एक्सेप्ट माई सेल्फ ऑल्सो, कि वी मस्ट प्रोड्यूस क्वालिटी एनेस्थेटिस्ट। I would like to be anesthetized by a qualified person. I have received 3 anesthesia so far, and all the 3 were given by my students. I had extremely good faith on my student. They gave me 3 anesthesia, and I am still alive and moving around. So we must produce that quality anesthetist who can give anesthesia to a safe anesthesia. And the paper of Dr. Fauziya was very pertinent, that an excellent survey of the province. We must do something about it. The theme of this Congress this year is safety, safety, and safety. We try to organize this sort of baseline grassroots functions every year. As you can see here, this function is 41. 2 का नुकसान हो गया कोविड की वजह से, वरना ये 43 होता या 44 होता। मजाक बात नहीं है, इतने सारे रेगुलर हर साल 40 से ऊपर 44 फंक्शन अरेंज करना। हमारे मुल्तान के साथी ने 2 हफ्ता पहले किया, उससे पहले पेशावर में होगा, लाहौर में रेगुलर होता है। तो अगेन इसकी ज़रूरत है, इसलिए कि विद दिस कांग्रेस इज़ ए ग्रास रूट कांग्रेस फॉर एजुकेशन एंड नो हाउ। इस कांग्रेस में सारे पाकिस्तान से 10, 20, 30 सीनियर आए होंगे, बाकी सब जूनियर्स हैं। इस तरह से सारे शहर में ऐसा होना चाहिए, विच वी प्रोमोट। फिर 77 कोर्स ऑर्गेनाइज हुआ, हर 6 महीने में एक कोर्स ऑर्गेनाइज हो रहा है। 77 कोर्स फॉर द एजुकेशन ऑफ एनेस्थेटिस्ट, again a compliment to the organizers of the courses and the conference. So ये सब देखने के बाद, as a patron, as a person who worked, who is here since last 47 years in Karachi, in the anesthesia practice, it is a great pleasure, something to be proud of. And I'm so happy to see our colleagues this morning. And I'm grateful to Chief Secretary Saab, who has come here and honored us. Thank you very much.
It It is very fortunate of us to have Professor Fauzia as a guest of honor today. Ma'am, I would like you to join me on stage and express your opinions with us.
Assalamu alaikum once again. Our chief guest, Dr. Rajput, patron, PSA, Dr. Tipu Sultan, dear colleagues, ladies and gentlemen. First of all, I would like to thank the organizing committee who has invited me to this 41st meeting of PSA Karachi as the guest of honor. And it is a privilege for me to address you in this capacity. Now, I have stood and spoken at this rostrum many times, but it feels a bit strange to be talking to you as the guest of honor, since it's a role I've always associated with my senior colleagues. And it makes me realize, ek English ka muhavra hai, how much water has run under the bridge. When I got this invite, I reflected a little bit on what to focus this address. And finally, I think I chose to say a few words on the role of a professional society with focus on the Pakistan Society of Anesthesiologists. What are its current objectives and what more can be done? Now, PSA was formed in 1971. This is the center, by 12 of my visionary senior colleagues, led by Dr. Habibul Haq Siddiqui, whom I think majority of the senior anesthetists present here know. So I think we have, as a center, PSA, we've completed our golden jubilee. It has, as Dr. Tipu said, it has grown immensely, the different branches as well. The society has about 9 branches now. I'm not sure how many of you have read the objectives on the website, and I will share them with you. First is to advance the science and art of anesthesia in Pakistan. Second is to enhance the professional, economic, and social status of anesthetists. And thirdly, to develop cordial relationships between members and other specialties. Now, in modern day practice, the role of professional society has expanded, and it should be reflected in our goals. So my humble suggestion is that at the next PSA Center General Body meeting, we need to add a mission statement to our objectives, and also we need to expand on these current objectives. I must admit that PSA, and especially PSA Karachi, has fulfilled and expanded in its academic role. And we have had our annual meetings, a lot of workshops, newer techniques, now Zoom lectures, several courses, and also a newsletter. And now we'll have a YouTube channel as well. It has also provided opportunities of networking with other specialties and opportunities for professional recognition by giving the Lifetime Achievement Awards. But there are key areas that fall under the purview of the professional societies that we lack. We have not been able to establish and implement standards of care and also of ethical behavior for professional and individual practice. A lot of the well-known societies like the European Society, the American Society, they also have standards of ethical behavior for individuals and for the profession. We lack liaison with the government, and this may be there may be liaison at the individual levels or personal level, but not at the level of the society. That is very important. And not any less important, we lack a strong central structure. Maybe that is the reason why we do not have a presence at the government level. I realized this when I wanted to get some information on the number of registered anesthetists in Karachi chapter. And unfortunately, we did not have a list. There is no list maintained. I don't know whether the others are doing it, but there is a list for our annual meeting for those who registered, but we do not have a list of members. We also, I think if we have a strong central structure, we can take leadership in confronting issues. And we have to make, lastly, we have to make the membership of society attractive to our colleagues, especially the younger ones. And it should provide an avenue for them to express expression to individuals far beyond which they are able to do on their own. There is a big role to play in the professional well-being of the anesthesiologists and of the members of the society. I will end here now. The PSA Society has come a long way over the years. My seniors and my generation have done our lot, and now it is for the younger colleagues to have to undertake this responsibility and take the society forward. I know that PSA is not perfect. I also know that many of us have a personal reason for joining, but remember that we are stronger personally and professionally when we work together. और जैसे कि हमारे नेशनल शायर जो हैं उन्होंने कहा है, सितारों से आगे जहां और भी हैं, अभी इश्क के इम्तिहान और भी हैं. Thank you.
Highly respected Dr. Suhail Rajput, our chief guest for the procession, Chief Secretary Sen. Sir, I would feel grateful if you can join up on stage and say a few words with us.
Bismillahirrahmanirrahim. Honorable Dr. Tipu Sultan Sahab, Dr. Fawzia Anis, Dr. Amin Khwaja, and other distinguished ladies and gentlemen, a very good morning and assalamu alaikum. First of all, it's my honor to be here speaking to you today, because I think the events like this provide a great opportunity not only for networking, but also for providing cross-learning so that we can learn from the experience of each other and get new thoughts and ideas. So I congratulate the organizers of Pakistan Society of Anesthesiologists, particularly its Karachi chapter, who have organized this event today here in Karachi. I wish them all the success and best of luck. Coming to the issues which have been highlighted here today, being on the policy side of it though, I am a medical doctor by qualification, and I did practice for a couple of years, so I have a perspective from the medical practitioner side of it as well. But since I have been in the different policy making positions for the governments for now about 30 years, so I can correlate both the perspectives and come up with what can be done in the realm of policy making for improving the healthcare and healthcare standards in general, and improving the standards of anesthesia in particular. Since I was sitting here listening to a couple of lectures, Dr. Tipu Sultan asked me whether I am getting bored because the lectures might be too technical for any layman. But since I have that medical education background, so those were very interesting for me. and I think those were very good research-based lectures which brought forward what are the key issues and what are the areas where the policymakers and the governments shall look into in order to improve the healthcare standards, because it's the right of every citizen to get quality healthcare. The Constitution of Pakistan provides such fundamental rights to the citizen of this country. And this is for the governments to provide that framework and that ecosystem in which the citizens get that kind of health care. I believe, being Chief Secretary for maybe a year now, I believe that if we look into the tertiary healthcare services in the province, government has been doing quite a decent job. If you look at the example of an ICVD and we see how it has expanded in the last 5-6 years, there have been a lot of satellite centers which have been established all over the province. So tertiary healthcare in the field of cardiology has improved a lot. Same applies to SIUT. It has expanded, it has increased its network, its services, it's now in reach of many people. You look at JPMC and particularly the radiology department through public-private partnership, a lot of investment has been made into it, and there are very few in the public sector which can match that level of service delivery or excellence. And so this is one area I believe where government has done a reasonable job, and government has also supported the facilities like Indus Hospital through its donations. So that is also one of the example where government has joined hands with the private sector to improve the tertiary health care. We also outsourced our own health services to the private sector. That experience is still in its nascent stage, and there have been some initial teething problems and issues, but I think ultimately outsourcing the government facilities to good private sector management will be the solution in the future. Initial experience have mixed results. We can improve on that, but the typical inefficiency, red tapeism which is associated with governments, it will be best to mix the government resources with the private sector agility and efficiency. So having said that and narrated about the achievement of the government of Sindh in particular in tertiary healthcare, I think the area where we are failing and failing badly is the primary healthcare or preventive side of it. And I think it's not a very wise strategy to spend too much of resources on curative side without looking into the preventive side. Because if we spend more resources on preventive side, the benefits we get are far larger than what for each rupee we spend on the curative side. So if you look into the provision of clean drinking water, particularly in the rural areas of the province, basic sanitation, sewage disposal, the maternal child health care on preventive side, I think those are the areas where we need to look into and inject more resources, train more workforce. Like if you can detect hypertension or diabetes at a very early stage with very cheap methods, I think you can take care of a lot of diseases which we need to cure in the tertiary care hospitals by spending lot many resources. So my take is that we need to look into our preventive or primary healthcare side and see how we can improve it. I think one of the presenter presented a number that maternal mortality ratio in Pakistan is still 500 per 100,000 births. This is a very high number. Even if we compare with our regional countries, I think we have not been performing well in comparison even to India or Bangladesh. Their indicators in terms of MMR or IMR, infant mortality rate, are much better as compared to Pakistan. So that is the failure on the preventive side. We look into the expanded program of immunization. There again, the vaccination rate are dismal, not very good. We are still one of the 2 countries in the world where we are still finding polio cases. We have not been able to eradicate polio altogether. So these are the areas I think where we need to focus on. Coming to this specific topic of anesthesia and the issues which have been brought forward here, I totally agree with you that the number of anesthetists, if you go out of Karachi and Hyderabad, are too low. And the number which was presented here through a research study was only, I think, 0.5 or 0.6. So that is too low a number, and definitely we need to increase it. What happens is that we select not the adequate number of people, but whatever number we select, most of them end up getting transferred to Karachi or Hyderabad. And I have seen many cases under disciplinary proceedings which have come to me that doctors have gone to Middle East or maybe Europe, and they are still on the payroll of the government. So a lot of human resource has been mismanaged. My suggestion to government has so far been that we shall go for the contractual hiring, not for the permanent hiring and having the option of transfers available. So we shall go for facility-based hiring, like if some anesthetist or some other specialist is being hired for a hospital in Sakhar or Ladkana or Mirpur Khas, it shall be specific for that facility. That shall not be transferable, and contract shall be there against KPIs. And I think we need to pay handsomely to the specialist people to retain them. So under the contractual arrangement, we can go for higher skills instead of routine BPS skills of the government. So for the specialist doctors and anesthetists, we will work on that, and I will look forward to a recommendation from PSA as well. And I will request Dr. Amin, after this 2-day event is concluded, the key deliverables or key findings or key recommendations shall also be communicated to government, so that will make the bridge between the policy makers and the needs of the specialist areas more practical. What is happening with different professional organizations, and that is not specific to PSA, that there is a communication gap between the government and these organizations. Most of the time we are working in isolation or in silos, and we are not talking to each other. So one of the deliverables for these conferences and these seminars can be to bridge that gap of communication. And I think we shall be inviting the government functionaries in greater number in these conferences, like health minister, health secretary, or other key functionaries, even the deputy secretaries. If they are sitting here, they are listening to this course, this will give them the perspective from the practitioner side that what is happening there. So that opens new vistas and new communication skills. So on concluding this, I will say that if these requirements, these demands comes to the government, we will look into it positively, because it's the responsibility of the government to ensure quality health care for the citizens. So I look forward to getting these recommendations from your end, and inshallah we will be looking at them positively and try to resolve these issues and in order to achieve better results. Thank you.
I hereby invite Patron PSA, Professor Tipu Sultan, to present shields to our guest of honor and chief guest, please.
Asma ka hai? Asma?
Dr. Fawzia, to please come up on stage and receive your shield, please. Now I request our chief guest to present certificate to President PSA, Professor Amin Khwaja. And now to kindly give certificate to General Secretary PSA, Dr. Asma Abdul Salam. Now I would invite Professor Saida Haider to kindly receive your certificate. And now I would invite Professor Fawzia to receive your certificate, please.
Thank you. Good.
I would like Dr. Safia Zafar to please come up on stage and launch the official website of Pakistan Society of Anesthesiologists.
थोड़ी सी गलती है, लॉन्च तो पहले हो चुकी है वेबसाइट हमारी, थोड़ा सा इसको अपडेट किया गया है और इसकी फेस चेंज किया है, तो ये अस्मा आ जाओ तुम भी, इसमें वेबसाइट आप देखेंगे. आई वुड लाइक टू इनवाइट ऑल ऑफ यू टू ओपन दिस वेबसाइट एंड सी व्हाट इज़ हैपनिंग एंड अस्मा विल टेल अबाउट योर टू. ओके, स्टार्ट करें.
जी, पहले उनका करवा दें. यूट्यूब नहीं, वो वेबसाइट. मैम आपका खड़ी है वीडियो इसकी
आवाज़ क्यों नहीं आ रही? आवाज़
वो लोड कर रहा है।
बता देना फौरन शुरू हो जाए। इसमें डायरेक्टली आ रहा है फ्रॉम नेट।
So when we started the online lecture series in June 2022, the need of the platform arose where all the academic activities which have been held under the banner of PSA can be reached upon later. This led to the idea of using social media and launching the YouTube channel along with the upgradation of the website, which Dr. Safia has just shown to you. With the upgradation of the website where the academic material can be found 24/7. PSA YouTube channel will include all the academic activities, whether it be lectures, workshops, webinars, sessions, or other academic videos or clips, with the purpose of sharing knowledge to all anesthesia doctors across Pakistan and worldwide. Kindly join the link via the QR code given on the flyer and like, share, and subscribe to the channel. Please join us through the 52 years journey of Pakistan, PSA Karachi. Oh, okay, now back to me. So I would request the Honorable Chief Guest, Dr. Suhail Rajput, Guest of Honor, Professor Fawzia Anis Khan, and all of my faculty from all institutes, including every senior, to please come on stage for the cake cutting ceremony. Professor Shahab, Dr. Ehsan, Dr. Jawdad, Dr. Samina, Dr. Azhar, Dr. Zahid Salud, everyone, Dr. Mujahid, Dr. Fazal Hamid, I'm just looking at the names, Dr. Wakasi, everyone please, everyone, Dr. Saadka, Dr. Dilu please, everybody please come on stage, especially the seniors, Dr. Rafia. Am I forgetting any name? Dr. Naveed Masood, Dr. Hamid, Ma'am Rehana Kamal, Dr. Gohar. Am I missing any names? Dr. Farjat, please. Ajay. Dr. Khalid Samad, if I'm not mistaken. All our seniors can please come on stage. Dr. Saida, please. Dr. Faisal Khan. Dr. Zahid. Dr. Amin Suleiman. Dr. Masroor. Sir, aap. Okay. Dr. Shahryar, General Secretary, PSA Peshawar, how can we forget? Dr. Dilip, Dr. Imtiaz, Dr. Mujahid, sir. Dr. Ashok Parchani. Anyone else? Dr. Noor, Dr. Hamid, Dr. Hamidullah, Dr. Mirza Azhar Ali. Am I forgetting any more names?
Nice.
Thank you so much. And now I would like to invite Dr. Dilu Raja for the vote of thanks. Ma'am, Dr. Rubina Ahmed is also here with us.
Good morning, everyone. Please take a seat. Please take a seat, please. Have your attention, please. Good morning, everyone. It is great honor and privilege to propose vote of thanks on this auspicious occasion. First and foremost, I thank you, special guest, Chief Secretary of Sindh, Dr. Mohammad Suhail Rajput, who despite his busy schedule has found some time to grace this occasion. Thank you very much. It is great honor and privilege to propose vote of thanks on this auspicious occasion. First and foremost, I thank our special guest, Chief Secretary Sindh, Dr. Mohammad Suhail Rajput, who despite his busy schedule has found some time to grace this occasion. I also express my heartfelt thanks to our respectable teacher, ex-chairperson, Department of Anesthesiology, Aga Khan University, a very good researcher, Chairman Quality Assurance Committee, World Federation of Societies of Anesthesiologists, Professor Fozia Anis Khan. I am also thankful to our most valued invited guests, speakers, ladies and gentlemen, who came all the way to grace this memorable event. ठीक है यार इसको बंद कर दो The very presence of you, honorable chief guest, and respected guests of honor today in the program is really honor for all of us. I am also thankful to our patron PSA, Professor Tipu Sultan, patron PSA Karachi, Professor Saida Haider, President PSA Karachi, and Chairman Organizing Committee, Professor Amin Khwaja, General Secretary PSA Karachi, Dr. Asma Abdul Salam, Chairman Scientific Committee, Professor Zayed Akhtar Rao, Professor Safia Zafar, Dr. Mohamed Hamid, Chairman Inaugural Committee, Dr. Shabir Jumani, Dr. Hamid Ali, Chairman Printing and Publication Committee, Dr. Shoaib and Dr. Vinod Kumar. Dr. Duriya, Chairman Entertainment Committee, Professor Samina Ismail, Dr. Mukesh Kumar, Registration Committee, Dr. Amin Manwar, Dr. Musaddiq Jafri, Dr. Tariq Aziz, and Chairman Paramedical Committee, Dr. Asia Aman, Dr. Samuel Nawab, Chairman Audio Visual Committee, Dr. Farjaz Sultan, Dr. Nasir, Chairman Scientific Exhibition Committee, Professor Nurul Haq, Professor Nigat Abbas, Pre-Conference Workshop, Dr. Ali Sarfaraz Siddiqui, members of all Organizing Committee, Advisory Committee, all office bearer of PSA, our teachers, workers, for their endless efforts to make this event successful. In the last but not the least, I thankful to sponsors of event, all pharmaceutical companies, for their unconditional support. I also thank all media for coverage of this event. I, on behalf of Pakistan Society of Anesthesiologists Karachi and entire anesthesiologist committee here together in my own behalf, extend a very hearty vote of thanks to all for gracing the occasion. Once again, I thank you all for your attention. Thank you.
I request all the guests to head to Damport for tea arrangements, please.
Dr. Fazal has been frequent speaker at national and international conferences. He has over 40 peer-reviewed publications and a few book chapters in the Anesthesia lecture series. Dr. Fazal Hamid Khan, kindly. Our second chair for the session is Professor Rana Altaf Hamid. He is the Executive Director, Multan Institute of Cardiology, and pioneer in starting cardiac anesthesia in South Punjab in 2007. He is the first supervisor in public sector hospital of Punjab in cardiothoracic anesthesia, President of Pakistan Association of Cardiothoracic Anesthesia, member of faculty of CPSP. He has been 28 research papers in international and national journals and has been awarded appreciation awards from Chief Minister and Governor of Punjab. Professor Rana Altaf, kindly come. Mike.
Bismillahirrahmanirrahim. So, in this session, we are going to talk about anesthesia international standards and where do we stand. Our first speaker is Professor Dr. Gaurav Shah, and it is my pleasant duty to introduce her. Dr. Gaurav Shah is an endowed professor of anesthesia, head of pain medicine department of anesthesiology at Aga Khan University. She established the first pain setup at AKU. She is a member Pain Management Committee, WFSA, Cancer Pain Curriculum Committee, Cancer Pain Guideline Committee, WHO, and Secretary Faculty of Anesthesia, College of Physician Surgeons, Pakistan. She is the recipient of many national and international grants and author of more than 120 peer-reviewed publications. Dr. Gaurav Shah.
Assalamu alaikum, and thank you very much, PSA. Thank you very much, Dr. Fazal, for a kind introduction. So the topic given to me was documentation of anesthesia care, what to document, and certainly this is according to the theme of this year conference. So I don't have any conflict to declare as far as this topic is concerned. So what I plan in the next 15-20 minutes that very briefly I will talk about the medical negligence in Pakistan and anesthesia discipline in newspapers or in the various news. History of anesthesia documentation. Then what we actually understand by the documentation of anesthesia case, any definition exists for documentation of anesthesia. Then what is the standard of anesthesia documentation, what we have to document as a standard report or record, and what is the deficient documentation. And certainly I would like to conclude. So medical negligence in Pakistan, the understanding of medical negligence as a concept is rather hazy in our society. We don't know about our rights, what is our rights as a patient. We don't know about a expected relationship of physician and doctor relationship with the patient, and we are very difficult to understand what actually the medical negligence is. Unfortunately, a number of cases have been registered against anesthesiologists in which either an untrained medical practitioner administered anesthesia or trained practitioner did medical error or any medical mistakes, any error of judgment, or when deficient documentation did not give a clarification for the position of anesthesiologist. And this is very, very tragic in the last 1 decade. So if you find a Google, what are the different, problems or cases against anesthesiologists, we have a lot nowadays. But because, in our country, the Punjab healthcare or Sindh healthcare, so there are some of the, ethical concerns of keeping confidentiality, so we cannot, discuss the cases here. However, I would just share one or two very important cases that actually comes in a newspaper. And why I choose this one, the child dies from anesthesia overdose during surgery. So this is from, I choose it because it was on a front page of the paper. All the other, such kind of cases where FIR was lodged against anesthesiologists are in the, akhbar, darmiyan ke akhbar, or the back of the papers, but not on the front page. But this case was reported in the Tribune as a child dies from anesthesia overdose during surgery, and FIR was lodged against that unfortunate anesthesiologist who could not defend the case because of the poor documentation. When we say about the poor documentation, deficient documentation, because we know that during investigation, one of the most important, your support is what you document. So no matter how good you are in your clinical skills or how good you are as a physician or practitioner, until unless it is documented, nobody can say that. So if you just see how this documentation of anesthesia started in this discipline of anesthesia. So history goes back to 1894, when the two surgeons, and they were both are the surgeons, the Cushing and Codman, 1894, they insisted the person who is giving ether anesthesia to document what is happening. And they actually insisted for the vital signs. And later on, then other surgeons, again the surgeons keep asking the anesthetist, the person who is giving anesthesia, to give, to write down what is happening during this surgical procedure. So this is the first, anesthesia documentation, which I found it from a very nice book of history of anesthesia, and this is from November 30, 1894. So on November 30, 1894, you can see this is a two-side documentation. On side number 1, the documentation is about the operation card and the recovery room card. So even at that time, even these sensible people, they have an understanding that recovery is something which need to be documented. And on the other page is that the vitals and the rectal temperature. So rectal temperature, vital means that they were actually counting the pulse rate. And rectal temperature, they also started. This is the first anesthesia documentation in 1894. Then there's an American book, which is the history of surgical anesthesia. And this American book, the history of surgical anesthesia, this is the first book who actually gave a full description of development of anesthesia record keeping. Before that, we did not find any reliable book that mentioned how the anesthesia record keeping should be done and what is the importance of anesthesia record keeping. So this is happening everything in America, the documentation. 1894, the first case in America. Then this American author, they write a case, again this in America. What was happening in the British at that time? So if you find the history that there were 4 books written about the anesthesia, but unfortunately all these 4 books, they did not mention about the importance of anesthesia documentation. So that was a change between Americans' approach since the beginning, that why the accommodation is so important, documentation. At that time, Europe was not doing any kind of documentation. Later on, this is not moving. This is not moving, right? Later on, the 2 important histories of anesthesia again comes in this area. And they actually, they just mention about the record keeping of anesthesia then across the world. Suddenly 1924 ke baad, so all of a sudden there was a huge, change in the trends about anesthesia documentation, that people start documenting what they were giving. So what was happening in Pakistan? It's very difficult to take history from or getting evidence from in Pakistan. However, the last year I was fortunate to write a history of anesthesia in Pakistan, and I dig this thing, the way in Pakistan this actually started. So in Pakistan there was no evidence of anesthesia record keeping or documentation in early 1950s. However, the importance of observing and recording the variation in heart rate, blood pressure and respiratory rate was realized, and anesthesia documentation began in late 1950s. Dr. Tina is not here. She promised me that her father has a 1958 record that was, according to Dr. Tina, was the first one, and it is available in the library of her library, and she would certainly find out one day, and she said she's promised me that she will give you. I wanted to share that first documentation in Pakistan, but certainly because of the time frame, I could not. So this is one of the important anesthesia documentation. According to the history, this was in 1943, where again the two sides of anesthesia documentation was happening. So what is actually the anesthesia documentation or anesthesia record? Because if you find in literature, some people use a word of anesthesia record and some is anesthesia documentation. So anesthesia documentation is a clinical, because you know this is a clinical care document. It is a clinical, scientific, because this paper or this documentation can be used for healthcare research or digital healthcare for making guidelines. So this is, you can use it for scientific way when you are presenting morbidity and mortality meetings, what was happened during that, or critical incidence meetings. So this is important document. Then this is a legal concern about this document. And the administrative document, because it captures the patient's response to anesthesia and surgery by recording the physiological. This is very important, that this is the only discipline where a very comprehensive physiological and pharmacological data collection is performed during the patient care. No other discipline you can find such a detailed pharmacological and the physiological data collection. In other part of the world, and in some here also in Pakistan, it is also used for reimbursement, duration of surgery, what is duration of surgery, then quality improvement audits. Institutions which are JCIA accredited, they need this kind of a documentation, the perfect documentation in terms of anesthesia, the pre and post and intraoperatively. So who is responsible for this documenting anesthesia care? We all know that the anesthesia care is a continuum, including 3 general phases: pre-anesthesia care, intraoperative anesthesia care, and the post-anesthesia care. An accurate and thorough documentation of anesthesia care in all 3 phases is an integral part of the patient's journey in hospital and considered a basic responsibility of anesthesiologist. So we as anesthesiologists, we are responsible for documenting anesthesia care during a patient's journey in the hospital for any kind of surgery. So what is the current practice of anesthesia documentation? So currently, majority is sitting here or practicing anesthesia. We know if we ask anyone of what is ASA, this patient ASA status kya hai, so everyone knows ASA 1 hai, 3 hai, 4 hai, this, and some of the common understanding from American Society of Anesthesiologists actually is really prevalent for everybody practicing anesthesia across the world. So again, I wanted to see what the ASA says about this documentation. Although the other societies like Canadian societies and Australian society, they also have given a good guidelines or standard for documentation. Remember that the lack of clear and adequate documentation can potentially affect the quality and safety of the patient. Sometimes we think, we see that this documentation has a medico-legal impact, but actually beyond this medico-legal impact, because the frequency is not as much, but the patient and safety is everyday issue. So the information which we find from the previous anesthesia record, कोई allergy हुई थी, antibiotics का मसला हुआ था, difficult intubation थी, difficult airway mask था. So we can always find from the good record keeping. Otherwise, certainly we may end up with some kind of unused information. So what is the statement of document of anesthesia care? This is just like American Society ki jo grading hai, ASA1, ASA2. This is simple, very simple document, 1.5-page document, the what to document, how to document, what to document. We all know the anesthesiologist is responsible. So the documentation needed, again, we are doing, majority are doing it. Pre-anesthesia record completed by anesthesiologist. And for the legal document, this is very important that you do pre-op, but you have to sign. If you don't sign that pre-op assessment, the document की legal importance कम होती नहीं रही है. Intraoperative document anesthesia completed by anesthesiologist, similarly the post-anesthesia. So what is the meaningful documentation? Maybe people are documenting, but meaningful documentation means that the document has to be legible. Writer के अलावा दूसरा पढ़ सके, so it is legible. It has to be accurate and factual. And again, when we talk about accurate and factual, this means you have to be very vigilant, and that's why the vigilant, anesthesiologist is the best anesthesiologist in OR. then it has to be complete, starting from pre-anesthesia until you hand over the patient to post-anesthesia care, and timely. Now, in timely, there are, we all agree that it has to be timely documented, but however, there are certain issues come up in the literature about the timely documentation. And then again, there are certain consensus guidelines made about what we do if you are stuck in emergency in operation theater, is rapidly developing critical event. So certainly you would be busy in managing that particular patient. So anesthesiologists may be in the conflict between a primary obligation of managing care, which is certainly if there's certain emergency ho gaya, allergic reaction ho gaya, bradycardia ho gaya, and it may, this event may prolong for 15 minutes, 20 minutes, maybe 5 minutes. So what should we do? So in emergency cases, certainly the priority is to focus on the clinical care. However, as soon as you are over from that clinical care problem, then certainly you have to document. And this, even in the code, because I was reading one very interesting article, again from majority, some of the article comes from America. So they said that if this kind of situation arises, then the deficient documentation at the time of crisis actually give a benefit of doubt to the person who is actually giving or managing the patient or crisis. So as compared to a pure elective cases where the person is there monitoring, and there are some missing document or missing information or missing entries. So this is very important to understand. Here is a very interesting book because majority are...
5 more minutes.
So, so there was a very interesting book, this medical record of attorneys. And this book actually gave for all medical practitioners, the people who are practicing in pediatrics or in surgery or in ER, similarly they have a good 2 chapters about anesthesiologists. And what I like, so I quote unquote, in the chapter of operating room, what this attorney wrote, if there is a crisis in the operating room, one can generally say that the anesthetist is responsible. As a matter of general protocol, in such cases, the quality of anesthesia record will likely be the most critical documentary evidence in the case. So anything happens in the, even if something happens at the surgical side, then accidentally inferior vena cut gayi, kuch bhi ho gaya. So because surgeon is scrubbed, they're busy, so the person, the expectation from the medical legal record that what is the chart, what is the documentation from anesthesia side as far as all these critical incidents that was happening at that particular time. So this is, I just quote unquote, so you can understand that in the medical, in the legal background, this is a very important, that operating room chart is at most important document. Remember, if it was not documented, it was not done. No matter how explanation you gave it to you, I was personally there, I personally give this medication, I did this intubation, no. If it is not written, then it is considered not done. So about deficient documentation. So deficient documentation, because since you have been hearing even in the morning session, is not a problem of lower and middle income countries. Even in the high income countries, this deficient documentation is mentioned. However, and you know that there are so many international guidelines. So the inadequate documentation has been shown, although in all cases, but 2 cases may even in the other part of the world also document is emergency cases. And recently the deficient documentation found during the regular audits if the patient get a regional anesthesia. So the regional anesthesia, only regional anesthesia, you find a lot of deficient diagnosis because ab bahut dafa nahi likhte, ultrasound ki kya aapki settings thi, aapka size of probe kya tha, what was, initial dose kya di gayi thi, कितने इस पे मिल गई थी, क्या करंट दिया था, अगर आपने साथ में स्टिमुलेशन भी इस्तेमाल किया. So this is the 2 areas, emergency C-section. The most problem area is emergency OB area, जहाँ deficient documentation होती है. So there is unfortunately, this is the area deficient documentation where I really find hard and different, whatever my capability literature search, different keywords, everything, but there are very, very few papers. And then I realized why this deficient documentation people are not studying. And then later I found that some of the area, like for example in America or in some of the European countries, they have now a regular audit system. So that's why these kind of a quality audit is not coming as a research papers, they are actually a routine plan. But in Pakistan, there's a problem. So what is the standard documentation in our part? So pre-anesthesia care, we all know that, discussing the patient's medical history, examining patient physical, order any test, ordering NPO, we all know that, we are doing it. Intraoperatively, we all know that we have to standard, you have to find the physical presence of qualified anesthesiologist, so you have to sign. Without sign, you cannot verify that you were there. And then fourth system, oxygenation, ventilation, temperature. And this is all we do normally, anesthesia technique, airway management, and you are doing everything, I know. But don't miss anything, whatever you are doing it in timely manner. Post-op care, again, post-op care, until unless you hand over the patient to the PACO, you are responsible. Later on, then the nurses are responsible for regular monitoring. So manual and EMR is certainly in many countries now, EMR is also there, automatic documentation, which is in some part of the Pakistan is coming up soon. So common anesthesia documentation error, normally क्या गलतियाँ लोग करते हैं, एक तो signature नहीं करते, which is simple thing, you have to sign whatever you are doing it, ठीक है? Then again the lack of clarity, जो surgical part में होता है, कब surgery शुरू हुई, कब surgery खत्म हुई, and then certainly we are focusing on our own physiological parameters and the pharmacological interventions. So here I would just like to conclude that anesthesia documentation is the main record of pre, intra, and post-op course of anesthesia administration. It must be clear, accurate, legible, precise, and timely. A sloppily anesthesia documentation indicates a careless anesthesia providers, even if that is not true in reality. Every anesthesiologist must have some knowledge of law and ethics in order to protect himself or herself from avoidable litigation and disciplinary matters. Remember, documentation compliance is more than just an expectation, it is a necessity. It is a necessity. The anesthesia record documentation is your legacy, and the record of what happened many years even after that, the occurrence of that incident, your legacy is there. So it can be your best ally or it can be your worst enemy. Now you have to decide what you want to adopt. And I am again repeating, if it was not documented, it was not done. So please start documenting everything which you are doing. Thank you very much.
Thank you, Dr. Gaurav Shah, for this very important talk. Question and answers will be at the end. Now I am requesting Dr. Arshad Taki from Cole Associates, the consultant anesthetist and the critical care expert, with a special interest in anesthesia and thoracic and critical care. He is the former president of Pakistan Medical Commission, and he is the pioneer in establishing the Critical Care Society and Critical Care Fellowship in Pakistan. Dr. Arshad Taki will join us on the Zoom link. I request Dr. Arshad Taki to come on the link if he is there.
I hope you can hear me. क्या आपको मेरी आवाज़ आ रही है?
जी डॉक्टर अरशद, आपकी आवाज़ आ रही है, जूम कनेक्टेड है, बस ये जो आपकी स्क्रीन शेयर हो रही है, दे आर जस्ट डूइंग इट ऑन द अदर HDMI कनेक्शन हो रहा है.
जी.
Yes.
So I hope you can see my screen as well.
जी सर, आप.
I apologize for not being there in person. It was just that I had this recurrence of flu-like symptoms. And since it was the second time in 3 weeks, so I thought, why not test myself? And lo and behold, I tested positive for COVID. I'm all right otherwise, and I feel guilty because sitting home and not doing any work when you're feeling all right is some kind of an experience that you're not really used to. But I think we need to get used to sitting home and not doing some work. I find that refreshing really and exhilarating at times. So if the screen sharing is on there, I may start now. So I've been asked to talk about unsafe practices in anesthesia and how to avoid them. Now, that's a very extensive topic, patient safety and unsafe practices. And I'm sure First of all credit to PSA Karachi. Like always, they've been leaders in bringing up issues, highlighting issues which are of importance, and then giving me the opportunity to talk about it. I know that Professor Fawzia Khan has talked about it. Dr. Gohar has talked about documentation part. There will be talks about drug safety. So I'm not going into those very basics that they must have talked about, and you will keep on listening to. My idea is to just highlight one dimension of patient safety and how to deal with the situation. And I'll focus on that.
Sorry, Dr. Arshad. Sorry, आपकी screen duplicate हो रही है. Kindly screen play कर दीजिएगा.
जी, मैं ऐसा करता हूँ. Let me see. Is that okay now? Is that okay now?
Sir, it's clear, but बाकी की चीजें भी साथ में आ रही हैं. आप बता दो.
Okay, so इसलिए अब ठीक हो गया या भी ऐसा ही?
सर टॉप लेफ्ट पे शॉप डिस्प्ले लिखा होगा, उस पर क्लिक कर दें.
जी, मैं आई थिंक आई जस्ट. अब कुछ ठीक हुआ या नहीं हुआ? जस्ट गिव मी अ सेकंड.
अरशद अब सही हो गया. अब सही हो गया अरशद.
जी,
अब सही हो गया ना. Now you're okay.
Right, thank you. So this is a case. This is a typical case, and this is not a true case, but this is a typical case, and I'm sure it may be kind of a little alien to few of you who are working in those institutions, centers of excellence. But this is, I have kind of collected this based on my experience of having looked at the complaints as the regulator and other case reports that have come across dealing with various cases. And this is a 50-year-old woman on list for repair of her large incisional hernia. And she certainly lands in the pre-op 15 minutes before scheduled time for surgery. She's shifted from the ward, was admitted in the afternoon a day earlier. The anesthetist who is supposed to deal with her has a look at her and discovers that the call for preoperative assessment that was sent a day earlier, I don't know at what time, was not attended. She gives a history of long-standing hypertension, diabetes, paretic control, one episode of chest pain 2 years back, resulting in angiography and a stent in LAD, following with dual antiplatelet therapy, which was withheld. Largely symptom-free, but three METs level of physical activity, kind of a typical housewife, middle class in coming to our hospitals. The lady in a 58-year-old, not one of the professional ladies who are vibrant and very active. So then it may lead to three scenarios, and I'm kind of sharing all three possible scenarios. First, under pressure to proceed, the anesthetist took her to OT for induction. After a quick review, planned to use invasive blood pressure monitoring. The plan was dropped because there was no transducer available in the OR. Maybe not very sound strange to a few of you, but then this is something that you may encounter in most of the ORs in the country. Surgery lasted 2 hours. Estimated blood loss was about 200 ml. Received about 2 liters saline. She was shifted to PACU. End of the procedure, stepped down after 12 hours to the ward and then discharged. I'm sure in most of the hospitals in our country, this case would not come under the radar. This would just pass under the radar. Nobody would even bother to think about it. Then there's the other scenario. Once again, the same. Does a quick review, plans what was planned, starts the same. This time the surgery lasts 4 hours, blood loss is a little more, and at some point she becomes hypotensive, blood pressure drops to less than 55 millimeters, stays there for about 15 minutes, starts a norepinephrine infusion, at one point even drops to the level NIBP is not recording. So end of surgery, they struggle through the anesthetics. At the end of surgery, she shifts to ICU where she remains on vasopressors and with a low output, urine output for some time, and then gradually picks up and is shifted home after 48 hours. And the third scenario, once again, the same lady. This time the surgery lasts almost 4 hours. The blood loss is about 900 ml. She received 6 liters of ringers. Norepi started, once again hypotensive. But this time she was shifted to ICU. And this time she was not good for extubation, had an AKI, an MI, and a stormy coast. 7 days later died. This is the one patient who is going to come under the radar. So what is going to happen? What's likely to happen? I thought this would be more interactive when I was standing there, but unfortunately I'll have to go on and do it myself. The traditional approach towards this would be, whose fault is it? Fix the blame, punish the culprit. In all likelihood, the person who would be punished is going to be the frontline worker. And that is what I'm going to talk about. The frontline workers are the ones who are actually the ones who have to deal with these situations where there is pressure to proceed, the production pressure, and they are the ones who are to be blamed when, and agreed that they are the ones who that's the point where omissions are noticed, that's where the points where errors are made, and that's where the point where the harm is noticed. However, as more recent work, not very recent work, has shown that the fault, the actual harm to the patient occurs not only because of those errors or patients at the time of that point of care, but there are those latent factors which are contributing to it. And that's where the systems approach comes into play. Shortly, I was asked to say, what are the unsafe practices in anesthesia? There will be a long battery of long lists. I'll just summarize that, say that they can be summarized into 3 categories. Failure to conduct a proper preoperative assessment and formulate a safe anesthetic plan. This includes optimizing the patient for surgery. This includes identifying the risk and identifying the magnitude of the risk and counseling the family and the patient about the risk and getting an informed consent. And this includes formulating a safe anesthetic plan, which means, and any deviation from that plan is then considered a critical incident. And at this point, I just want to highlight, it's not the subject of my today's talk, is when we are formulating that plan, we should not forget the anesthesia provider's safety, and that anesthesia provider's safety is an all topic about it in itself. When we talk about safety, we only consider patient safety. We are actually forgetting the safety of the provider. The second unsafe practice is a failure to execute the intended plan. For whatever reasons, we have a plan, but at the time of execution, for whatever logistic reasons, we tend to cut corners. We anticipate that there was a difficult airway. However, at the time, we failed to marshal the resources required to deal with the difficult airway, and at the last moment, we decided to cut corners. The expert, the person who was supposed to be the expert was not around. Any one of the devices was not available, and we decided to proceed with that. We did not execute the intended anesthetic plan. The third is failure to respond to emerging situations. So these are the 3 broad categories of anesthetic practice, and you can actually fit in almost everything that is unsafe practice into these 3 categories. And I'm not going to go into the details because just highlighting that when you talk about safety in anesthesia, we understand that safety means avoidance, prevention, amelioration of adverse outcomes or injuries stemming from the process of healthcare. Now, there are injuries that cannot be avoided. There are adverse events that cannot be avoided. Healthcare is a risky business, and as we deal with sicker and patients and more complex procedures, we are going to have adverse events. We are going to have adverse outcomes. However, when we talk about safety, we are talking about avoidable adverse outcomes. How to measure them? We are measuring them through our anesthesia-related mortality records. Once again, these anesthesia-related mortality, we understand that anesthesia-related mortality has fallen significantly. As established more recently, the safety record has reached that very safe level for ASA 1 and 2 patients undergoing simple procedures. However, for ASA 3 and 4 patients undergoing complex procedures, the level of safety is, as they say, to the 10 to the raised to the power of -5, which falls into kind of more risky procedures. So we still are like, however, anesthesia, generally speaking, would be a safe specialty as far as mortality data is concerned. When it comes to morbidity, we have not been able to actually reduce the anesthesia-related morbidity significantly. We still have anesthesia-related adverse events or anesthesia-related adverse outcomes reported from all over the world. The third way of monitoring this is critical incidents. And one important thing we must realize is that when we talk about anesthesia-related mortality, we are looking at the data that we look at is immediate mortality or mortality during 30 years. Now, looking at more recent data, which shows that even a brief period of hypotension, a mean arterial pressure of less than 60, it can lead to acute kidney injury later on, which means that may impact long-term mortality. So anesthesia can contribute to long-term mortality as well. So now we need to look at anesthesia-related adverse outcomes in a different light, as in their impact on long-term mortality as well. Coming back to why safety initiatives do not work, because we still understand that unsafe practices persist, and that happens more so in this part of the world, in our low and middle income countries. And that's what I thought we would talk about, because it always is the frontline worker which is blamed. But essentially what we find is that it is only the unsafe systems, healthcare systems, which breed unsafe healthcare workers. A safe healthcare system would actually identify unsafe worker and do something about that person. So we have three categories of concepts which explain why unsafe systems persist. The first, what they call, was explained by reason, which is a vulnerable system syndrome. The second is the migration of boundaries, and the third is first order problem solving. And if we go and look at this, vulnerable system of reason has identified vulnerable systems which blame the frontline workers, deny that there is the systemic errors or weakness in the system exist. And the third most important thing is that they actually pursue productivity and financial indicators. So they look at success in terms of number of cases done, the amount of revenue generated, the number of surgeries successfully concluded. Now, we all understand that, as I showed in the first scenario, the third outcome is relatively rare. Most of the times, you're getting away with scenario 1 and occasionally scenario 2. Scenario 3 is relatively rare. So that they generally, when it happens, they tend to blame the frontline worker and fail to, and this circle here, the blame circle, shows that they will choose an erroneous course of action, which means they will accept people cutting corners, and they will actually encourage people who manage things, and I'll come to that later, deliberate actions, and then they consider that as deliberate actions, deserve sanctions, they punish those making errors, which does not change the impact, the outcomes, because those errors, they are latent errors within the systems which are not letting things go correct. And for frontline worker actually is forced to do it, to react in a certain way, in a certain circumstance. And anytime that human error adds to that Swiss cheese model, you get an adverse outcome. So management, what the management does is they view this as a deliberate disregard for warning. So इसने जी बावजूद हमारे कहने के इसने गलत काम किया था, इसको और सजा दो. So this cycle persists और चीजें ठीक नहीं होती. The second concept is migration of boundaries. So the individuals, and that happens with surgeons, with due respect, more than anesthesiologists, but still we in our aim to not compromise our relationships with the surgeons, and in our to maintain our positions within the organizations, we also, with due respect, do become accomplice, because we cannot afford to go on fighting each day. So it's the system which breeds the individuals who are functioning outside of established zone of safe practice. Why? Because system needs increased performance. They like people who deliver more. And the individuals cooperate because they are looking for personal benefits in that system. The third is first order problem solving, and we find that in our organizations all the time. And that is the kind of the people who find readily available or first order solutions to the problem. So एक काम आया है, there is a problem there, थोड़ा सा जुगाड़ लगाओ, काम कर लो, और इस वक्त मसला हल हो जाएगा. The second order problem solver would seek and look at the underlying cause, try to correct the system, which doesn't really suit the organization, on an organization which really is not sold on safety. So that's where the first order problem solvers get encouraged. They thrive in these kind of organizations. So the root cause actually is when it comes to a balance between productivity and safety in these kind of organizations, and that includes our both private and public sector organizations, because the secretary health of the department in the province is only going to ask you or hold you accountable for the number of cases you've done. They will only hold an inquiry or ask you to look into things when an adverse event happens that makes public news. Private sector, of course, survives on productivity. For them, that is the goal. And the individuals and the healthcare establishments, they both succumb to that production pressure. So who will champion the cause of safety? All credit to PSA Karachi for bringing this up. It is the job of the professional societies to set the standards. So they set the standard and they go into an advocacy mode. The societies will have to go talk to all the people, talk to all the stakeholders, and that is going to be an ongoing effort. It's not going to happen yesterday. It will take a long time. You need to start somewhere, raise awareness, highlight those cases, and also, please, we need to inform people that even when we are managing to get away with no problem, we still have problems in the system which those latent problems which can actually manifest any times. Once we have, and who are we going to target? Of course, the healthcare establishments, because they are our practice regulators as well. But by the regulators, you mean the healthcare commissions, the licensing regulator, which was PMDC or PMC. So that's whose job it is to implement those standards. And also, it is the job of the healthcare regulators, like the provincial healthcare authorities, to rank the healthcare establishments according to the degree of safety that they provide to their patients. So safety or incorporation of safe systems we should advocate should become a part of the ranking of the healthcare establishments. So in the end, I'll just refer to this Institute of Health Improvement and Safe, Reliable Healthcare, kind of circle of safety. And what you find is that it's all about culture. What they're advocating is it's all about culture. Because bringing in change is one thing. Making that change persist and making that change persist to the extent that it becomes a part of institutional culture requires an ongoing effort. I'll cite this with an example from our own department's safety initiative, which was on drug safety. So we initiated a drug safety regime back in 2011. And we started off with 5 steps protocol for handling drugs. We developed all those drug labelings, all those standardized infusion software, and we made confirmation of following those 4 steps as an integral part of our anesthetic chart, which every consultant had to verify, resident had to fill, and the consultant had to verify that all 5 steps of the protocol were followed at the end of the procedure. Interesting, and it was working very well till the time I realized that in one of the hospitals, what they had done was the first step of that drug labeling, that protocol, was that all the drugs will come in boxes because the ampules are lookalike, so they'll come in boxes. And the drug will be drawn out of that box, which has got a distinct label on it. And what the pharmacy did was, due to their own logistic expediency, they started sending the boxes, that set of drugs in a tray, which means they were not coming in the boxes. And what I realized on day 2 was that although the drugs were no longer coming in boxes, the step 1 of the drug protocol was still being ticked, which means once you get into that habit of checklist, sometimes they become a habit, and then you are going and ticking those check boxes as habits. So that's where it becomes important to make sure that this becomes a part of culture, and the culture remains, the culture of safety remains, and that is going to require ongoing advocacy. That was my message. Thank you very much for allowing me this opportunity.
Thank you, Dr. Arshitaki. Now I request Dr. Muhammad Hamid from Aga University Hospital, Associate Professor, Section Head Cardiothoracic Anesthesia, and he published more than 70 publications in peer-reviewed journals. Main clinical interest in pediatric congenital heart anomalies.
Assalamu alaikum. Yeah. Is it coming? Thank you, PSA, for giving me this opportunity. So the topic is provision of post-anesthesia care unit and where do we stand. So initially I will discuss about the international standards of post-anesthesia care unit, and a little bit about the requirement by Sindh Healthcare Commission, and then where do we stand, and at the end I will give you some recommendations as well. So there are 5 standards of post-anesthesia care unit. These are the standards set up by ASA House of Delegates in 2004 and later on amended in 2019. So all these standards basically involve anesthetist at several stages. So the first standard is that all patients who receive general anesthesia, regional anesthesia or monitored anesthesia care shall be receiving appropriate post-anesthesia care management. And this must be done in a post-anesthesia care unit or area which has equivalent post-anesthesia care. All patients who receive anesthesia care shall be admitted in the PACU or its equivalent except by specific order of the anesthesiologist. And the medical aspect of care in the PACU shall be governed by the policies and procedures which have been reviewed and approved by the Department of Anesthesia. So the Department of Anesthesia is involved in making policies. Standard 2 is that all patients must be transferred by the anesthesiologist from the OR to the PACU, and the third standard is that upon arrival in the PACU, the patient shall be re-evaluated and a verbal report provided to the responsible PACU nurse by the member of anesthesia care team. So all these three standards, they require anesthetists to be involved in all this. But the most important, I think, over here is the member of anesthesia care team shall remain in the PACU until the nurse accepts the responsibility for the nursing care of the patient. If the nurse is not qualified and you are not comfortable with transferring the patient to such facility, then you should stay in the PACU and manage this patient. Fourth standard, the patient's conditions shall be evaluated continually in the post-anesthesia care unit: oxygenation, ventilation, circulation, level of consciousness, temperature. All these should be monitored and also documented in a chart. The written report of PACU shall be maintained. Supervision and coordination of the patient care in the PACU should be the responsibility of an anesthesiologist. Fifth standard, a physician is responsible for the discharge of patient from the post-anesthesia care unit. So there has to be some certain discharge criteria which anesthetist has to follow, and he can delegate this responsibility to the nurse as well. But anesthetist's name should be there at the end when transferring the patient from the PACU. So basically, I will talk about phase 1 care. Phase 1 care of the recovery is where patient transferred from the OR to the recovery room, and establishing full recovery from anesthesia and return of vitals to the baseline. And then after that, patient is sent to the surgical ward. Phase 2 care is basically when you are preparing the patient for transfer to the home. So other requirements for post-anesthesia care unit, that units must be located close to the OR so that in case of emergency, patient can be transferred back to the OR. And the exit must be outside the OR. The area for each patient should be around 12 to 13.5 meters square. 12 meters square is actually equal to a car parking space. Itna bada hona chahiye area. And bed to OR ratio in the post-anesthesia care unit should be 1.5 to 2:1. 1.5:1 by ASA, and 2:1 is the recommendation by AAGBI. Working hours can be 24 hours if there is an emergency coverage. Otherwise, it can be done during the daytime. Staffing, anesthetists must be immediately available in case of emergency. About staffing, there must be at least 2 nursing staff present for one patient in the PACU all the time. And there has to be 1:1 observation of every patient. And usually, suggestion is that for initial 15 minutes, there has to be 1:1 observation. After that, coverage can be 1:2 or 1:3. Anesthetist who is supernumerary to the requirement in the operating theatre must be immediately available. And the last condition about the staffing is that at all times, at least one member of the staff present should be a certified acute life support provider. And for children, hold an appropriate pediatric life support qualification. This is a tough one for us. Other requirement: electrical sockets, oxygen and air pipeline outlets, vacuums, adjustable examination light, push button, all these should be available along with the physiological monitors like pulse oximeter, non-invasive blood pressure monitoring, ECG, and in case of intubated patient, you need a capnograph as well. For intubated patient, actually, you need a bigger area for such kind of patients. And there should be immediate availability of crash cart and defibrillator. All drugs, equipment, fluid, and algorithms required for resuscitation and management should be available. So this is a statement which I like from the Association of Anesthesia of Great Britain and Ireland. Before transfer, the anesthetist should be satisfied that the PACU staff are competent and able to take responsibility for the patient. If this cannot be assured, the anesthetist should stay with the patient, either in the operating theatre or the post-anesthesia care unit until the patient is fit to return to the ward. So it's the responsibility of anesthetist to take care of post-operative period as well. It's not only pre-op, intra-op, but also post-op period. And ultimately, patient has to be discharged. There has to be a discharge criteria. So where do we stand after looking at all these international guidelines? There are certain recommendations by Sindh Healthcare Commission about post-anesthesia care unit. There has to be a separate, fully functioning, equipped recovery room for secondary and tertiary care hospitals. A trained recovery nurse is present for each anesthesia session. Sufficient qualified and experienced staff monitor the patient in the recovery room. Documentation has to be done. Documented discharge criteria must be used. Anesthetists available in the hospital until the patient has recovered from anesthesia, and anesthetists provide the final authorization of the patient to leave the recovery area. About equipment and facilities, recovery area is well lit and adjacent to the operating theatre. Resuscitation equipments and drugs should be available, and all these equipment should be available in the recovery room, including defibrillator. So these are the recommendations from Sindh Health Public Commission. And where do we stand? We don't know actually. There is no article I could find about recovery room status in Sindh or Punjab or anywhere else. And we don't know actually how many post-anesthesia care units are available in a province, how many equipment and medications are available. So this is the only article I found which is actually done by German researchers. It is about anesthesia health system capacities in public hospitals of Punjab. They survey about 106 public service hospitals where the surgery has been performed. And this was the first comprehensive assessment of anesthesia health system capacity, exposed a crucial deficiency of critical supplies and workforce for providing safe anesthesia. And in this article, they mentioned that in public sector, Punjab hospitals were performing surgeries, only 68.9% have post-anesthesia care unit, while 31.1% that doesn't have any post-anesthesia care units. So we don't know what kind of hospitals are there, are those which don't have post-anesthesia care unit. But most likely these are the hospitals which have 1 or 2 OR, and they recover their patient at different places. About the medications, there is a deficiency of medications as well. The most common analgesic which was available was nalbuphine and paracetamol, while fentanyl and morphine is available in very few hospitals. And interestingly, the costly drug like propofol is available in almost all hospitals, while 50% of the hospitals has only nitrous oxide. So this was another article about recovery room, a review of 6,978 consecutive admissions to the recovery room at a university hospital. This was done by Dr. Fawzia Khan in about 30 years back. And their observation at that time that very few hospitals in the Pakistan have this facility at hand. Among those that have, majority lack from firm guidelines as to the nurse-patient ratio, the essential equipment required, the responsibility of various staff, and discharge of the patient to the wards. and no minimum criteria of monitoring in the recovery room. I think this has changed a little bit. There are mainly the tertiary care hospitals, they do have a post-anesthesia care unit, but most of the secondary hospitals still have severe deficiencies. And at the conclusion, the local practice of having operating room suites without recovery area should be strongly condemned. So what is the situation in Sindh and other parts of the country? As there is no articles or no survey has been done, but there are some observations and the information I got from other colleagues. Most of the tertiary care hospitals, they do have post-anesthesia care unit, but the secondary hospitals, they don't have, or very few have recovery room, and they recover their patient either in the operating room, and this is the most common practice. And some of the hospitals who have ICU, these post-operative patients sent to the ICU. But the commonly what they do, as there is only one anesthetist available and he has to perform other surgeries, so he put that patient in the corridor close to the OR, and monitoring is done by a nurse, or sometimes even the nurse is not there. So the anesthetist has to move around from the OR to this recovery area and look after the patient. And discharge is also done by the same anesthetist. There is another study by Dr. Fawzia, Challenge of Pediatric Anesthesia Services and Training Infrastructure in Tertiary Care Hospitals, a perspective from the province of Sindh, which was published in Anesthesia and Analgesia. They said that there is no separate pediatric PACU, and none of the hospitals have dedicated pediatric nurse staff. And in this article, they also shows the deficiency of equipment and also the medication, particularly for the pediatric patients. For example, they talk about even the absence of pulse oximeter in one of the hospitals. So about recovery in the operating room, there is a study done in a Japanese hospital versus a hospital in USA. Actually, the hospitals of Japanese hospitals, they have almost 16% of the hospitals have post-anesthesia care unit, and most of the recovery is done in the operating room. So when they look at the recovery time at the University of Iowa was 112 minutes, which is almost 2 hours, and recovery time at General Hospital close to Tokyo was about 22 minutes. So soon after recovery, these patients transferred to the surgical ward. But in Japanese hospital, they are using very short-acting anesthetics like remifentanil. So the cost effectiveness is an issue. Medication and equipment, we already talked about medication and equipment. Pulse oximeter is available in very few, and it's been shared with different patients. Even the OR pulse oximeter is shared with the recovery room. ECG monitoring is not available in PACU. Staffing is deficient, and even if the nursing staff is present, then qualified nurses, trained nurses, and ACLS certification is a rarity. The area which we lack the most is the communication and documentation. Communication is required at the time of handover and discharge, and documentation particularly during PACU stay. So let me go to the recommendation directly. I would say that it is the responsibility of anesthetist to take care of all these 3 stages of anesthesia. All hospitals must have an identified area for post-operative recovery. Anesthetist must transfer the patient to this allocated area only if a competent person can take over the responsibility and if the monitoring is available. OR can be used as a recovery area if adequate staff and monitoring shortage in the hospital. All patients must be monitored for oxygenation or ventilation, and this should be documented. At least one ACLS certified nurse or anesthetist must be present at all times for post-operative patients. Anesthetist must help the hospital in developing discharge criteria. Even if there is only one ward in the hospital, discharge criteria must be there to discharge the patient from the area where recovery was done. A survey regarding current status of PACU in each province will help in planning and setting up future goals. Probably PSA can take a lead in this one. And the last one is the government regulatory bodies and anesthesia societies must work together to ensure patient safety in the post-operative period as well. So we all usually talk about the safety in the operative room, but the safety in post-anesthesia care unit is also important. Thank you.
Thank you, Dr. Hamid. A little time for the question answer session. Dr. Arshad Taqi is also online. So only 2 or 3 questions are accepted.
Assalamu alaikum. I'm just a gate crasher. I've not registered for this conference, sorry. But I wanted to make a couple of comments because it says in this, that this is international anesthesia standards, where do we stand? Currently, I happen to be working in UK, and so I thought I would just add in a couple of comments for the very nice 3 talks that we have heard from Dr. Gohar Afshan, Dr. Arshad Taqi, and Dr. Hamid. And regarding safety standards, I may just add about the documentation that if one really forgets to write something really important in the notes, then there can be serious consequences of that later on as well. And I'll give you an example. An anesthetist who had a very difficult intubation and managed to intubate that patient and did the surgery, went on successfully, and everything was fine. Few years down the line, the same patient had to undergo surgery in another hospital in UK. And over there, difficulty in intubation was found, and the anesthetist was unable to intubate that patient. The patient died as a consequence of that. Now the investigations were done, and the investigations included the previous anesthetic from a previous hospital as well. They got the anesthetic records from that hospital, only to find out that the anesthetist had failed to record difficult intubation in the case notes. And that anesthetist, the first anesthetist, was also punished for not documenting the problems he had faced during anesthesia. So I just wanted to add this to the very nice lecture that Dr. Gohar Afshan has delivered. And the other thing is the General Medical Council, which looks after the standards of healthcare and patient safety in UK, they take a very serious note on tampering of records. It's okay, if you have forgotten to write something, the court will take a stand on that. The General Medical Council will not take a stand on that. But if somebody is found to have tampered with the records, that something went wrong, and then they later on tried to correct it and just change the records, write something which was not written previously, then the General Medical Council takes a very sort of difficult stand on them, and most likely they'll be struck from the register for tampering with the records. So dishonesty is not acceptable by the General Medical Council. So I just wanted to add that. Again, regarding safety standards, when things go wrong and their case discussed in mortality and morbidity meetings, then it's mandatory for us to have multidisciplinary meetings there. For example, if it's a case related to ENT anesthesia and something went wrong, then we must have a combined meeting with the ENT surgical team as well and discuss the patient from both perspectives. Okay, can you hear me? Sorry. Okay, so that was another thing, that multidisciplinary meetings have become very standard there in UK. And anesthesia, with the blessings of the Royal College of Anaesthetists, are very stringent in the safety standards there. And as a result of that, the insurance premiums of the anaesthetists for medical negligence has gone down drastically. The surgeons pay a very high insurance premiums for their cover, whereas anesthetists pay very little premium as a proportion. So that is another good thing over there. And just by maintaining the standards set by the Royal Colleges, the anesthetists have managed to achieve that status. So we pay very little premium as a result of that.
Ehsan Waqar, last question from Ehsan Waqar.
I'm just intrigued by the comment that dishonesty is something that is not liked by GMC. Dishonesty is dishonesty. It's not liked by anyone. Full stop.
Thank you all. With this, we conclude this session, and I would now like to request the presenter who is present here, Dr. Hamid, to come on this stage and receive his certificate from Dr. Rana and myself. Dr. Hamid, please come on the stage. Dr. Arshad, we will send your certificate by air to you. Dr. Gaur, I'm assuming, is not here, so may I request Dr. Say.
Thank you so much, sir. Hello. Thank you, sir, for conducting the session. Now I would like to call upon stage Dr. Ehsan Waqar to distribute the certificates to the chief chairpersons of session 1. Thank you, sir. Thank you, sir, for conducting the session. Now we would proceed to our session 2, which would be moderated by Dr. Huba and Dr. Seher from Civil Hospital, Karachi.
Assalamu alaikum and a very good afternoon to everyone. I welcome you all to the second session for the day. My name is Huba Ahmed. I'm a postgraduate trainee at Dow University of Health Sciences, Civil Hospital, Karachi. So we would be starting our panel discussion on a topic which is of very paramount importance, that is local perspective about the medico-legal issues in anesthesia, as anesthesia is probably the most litigation-prone subject. And for this purpose, I would like to invite our chairs, Professor Naveed Masood, who is Professor and Consultant of Anesthesia at the Indus Hospital Network, Karachi. Professor Amjad Ali. Professor Amjad Ali has done his fellowship in cardiac anesthesia from Malaysia and is currently working as professor and head of department at Bolan Medical College, Quetta. Moving along the session, I would like to invite Professor Syed Muhammad Shahab Naqvi, who is working as Professor of Anesthesiology, Cardiac Anesthesia and Intensive Care at Bahria International Hospital, Rawalpindi, to share his views on the topic.
Bismillah ar-Rahman ar-Rahim. First thing first, thanks to PSA for inviting me for this very interesting and important session. Unfortunately, I don't see many for whom this session has been planned. So I would request the youngsters who are sitting outside to please join us, because it is basically for them that we do all the work, just that hard work has been done. So there are very few people sitting here, and most of them are very senior people. They already know what is the subject. So can I have the slides, please? May I request the people who are sitting on the back side to come forward? क्योंकि हॉल तो पूरा खाली है, थोड़ा सा आगे आ जाएं. Thank you. Okay, so medical issues, local perspective, and as we are working in the environment where these cases are happening with a great frequency these days as compared to before, so we have to be even more careful. As far as conflict of interest is concerned, I do have a conflict of interest. That is that I am biased to save my younger colleagues from the lawsuits, and I want them to be perfect because they are the ones who are going to take care of me one day, maybe. So, so let's start with some hypothetical, case, and then I have few cases which actually have been conducted in different courts of Pakistan. And if the time allows, I may, discuss 2-3 cases out of them, although I have collected 6-7 of them. But I'm sure that I won't have time to discuss all. So as first is the hypothetical. Hypothetically, suppose none of us sitting here is an anesthesiologist, just the ordinary person who walks into the hospital and gets a operation of a belly fat reduction, which is very common these days, especially in the ladies, under GA that lasted about an hour and resulted in complete recovery. But you remained aware during the surgery, one of your tooth was broken, your right arm got numb and weak due to annular compression, you developed severe sore throat and hoarse voice for about a month, and you developed post-traumatic stress disorder because of all that. So what are the chances that you are going to sue your anesthesiologist? Are they very high? So for the people who think that there are very high chances they'll sue their anesthesiologist, can raise the hand, please? And what are the chances? And number 2, for B, who are for B? Who are for C? C के लिए कोई है? Anesthetist ना बने, just the patient. And anybody for D? Delta. आप बिल्कुल नहीं करेंगे. Okay. So, have you ever thought that why anesthesiologists are more liable to face the lawsuits for their mistakes? We are the most, जिन गलतियों के लिए surgeons को बड़ी easily patient जो है वो माफ़ कर देते हैं या नहीं आगे जाते, उससे कहीं कम गलतियों के लिए anesthesiologists are being charged. Not in Pakistan. While I was going through the literature, I saw somebody was sued, one anesthesiologist was sued because he did not tape the eyes properly, and some of the pyodine went into the eye of the patient and got the irritation, and he was sued that and fined. In another case, one anesthesiologist gave epidural for painless labor. It had to be converted into C-section, so he topped up the dose, but when the incision was given, patient felt pain. He immediately converted into the GA. But after the procedure, patient sued the anesthesiologist for post-traumatic stress disorder. And in the third case, which was even more funny, that the one endoscopist asked for the sedation during anesthesia, and the anesthetist gave just IV sedation there, and the endoscopist did the endoscopy, and afterwards there was a damage to the teeth. And both were sued, both doctors were sued for that, and both had to pay the fine, anesthesiologist included. So be careful. So the anesthesiologists are more liable to face the lawsuits for their mistakes as compared. Why? Because one, patients or their relatives don't even know that we exist. It may be our fault. Anesthesia is not the main purpose for, that's what I think. Anesthesia is not the main purpose for which the patient is coming to the hospital. They are coming there for the surgery, and they think anesthesia is just there, for the sport and supposed to be very good. So, एक तो ये reason हो सकती है. And it is much easier to blame the anesthesiologist for less than perfect outcome than a surgeon, because surgeon has a rapport. वो काफ़ी देर मरीज के साथ बैठा होगा, फैमिली से भी डिस्कस किया होगा, उसके बेड साइड पे भी आके उन्होंने किया होगा बातचीत. Anesthesiologist never bother for that. हम लोग डिस्कनेक्टेड होते हैं, स्पेशली विद द फैमिलीज. अगर पेशेंट से बात कर भी लें तो फैमिलीज से हमारा कोई कनेक्शन नहीं होता. सो प्रोबेबली दैट कुड बी वन ऑफ द रीजंस. व्हेन इट कम्स टू एविडेंस इन द कोर्ट, ये पाकिस्तानी कोर्ट्स की भी बात है, लेकिन जनरली द क्रेडिबिलिटी ऑफ द एविडेंस इज इन ऑर्डर. इज फर्स्ट इज anesthesia records and notes. Second is the expert's opinion. Third is the specific recall by the witness of the event. And fourth is usual and customary practice. और हम usually जो है rely करते हैं fourth पे ही या ज़्यादा third पे. So we, generally anesthesia record में I have seen most of our youngsters are not very perfect. So ये बात पहले डॉक्टर गौहर अफशा ने भी कही, if it was not written, it was not done. That is an accepted norm in the courts of law. And this is from the father of quality in the world, Edward Deming. He say, in God we trust, all others must bring the data. And let's ask from the God Almighty, what does he say about it? Recording the data. And we all know what does he say. And indeed, over you, keepers noble in recording, they know whatever you do. Surah Infal, or ek aur jagah, and he is the subjugator over his servants, and he sends you over you guardian angels until when death comes to one of you. Our messenger take him, and they do not fail. So data is being recorded all the time. तो जब अल्लाह मियाँ ने डाटा हर वक्त आपका रिकॉर्ड करना है और उसके बगैर कुछ नहीं करना, तो आप कैसे समझते हैं कि बगैर डाटा रिकॉर्ड किए जो है आप सेव हो जाएंगे कहीं? So that is the importance of the data. So please, whenever you do, always record. क्योंकि अगर रिकॉर्ड नहीं करेंगे तो कोई यकीन नहीं करेगा. So this is one of the studies 20 years ago. Of 20 years, Melbourne की ऑस्ट्रेलिया की विक्टोरिया एक वो है काउंटी, उसमें मेलबर्न से उन्होंने ये डाटा कलेक्ट किया है 20 साल का। उसमें सिर्फ मैंने वो लिस्ट किए हैं जो 10 से ज़्यादा क्लेम्स हैं। एंड टॉप मोस्ट इज डेंटल डैमेज। अवेयरनेस इज अगेन सेकंड। डेथ अंडर एनेस्थीसिया, एपिड्यूरल्स पे बहुत हुए हैं कि जी वो कैथेटर स्लाइड इन कर जाता है डालने के बाद, और उसमें कभी कभी कॉर्डाइक्यूना सिंड्रोम तक हो गई है, परमानेंट डैमेज हो गया है। और हेडेक्स के लिए हुए हैं, ड्यूरल पंक्चर हेडेक्स के लिए। इंक्वेस्ट इज वेरी कॉमन। Joined with surgeon, whatever surgeon you do, even in one case anesthetist was fined because the surgeon operated on a wrong finger, so anesthetist was also fined in that. Nerve palsy is common. We all know that if you place both the hands on the chest and the elbows are flexed, there is more chance that the patient will get ulnar palsy later on or ulnar problems. Or, if you see the hand is stretched and neck is on the other side, there will be a brachial plexus injury. तो ये कॉमन चीज़ें, कॉमन पेरिनल इंजरी, लिथोटमी पोजीशन बहुत बनाते हैं, अगर गलत बनाएंगे हो सकती है. And you, anesthesiologist, will be charged, not the surgeon for that. Post-operative complications के लिए 12 cases हैं. So I have few actual cases. इनमें से जो एक्सपर्ट्स, इनके एक्सपर्ट ओपिनियंस थे, इनमें से शायद 1-2 लोग यहाँ ऑडियंस में मौजूद हैं, और ये दीज आर द एक्चुअल केसेस जो कि कोर्ट्स में हुए हैं. पहला केस है कि सर्जरी वाज परफॉर्म्ड फॉर एन इमरजेंसी. दिस हैपेंड इन सबर्ब पार्ट ऑफ सिंध. Surgery was performed for an emergency lower sector cesarean section. The patient had only one functioning kidney whose ureter was damaged during surgery. Patient later on developed kidney failure. Anesthetist ने सिर्फ स्पाइनल लगाया, स्पाइनल बहुत ठीक लगा, सर्जरी हो गई, पेशेंट शिफ्टेड, रिकवर्ड, केप्ट वॉकिंग, यूरिन आउटपुट ठीक रहा 24 घंटे, बट आफ्टर 24 आवर्स यूरिन आउटपुट स्टार्टेड ड्रॉपिंग. So the unanticipated damage to the patient's ureter caused the patient to suffer from kidney failure. As a result, she had to be referred to a specialist institute for treatment. उन्होंने reimplant कर दिया ureter को, kidney failure ठीक हो गया, patient went home hale and hearty, but the case comes up. And the judicial proceedings जो थी, उसमें anesthetist was asked first thing, license to practice. कि आपका लाइसेंस किधर है जो जिस पे आप प्रैक्टिस कर रहे हैं. मोस्टली हमारे जो पेरिफेरल एरियाज़ हैं, हमारे एनेस्थेटिस्ट बेचारे काफ़ी स्ट्रेस में होते हैं यंगस्टर्स, क्योंकि कभी कभी उनके पास डिग्री नहीं होती, MCPS की भी नहीं होती, FCPS की भी नहीं होती, एंड दे हैव जस्ट डन एमओशिप अंडर सम सीनियर पर्सन एंड दे आर गिविंग एनेस्थीसिया. और वो फिर जब केस बनता है तो सारी चीज़ें डिटेल में आपसे पूछी जाती हैं. उस वक्त कोई ये आपको माफ़ नहीं करता कि जी आपने बड़ा काम किया मरीज़ की जान बचाने के लिए, जबकि हॉस्पिटल आपके ऊपर स्ट्रेस करेगा, सर्जन भी आपके ऊपर स्ट्रेस करेगा कि जी नहीं, आप जान बचाने के लिए सिर्फ आप ही हैं मौजूद और कोई कुछ नहीं कर सकता वगैरह वगैरह. एंड व्हेन द केस हैपन्स इट इज़ यू अलोन हु हैज़ टू डिफेंड. सो उन्होंने पूछा कि आर द ट्रेन्ड एनेस्थीसिया एमओज अलाउड टू गिव इंडिपेंडेंट एनेस्थीसिया और नॉट. The strong emphasis was given that the anesthetist should have refused if he did not have certified post-graduate training. और हुआ क्या था? हुआ ये था कि ब्लीडिंग शुरू हो गई और वो उन्होंने इमरजेंसी मचा दी कि जी हिस्टेक्टमी करनी है. पेशेंट वाज शिफ्टेड, ही गेव स्पाइनल, सब कुछ, मरीज़ ठीक हो गया, बट स्टिल ही वाज सूड. और काफ़ी ग्रिल किया जो उनके लॉयर थे, उन्होंने उसके ऊपर एनेस्थेटिस्ट को. वेदर थ्रू pre-operative assessment was thorough, peri-operative assessment was done or not. Was the anesthetist aware that the patient had only one kidney, one functioning kidney? If yes, did he explain the risk to the patient before surgery and or discussed with the surgeon? Subject expert ने क्या opinion दिया कि pre-anesthetic evaluation ज़्यादा thorough होनी चाहिए थी. Informed consent was not taken from the patient. उनको नहीं ये बताया गया कि ureter injury का भी risk है. So failure to inform the attendants about the critical incident in OR, मरीज़ को ये नहीं बताया गया कि OR में ureter damage हो चुका है और बाद में उन्होंने implant करने की कोशिश की है. Hospital admin should be held responsible to hire only qualified anesthesiologists. Now there is a question from my side to you. Should the PMC or PSA assert to implement a law of minimum qualification, minimum monitoring, and minimum data collection during the surgery? आप क्या कहते हैं, होना चाहिए लॉ या नहीं होना चाहिए? क्योंकि अभी तो I don't think so exist or not. So there has to be a law, and PSA should play a role, or Pakistan Medical Commission or PMDC should play a role in it. Case number 2, 4-year-old girl, मुझे जरा 2-3 मिनट पहले बता दीजिएगा क्योंकि केसेस काफ़ी हैं तो मैं फिर छोड़ दूंगा बीच में. 4-year-old girl with a fractured elbow underwent under surgery under GA. मरीज हैंड ओवर कर दिया PG रेजिडेंट एनेस्थेटिस्ट को. कंसल्टेंट थोड़ी देर के लिए बाहर गए. वहाँ पेशेंट जो है उनको पल्स ऑक्सीमीट्री पे स्ट्रेट लाइन नज़र आई जब अपनी PG को, तो उन्होंने कंसल्टेंट को कॉल किया. उससे पहले उन्होंने 1 मिलीग्राम एट्रोपिन दी. ही केम ही सेज ही केम विद इन 15 सेकेंड्स. और उसके बाद CPR हुआ, एड्रेनलिन 1 मिलीग्राम दी, एंड दे क्लेम दैट 45 सेकेंड्स के बाद हार्ट जो है वो चल पड़ा. बट द पेशेंट व्हेन यू वेंट आउट, जब रिकवरी में गई तो फिर उसके बाद उसको फिट्स पड़ने शुरू हो गए, और उसके बाद शी हैड टू बी रीइंटुबेटेड. फिर EEG कराई जिसमें सीजर एक्टिविटी नज़र आई. CT स्कैन पे बोथ सेरिब्रल हेमिस्फीयर्स वर डैमेज. Ischemic injury done. Patient's pupil became unresponsive, और न्यूरोलॉजिकल 2 दफ़ा एग्जामिन किया और ब्रेन स्टेम डेथ कंफर्म हो गई. She was disconnected from ventilator after 72 hours. Now जुडिशल प्रोसीडिंग्स इसकी क्या हुई, ज़रा ये देखने की बात है. अब ये हो सकता है कि आप आगा खान में बैठे हों तो आपके पास सारी चीज़ें होती हैं, या इंडस हॉस्पिटल में बैठे हों. अच्छा, अभी तो मैं शुरू ही हुआ हूँ. तो डॉक्यूमेंटेशन विद प्रिसाइज टाइमिंग्स हुई थी या नहीं हुई थी. मैक मॉनिटरिंग पे इंसिस्ट किया कि आपने की या नहीं की ड्रग्स की मैक मॉनिटरिंग. टेम्परेचर मॉनिटरिंग हुई थी या नहीं हुई थी, कितने लोग हमारे करते हैं. फ्लूइड एडमिनिस्ट्रेशन का रिकॉर्ड, एस्टिमेशन ऑफ ब्लड लॉस और उसकी क्या मैनेजमेंट की आपने. उन्होंने कहा कोई एस्टिमेशन ब्लड लॉस नहीं हुआ, लेकिन सेकेंड डे पे ये ऑब्जर्व किया गया कि 2 ग्राम जो है वो कम हो गई थी हीमोग्लोबिन. हॉस्पिटल से पूछा कि आपका इमरजेंसी रिस्पांस सिस्टम कैसा है. कोड टीम अनाउंस होती है रोज़ाना या नहीं होती है आपकी. एग्जैक्ट टाइम ऑफ स्टार्टिंग एंड स्टॉपिंग CPR वो पूछा गया. लैब टेस्ट इमीडिएटली आफ्टर रॉस वाज अचीव्ड, ABGs की थी या नहीं की थी इसके बाद. और मोस्ट इम्पॉर्टेंट, दे इंसिस्टेड and also reprimanded the hospital for not giving CCTV camera footage to find out the lag between the call and response of the consultants. आजकल के मॉडर्न ज़माने में ये बहुत ज़रूरी हो गया. Why the parents were not informed about cardiac arrest and CPR in OR by the first consultant. Later on जो senior consultant आए तो उन्होंने बताया. Subject expert को opinion, cerebral hypoxia was possibly due to late recognition of hypoxic episode, delay in providing cardiac massage एक हो सकता है, और faulty technique एक हो सकती है, जो कि ज़ाहिर है senior वो थे anesthetists शायद possible नहीं थी. Giving atropine is not the protocol of the PALS. जो recommend कि अगर 60 से कम अगर heart rate हो जाए बच्चे का तो आपने basic life support शुरू करनी है. So these were the comments. और भी काफ़ी सारे हैं. ये जो तीसरा केस है इसमें anesthetics का इतना कसूर नहीं था. ऑर्थोपेडिक सर्जन ने प्लेटिंग की, बाद में उसको किसी और हॉस्पिटल में जाके रिमूव किया, लेकिन उन्होंने एनेस्थेटिस्ट को भी शामिल कर लिया एज अ रेस्पोंडेंट बिकॉज ही वाज जॉइंड विद द सर्जन. बाद में उसको नर्व पैल्सी हो गई हाथ में और पेशेंट जो है वो फिर DNC एक गायनेकोलॉजिस्ट ने की. उन्होंने कहा जी मैं बगैर एनेस्थीसिया के कर लूँगी, मुझे कोई मसला नहीं है. सारे एनेस्थेटिस्ट चले गए और उन्होंने अटेंडेंट से कहा कि उसको फेनागन लगा दें. उसने एम्प्यूल उठाया, लगा दिया और वेंट आउट. The patient arrested after a while. She was resuscitated later on. Anesthetist call हुए, ROSC achieved हो गई. Later on it was found that the injection was Pavilon and not the Fenagan. अगर आप दोनों एम्प्यूल्स को साथ रख के देखें तो तकरीबन एक जैसे हैं. इस पर अभी तक कोई लॉ नहीं बना कि लुक अलाइक साउंड अलाइक ड्रग्स जो हैं वो कैसे हैंडल होनी चाहिए. कोई स्टैंडर्ड प्रोटोकॉल हो उसका जो इंसिस्ट करे, पंजाब हेल्थ केयर कमीशन या पाकिस्तान हेल्थ केयर कमीशन इंसिस्ट करे या PMDC इंसिस्ट करे या PSA इंसिस्ट करे. Patient could never recover neurologically and remained in vegetative state for a long time. तो इसमें क्या नज़र आता है? लैक ऑफ डिसिप्लिन इन ऑपरेटिंग थिएटर, एब्सेंस ऑफ प्रोटोकॉल फॉर IV मेडिकेशन, नो protocol for LASA drugs, responsibilities of anesthesiologist while surgeon is operating under local or without anesthesia. तो उसमें क्या responsibilities anesthetist की होती हैं as in charge of the operating theaters, ये हमें define करने चाहिए. अयूब मेडिकल कॉलेज में एक केस प्रेजेंट हुआ, उसमें यूट्रस डैमेज हो गया, एडिनोकार्सिनोमा ऑफ यूट्रस जो है वो निकाल रहे थे तो यूरेटर डैमेज हो गया, ब्लैडर डैमेज हो गया. ब्लैडर को उन्होंने रिपेयर कर दिया, ठीक हो गया, बट लेटर ऑन प्रॉब्लम्स हुए और एनेस्थेटिस्ट भी चार्ज किया गया, मरीज हालांकि ठीक था, बिकॉज ही वॉज ज्वाइन विद द सर्जन. तो ये दो और भी केसेस हैं, इसको हम स्किप करते हैं. टेक होम मैसेज क्या है? वी लर्न क्वाइट अ लॉट फ्रॉम द एविएशन इंडस्ट्री एनेस्थीसिया में. तो एक बड़ी स्टोरी है छोटी सी जो है ऑफ ए फ्लाइंग फोर्ट्रेस. 8 अगस्त 1934 को US आर्मी ने डिसाइड किया टू गेट अ बॉम्बर कैपेबल ऑफ बॉम्बिंग टेकिंग अ लोड 10,000 फीट फॉर 10 आवर्स. और उन्होंने बड़ा रिसर्च किया, उन्होंने स्पेशलिस्ट इंजीनियर्स रखे, 1 साल लगाया, और जब वो बन गया तो फिर उसको जो बेस्ट पायलट टेस्ट पायलट था उसने उड़ाया. दोनों इंजीनियर्स उसमें थे. एंड व्हेन this took off, and when the plane took off, it was a beautiful plane और उसको flying fortress वो कहते थे. Unfortunately हुआ ये कि जब वो टेक ऑफ किया उसने तो so this is the actual plane जिसको वो flying fortress कह रहे हैं. And within इसमें साउंड नहीं है मगर वरना साउंड भी इसकी बहुत अच्छी है. तो and it within 5 minutes of taking off, it turned around and crashed. All the engineers died, everyone on this died, and all the effort was done. बहुत उन्होंने रिसर्च की क्या वजह हुई होगी, इंजीनियर्स ने, सब लोगों ने, लेकिन आखिर में पता चला कि the pilot had forgotten to release a new locking mechanism on the elevator and rudder controls जो उन्होंने लगाया था. What we have to learn from this, उन्होंने क्या किया? उन्होंने बहुत आसान काम किया. इस 28 जुलाई 1935 के फ्लाइंग फोर्ट्रेस के एक्सीडेंट के बाद it changed flying forever. और क्या किया उन्होंने? सिंपल अप्रोच. दे क्रिएटेड पायलट्स चेकलिस्ट विद स्टेप बाय स्टेप चेक्स टू टेक ऑफ फ्लाइट, लैंडिंग एंड टैक्सिंग. चेकलिस्ट इन हैंड, द पायलट्स वेंट टू फ्लाई द सेम मॉडल फॉर अ टोटल ऑफ 1.8 मिलियन माइल्स विदाउट वन एक्सीडेंट. जुलाई 28 को उस दिन के बाद से चेकलिस्ट डे कहते हैं फ्लाइंग हिस्ट्री में. सो व्हाट डू वी लर्न फ्रॉम इट? दैट वी हैव टू हैव द चेकलिस्ट फॉर एवरी प्रोसीजर. Every important procedure we have to tick before move on. So consider every patient as a potentially litigious patient. हर patient को आप ये सोच के induction दें कि वो बाद में आप पे केस कर सकता है. And whenever you work, make SOPs, protocols and checklists and implement them in two-letter pre-anesthetic evaluation बहुत important है. I would insist even कि वीडियो रिकॉर्डिंग कर लें उसकी. आज तो पूरा पाकिस्तानी आजकल तो वीडियो रिकॉर्डिंग पे चल रहा है. So why not anesthesia pre-anesthetic evaluation? Consent should never be taken in the operating room. पहले से informed consent होना चाहिए. Informed refusal को भी उतना ही respect दे जितना informed consent को देते हैं. और never leave the patient unsupervised, ये तो normal बातें हैं. Second opinion जो है वो hesitate ना करें. और एक चीज़ बहुत ज़रूरी है जो कि हमेशा होती है कि we hesitate to inform the surgeon, especially अगर anesthetist junior हो और कोई कार्डियोवास्कुलर इवेंट हो रहा हो, ब्लड प्रेशर कम चल रहा हो, वो एनेस्थेटिस्ट को डर के, वो सर्जन को डर के मारे बताते नहीं है बेचारे. एंड इट कॉजेज प्रॉब्लम. आई थिंक वन ऑफ द केसेस जो हमने डिस्कस किए हैं उसमें ये भी एक रीज़न होगा, बिकॉज द एनेस्थेटिस्ट वर जूनियर. सो डिटेल रिकॉर्ड कीपिंग इज़ अ मस्ट. थैंक यू. सॉरी फॉर द एक्स्ट्रा टाइम.
Thank you, Professor Shahab, for addressing this interesting talking point. Now please welcome Dr. Hamidullah, Faculty Anesthesiology and Intensive Care at Aga Khan University, to moderate the discussion.
अस्सलाम वालेकुम। सर ने बहुत कुछ कवर कर दिया और उसके बाद जा भी रहे थे। Okay, to take this discussion further, I would like to invite the other members of the panelists. Professor Tipu Sultan, इनको मैं क्या बताऊँ कौन नहीं जानता और क्या नहीं जानता। Sir, please. We also have with us Dr. Ehsan Kavi Siddiqui, who is currently the CEO of Sindh Healthcare Commission. He is an old friend from AKU, where he was a pulmonologist, and then he took over into the quality and healthcare management and ethics, clinical trials. He is a graduate from the London School of Hygiene and Tropical Medicine. Next, we have with us Justice Athar Saeed. He has been the Justice of the High Court, and then he progressed to the Justice of Supreme Court. And okay, so based on Dr. Shahab's presentation, we have another panelist, Dr. Rubina Bashir, who is the administrator at Civil Hospital Karachi. She is the medical superintendent there. She has 34 years at different posts in health departments, government of Sindh, 8 years at administrator at different hospitals of Karachi, ex-civil surgeon and MS of Services Hospital Karachi. Koi reh to nahi gaya? Okay, so based on Dr. Shahab's presentation, if there is any question from the audience. Right, so from the CPOD report published in 1987, and that was one of the most comprehensive reports. We don't have any other further reports of that intensity. Sole cause of death from anesthesia point of view is less than 0.1%, where anesthesia is the sole cause of death. However, as a contributory to post-operative deaths, anesthesia has been implicated in 14% of the cases. So to begin the discussion, we need to understand the difference between a known complication and a post-operative event attributed to negligence. So can anybody highlight the difference between complication and a negligence?
Assalamu alaikum ji, bismillahirrahmanirrahim. There are so many things which are coming to my mind to discuss and share with you, but I would like to highlight a few points because of lack of time. And your question is, what's the difference between the negligence and actual complication? I think negligence, if you go by the definition, is that if there is a failure of the equipment or absence of a human resource at the time of the event, then in the court it is considered as a negligence. But having said that, because I am talking from the perspective of the Sindh Healthcare Commission, first of all, I would like to inform you that whatever Dr. Shahab has presented, it is going to be a norm in the future. Because the litigation, and Dr. Hamidullah, my colleague, will vouch for that because he is also part of many hearings at the Sindh Healthcare Commission. So many complaints are now coming to us that you cannot even imagine. It's like we are not able to handle them. The problem is the most common cause of something converting into a negligence is not actual negligence, it's a system failure. Secondly, it is the lack of communication and lack of involvement of the patient and family in the care process which creates a perspective of negligence. These are very two important aspects, and these are the majority of cases where no actual negligence happened, but the system got failed. It's not an individual doctor who got failed, but the system got failed. And I was just when Dr. Shah was talking about the operating theater, many hospitals, I am not talking about, and I am not going outside the boundary of Karachi. I am talking about Karachi and Hyderabad, the big cities in the Sindh province. Most of the hospitals, majority of them are polyclinics. And these polyclinics do not have any institutional policy and procedure to follow. These clinics are established on the basis of a doctor bringing volume to the hospital and giving them business. So what about having a pre-procedure meeting between the surgeon and the anesthetist is very rare. Because a surgeon is called upon, and an anesthetist is called upon, and the patient is given to them to operate. So there are so many factors which play their role in creating something which becomes a negligence at the end of the day. And once it happened, because इस वक्त हम यहाँ जब बैठ के ये बात कर रहे हैं, बहुत सी सर्जरीज हो रही हैं जिसमें कोई इवेंट नहीं हो रहा है, and they are going smoothly. But the problem arises जब कोई इवेंट हो जाता है तो फिर लाइसेंस भी देखा जाता है, फिर कॉम्पिटेंसी भी देखी जाती है, फिर इक्विपमेंट भी देखा जाता है, फिर हर वो चीज़ देखी जाती है. तो इसमें जो आपका सवाल था उसका जवाब तो शायद मैं दे सका, अगर कोई साथी उसमें ऐड करना चाहे. बट देर आर सो मैनी थिंग्स व्हेन वी गो थ्रू दीज कंप्लेंट हियरिंग. और मैं अगर आप मुझे दोबारा मौका देंगे तो पता नहीं देंगे, मैं एक बात और ज़रूर करना चाहूँगा कि सिंध हेल्थ केयर कमीशन का एक एक्ट है, वो कानून है, लेकिन क्या वो कानून हमारे फ्रैक्चर्ड हेल्थ केयर सिस्टम पर एप्लीकेबल है या नहीं? नो, इट्स नॉट एप्लीकेबल, because this Qanun is copy and pasted. It has not taken into account the reality of our healthcare delivery system. And our healthcare delivery system, you all know how it comprises. So उसकी वजह से जो बहुत बड़ा रोल है वो इन सोसाइटीज़ का है, जिनको मैं एम्फेसाइज करना चाहूँगा कि आज हम अगर उस एक्ट पे चलते हैं तो 80% ऑफ द हॉस्पिटल को मुझे बंद करना पड़ेगा, जो कि पॉसिबल नहीं है. सो अब अगर हमने कुशन प्रोवाइड करना है तो कुशन प्रोवाइड करने के लिए जो चीज़ बनाई जानी है वो कौन बनाएगा, वो किसका रोल है? उसमें आपकी सोसाइटीज़ का रोल बहुत इंपॉर्टेंट है, क्योंकि आपकी सोसाइटीज़ ने रिकमेंड करना है वो कुशन जो कि आज हमारे यंग डॉक्टर्स जो कि बेचारे डू नॉट हैव एनी पोस्ट ग्रेजुएट क्वालिफिकेशन बट दे आर वेरी कॉम्पिटेंट, दे वर ट्रेन्ड, बट एट द टाइम ऑफ लिटिगेशन द ट्रेनिंग विल नॉट काउंट. So should we include something like training with credentials available for them to prevent from litigation? So it is important that the societies like Anaesthesia Society should start working on those standards. मैं आपको भी बता रहा हूँ, मेरे पास जो इसका डेटा है वो तकरीबन 300 कंप्लेंट्स का है. इस 300 कंप्लेंट्स में डायरेक्ट एनेस्थीसिया की कंप्लेंट्स तकरीबन 20 हैं और इनडायरेक्ट बहुत सारी हैं. और एक लास्ट पॉइंट मैं ये कहना चाहूँगा कि जिस वक्त कंप्लेंट होती है तो एनेस्थीसिस्ट के, जैसे उन्होंने एक एग्जांपल दी थी कि कसूर सर्जन का भी हो एनेस्थीसिया पे लग जाता है, इसका अदर वे राउंड भी होता है, क्योंकि प्राइमरी फोकस और प्राइमरी जो इंटरफेस होता है वो सर्जन होता है. तो उसकी वजह से वो नहीं, उसको हमेशा सर्जन को अक्यूज़ करते हैं, बाद में पता लगता है कि कुछ कसूर शायद एनेस्थेटिस्ट का था. और इन्फॉर्म कंसेंट, माई लास्ट पॉइंट देन आई विल एंड. इन्फॉर्म कंसेंट जो चाहिए, आज उन्होंने मेरे दिल की बात कही है, कई हॉस्पिटल्स में ये बात मैं कह चुका हूँ कि प्लीज़ स्टार्ट टेकिंग इन्फॉर्म कंसेंट विद अ वीडियो रिकॉर्डिंग, बिकॉज इवन इफ़ यू डॉक्यूमेंट. आज बात हो रही थी कि ऑनेस्टी, क्योंकि बाद में टेम्परिंग बहुत होती है उसके अंदर, लेकिन अगर वीडियो रिकॉर्ड मौजूद होगा, दुनिया आगे चली गई है, हर चीज़ रिकॉर्ड हो रही है, तो कम से कम पेशेंट को लिटिगेशन के टाइम पे पता होगा कि उसको क्या बताया गया था और क्या नहीं बताया गया था, क्या उसको चॉइस दी गई थी, क्या नहीं चॉइस दी गई थी. एक जिक्र इन्होंने भी किया था कि पेशेंट को एपिड्यूरल दिया
और एपिड्यूरल देने के बाद जब वो फेल हुआ तो उसको जनरल एनेस्थीसिया में कन्वर्ट कर दिया। जनरल एनेस्थीसिया में कन्वर्ट करना, क्या ये इन्फॉर्म कंसेंट के टाइम पे उसको बताया गया था कि अगर एपिड्यूरल फेल हुआ तो आपको जीए दे दिया जाएगा? यहाँ भी लैक है। सो दीज आर फ्यू कमेंट्स। थैंक यू वेरी मच।
राइट, सो जब भी कोई लिटिगेशन होगी, एक छोटा सा क्वेरी है जिसको हम थोड़ा सा अगर समझ लें, इट कुड बी सिविल सूट और अ क्रिमिनल। तो जस्टिस साहब से मैं ये पूछना चाहूँगा कि हाउ डू यू, ये जो ज़्यादातर लॉ सूट्स होते हैं, आर दे क्रिमिनल और सिविल, एंड वाई?
बिस्मिल्लाहिर्रहमानिर्रहीम। आपने एक लेमन को बुला लिया जिसको एनेस्थीसिया की स्पेलिंग भी नहीं आती। बट when I read your supplement this morning, articles by Dr. Fawzia Khan and Sayyida Haider, और Sayyida Haider साहबा ने जो आखिर में conclude किया कि even one death by negligence is more than enough and we should not be negligent. मेरे हिसाब से एनेस्थीसिस्ट प्रोफेशन तो बहुत ही पुराना है। When God created Eve out of ribs of Adam, तो मेरा ख्याल है एनेस्थीसिया आप में से किसी कुलीग ने दिया होगा आपके। बट लॉ की जहाँ तक बात करते हैं, एज फार एज माई एक्सपीरियंस गोज, आई हैव हर्ड अ नंबर ऑफ फैटल एक्सीडेंट केसेस, आई हैव हर्ड अ लॉट ऑफ क्रिमिनल केसेस ऑन फोरेंसिक मेडिकेशन, बट अनफॉर्चुनेटली मेरे पास कोई नेग्लिजेंस का केस नहीं आया। एंड सो आई एम नॉट वेरी वेल वर्स की नेग्लिजेंस के केस में क्या होता है। लेकिन अभी डॉक्टर कबीर ने फरमाया कि जो हेल्थ कमीशन है उसका कोई लॉ है, बट बिल्कुल नॉन फंक्शनल लॉ है। एंड देयरफॉर आई थिंक द फर्स्ट थिंग शुड बी डन इज दैट इट शुड बी मेड फंक्शनल एंड इट शुड बी कंटेन एवरीथिंग। व्हाट इज नेग्लिजेंस का डेफिनेशन होना चाहिए, ताकि बिला वजह कोई आदमी नहीं सफ़र करे। और सर्जन के साथ तो एनेस्थीसिया ज़रूर आएगा अगर कोई मेडिकल नेग्लिजेंस केस आएगा, बिकॉज गलती किसी की भी हो सकती है। आई हैड रेड अ बुक अबाउट ऑफ हैरोल्ड रॉबिन्स वेयर अ नोन सर्जन वाज ऑपरेटिंग and the patient died, and the surgeon was blamed for it. But after inquiry, it was found that it was not surgeon's fault, but it was a fault of the anesthetist. In Pakistan, we do not have definite, specific law on negligence of the doctors. खुदा न खास्ता आप लोग अगर अमेरिका में प्रैक्टिस कर रहे होते तो पता चलता कि एक पैसे की भी आपसे गलती हो जाए तो कितनी सज़ा मिल सकती है, कितना आप पे डैमेजेस लग सकते हैं। बट पाकिस्तान, एट लीस्ट टू माई नॉलेज, कोई ऐसा केस नहीं आया है जिसमें कोई ज़्यादा डैमेजेस लगाए गए हैं सर्जन पे या वो। लेकिन मेरा ख्याल है सर्जन इक्वली रिस्पॉन्सिबल है अगर एनेस्थीसिस्ट की भी गलती हो, बिकॉज सर्जन यूजली नॉमिनेट्स द एनेस्थीसिस्ट कि मुझे वो एनेस्थीसिस्ट चाहिए, मुझे ये एनेस्थीसिस्ट चाहिए। तो और आप देखें कि सर्जन की गलतियों में, आई गिव एग्जाम्पल, फौजिया वहाब का नाम आप लोगों ने सुना होगा, MNA थी, उनको सर्जन की, मेरे ख्याल ज़्यादा एजेड सर्जन थे, उनके हाथ शायद काँप गए और कोई उनकी वेन काट दी जिसकी वजह से शी डाइड। बट कोई उसके खिलाफ मेरे ख्याल तो एक्शन नहीं हुआ। एंड आई नो अनदर जज साहब जिनकी बीवी को एक बहुत मशहूर कार्डियोलॉजिस्ट ने ऑपरेट किया और रोज़ उनको कहते रहे कि एवरीथिंग इज़ गोइंग वेल, और जब वो सर्जरी करके आए तो कहा कि हमने कंडक्टेड सच अ good surgery before, and she died the next day. So everybody has to take the blame, but Health Commission, Dr. Kabir साहब, Health Commission का बहुत बड़ा रोल है इसको कंट्रोल करने में, और मैं इस सोसाइटी से भी रिक्वेस्ट करूँगा जस्ट टू सेफगार्ड योर वो आप इस पर सेमिनार्स ज़्यादा कराएं और कुछ एक लॉयर की टीम बनाएं जिनको आप रिटेनर नहीं दें बट उनको ट्रेन करें कि नेग्लिजेंस लॉ को डिफेंड कैसे किया जा सकता है बिकॉज दे कैन बी डिफेंडेड ऑल्सो। और आखिरी जो मेरी एडवाइस है यंग एनेस्थेसियोलॉजिस्ट को वो ये है कि हम जब कोई केस तैयार करते हैं और एक सेक्शन हमने 25 दफ़ा पढ़ा होता है तो वी विल गो ऑन रीडिंग इट अगेन एंड अगेन विद रेफरेंस टू दैट पर्टिकुलर केस कि इसको इस केस में किस तरह अप्लाई कर सकते हैं। तो आई वुड रिक्वेस्ट द एनेस्थेसियोलॉजिस्ट टू रीड द फैक्ट्स ऑफ ईच केस, सी व्हाट आर द टिपिकल factors which may create problems and then try to find a solution before it post surgery, not pre-surgery, not post surgery. And मैंने एक बार जज साहब से पूछा था, उनका इंटरव्यू ले रहा था, I asked him, like, my Lord, what makes a good lawyer? He said, you ask your juniors, give them a proposal and they have so many cases before you. It is the hairline distinction of finding the hairline, it is the fine art of finding the hairline distinction between your case and the other case, of the similarity between your case and the other case which makes a good lawyer. I say that it is the hairline distinction and hairline decision you make from the facts of the case which makes a good anesthesiologist. And मैं तो वैसे भी आज जब यहाँ आया था इतने anesthesiologists की सामने तो मैं वैसे ही disease pills आने लगे थे. But I would like to thank you for calling me to this panel. Although I know legally I have not been of much help today, but thank you very much all of you. और Dr. Tipu Sultan साहब ज़्यादा शुक्रिया. He is my favorite anesthesiologist.
सर अगर वो आप बता सकें कि सिविल और क्रिमिनल का डिफरेंस.
Hamidullah, can I comment? Can I comment?
जी जी.
अच्छा, I am Dr. Sadka. I am working at trauma center. ठीक है, तो बहुत ज़्यादा हमारे पास मेडिको लीगल होते हैं, केसेस होते हैं. व्हेन द पेशेंट एक्सपायर तो उसके बाद ये होता है कि जो हमारा रेसिडेंट होता है या ट्रेनी होता है वो डेथ सर्टिफिकेट पे डरता है साइन करने के लिए क्योंकि उसको कोर्ट में जाना पड़ता है और कोर्ट में जाता है वहाँ पे हियरिंग जो होती है वो होती है नहीं होती ये भी बहुत होता है और अक्सर कराची से लाड़काना जाना पड़ता है और वहाँ जाना पड़ता है सांगड़ वगैरह सब जगह पे. अब ज़्यादातर जो है ना हमारी डॉक्टर्स अब फीमेल हैं और फीमेल के लिए ये होता है कि वो इतना डरती हैं कि वहाँ पे कैसे पहुँचेंगी. तो ये हेयरिंग की जो होती है ना डिले वो प्रॉब्लम होता है.
बेसिकली तो कभी कभार कोर्ट आपको पर्सनली बुलाता है वरना आपका वकील जो होता है.
नहीं वकील नहीं है. वी डोंट हैव एनी लॉयर.
विदाउट लॉयर तो फिर
वी आर हम बोल रहे हैं
बिकॉज और लॉयर भी जिसको कुछ हेल्थ केयर के बारे में पता हो, जिसको आपने कोच किया हो, जिसको आपने ट्रेन किया हो. बिकॉज जिस तरह मेडिकल फील्ड में स्पेशलिटीज़ हैं इसी तरह लॉयर्स में भी स्पेशलिटीज़ है. आई माई सेल्फ practice tax all my life before becoming a judge of the High Court. So on the first day the Chief Justice told me you will not be able to hear tax cases for 1 year. दूसरी चीज़ें समझो तो उसमें स्पेशलिस्ट होती हैं. इसीलिए मैंने इनको ये एडवाइस किया है सोसाइटी को कि कुछ पैनल बनाएं और उन पैनल्स को खुद बता के फैक्ट्स बताएं और हर हॉस्पिटल से कहें कि ये लोग जो हैं दे आर नाउ वेल वर्स्ड इन नेग्लिजेंस लॉज.
अब एक्चुअली गन शॉट्स बहुत आ रहे हैं, बहुत गन शॉट्स आ रहे हैं इन द ट्रॉमा सेंटर के अंदर और दे आर ऑल मेडिको लीगल केसेस होते हैं.
चलें इसको
सारे गन शॉट केसेस आते हैं.
अच्छा जी, आपने इस पर 2 सवाल थे, मैं दोनों का आपको जवाब देने की कोशिश करता हूँ. पहली बात तो ये कि जो सिंध हेल्थ केयर कमीशन का एक्ट है वो अब एक्टिव है और लॉ इवॉल्व हो रहा है मैं क्यों ये कहना चाह रहा हूँ? देखिए, एक सिंध हेल्थ केयर कमीशन का एक्ट है जिस पर हम आजकल काम कर रहे हैं कि उसको हम अमेंड करें और अमेंड करके उसको अपनी ग्राउंड रियलिटी के साथ कंपैटिबल करें। ठीक है, एक तो ये बात हो गई। दूसरे कुछ और अभी लॉ हमारे इनएक्ट हुए हैं, जिसमें एक है हेल्थ केयर प्रोफेशनल एंड हेल्थ केयर फैसिलिटी प्रोटेक्शन, जिसमें कि लोग तोड़ फोड़ करते थे, उसका भी लॉ बन गया है। अब जो आपने बात की है उसका मैं आप क्रिमिनल वाली बात हम पहले कर लेते हैं। असल में होता क्या है कि व्हेन द पेशेंट इज़ वेरी इन्फ्लुएंशियल, दे ट्राई टू डिस्ग्रेस द डॉक्टर एंड द हॉस्पिटल बाय गोइंग फॉर अ क्रिमिनल केस, जो उनका राइट है FIR कटाना। अब सिंध हेल्थ केयर कमीशन या जितने कमीशन रिस्पेक्टिव कमीशन है, दे आर बिकमिंग अ बफर फॉर द मेडिकल कम्युनिटी एज वेल। हाउ? अगर कल आपको किसी क्रिमिनल प्रोसीडिंग में पुकारा जाता है, बुलाया जाता है, ड्रैग किया जाता है, यू कैन से दैट द केस हैज़ टू गो थ्रू द राउट ऑफ द सिंध हेल्थ केयर कमीशन फॉर इन्वेस्टिगेशन फर्स्ट। उससे पहले आप नहीं कर सकते। और अभी रिसेंट एग्जाम्पल, मैं नाम कोट नहीं करूंगा, बट आई कैन से द स्पेशलिटी, अ कार्डियोलॉजिस्ट वाज अरेस्टेड एंड बाय वन लेटर ऑफ सिंध हेल्थ केयर कमीशन हिज बेल वाज अश्योर्ड, कि पहले आप इसको इधर भेजेंगे, पहले यहाँ कमीशन उसको एग्जामिन करेगा, एक्सपर्ट उसको एग्जामिन करेंगे, उसके बाद किसी किस्म का फैसला होगा। आप FIR काट के उसको अरेस्ट नहीं कर सकते। नंबर 1। आपका जवाब मैं देता हूँ। बाई स्टैंडर्ड, ईच हेल्थ केयर एस्टेब्लिशमेंट, बी इज गवर्नमेंट or private, has to have a system to protect the legal and security of the doctors. ये अब लिखा हुआ हमारे स्टैंडर्ड में, और जिस अस्पताल को हम लाइसेंस देते हैं तो वी मेक श्योर, अभी ट्रॉमा सेंटर नहीं हुआ है अभी इत्तेफाक से, लेकिन जब हम आपके पास आएंगे तो हम इस स्टैंडर्ड को इम्प्लीमेंट कराएंगे कि आपके यहाँ लीगल एडवाइस होना चाहिए जो डॉक्टरों को प्रोटेक्ट करे, अवेलेबल होना चाहिए, और आपके पास इतनी सिक्योरिटी होना चाहिए जिनको फिजिकली ट्रॉमा से भी बचा सके। सो ये भी पार्ट ऑफ स्टैंडर्ड है। तो हेल्थ केयर कमीशन का पार्ट सिर्फ पेशेंट को देखना नहीं है, बल्कि मेडिकल कम्युनिटी को भी देखना है। तो ये अब हो गया है, मैंने कहा शायद इट आंसर योर क्वेश्चन।
सर मैं
सॉरी, लॉयर होना, लीगल सपोर्ट कैसे प्रोवाइड करेंगे अगर लॉयर नहीं होगा तो वो अब हो रहा था ना अभी तक। अब जब किसी अस्पताल को अपने स्टैंडर्ड के साथ हमारे साथ सर्टिफाई करना होगा तो उसके लिए ये लायबिलिटी होगी कि वो ये चीज़ पैदा करे।
That is related to the witness of a doctor that is involved in a medical legal case, not in a proceeding whereby he is accused by himself. तो ये जो प्रॉब्लम डॉक्टर सादका रेस कर रही है, हर डॉक्टर का प्रॉब्लम है। दिस इज नॉट रिलेटेड टू हेल्थ केयर कमीशन, दिस इज रिलेटेड टू दी अवर लॉ, कि जहाँ पे हर डॉक्टर को अगर इससे मेडिकल लीगल कोई केस एग्जामिन कर लिया तो उसको कोर्ट ऑफ लॉ में जाना पड़ता है, उसको अपनी विटनेस देनी पड़ती है, उसको उस केस के बारे में बताना पड़ता है। दैट इज अ प्रॉब्लम, इज इंटायरली डिफरेंट फ्रॉम सिंध हेल्थ केयर कमीशन।
Yes, तो ये बिल्कुल अलग।
Dr. Hamid, I would like to just clarify for juniors here. You asked about negligence and complication, I think. So complication is something which is expected of, which is expected in medical procedure or as a side effect of some medication, whereas negligence would be where you are deviating from standard practicing. So if there is some negligence of the sort, the court will define that if there are 3 or 4 anesthesiologists, expert anesthesiologists, what would they do in such a situation? So if that particular anesthesiologist is deviating from the norm, then that would be negligence, I guess.
Yes, that's partly correct. Okay, so आवाज आ रही है? Okay, so जी डॉक्टर साहब।
I'm Dr. Shaida Khwaja from Lahore. Actually, I've got double responsibility as anesthesiologist, and at the same time, I'm chief executive of a private hospital which is about 250 bedded. I just want to say a few things about Health Care Commission, because we have been attached with this Health Care Commission in Punjab since 2010. And all the SOPs and guidelines, they were prepared by the senior most anesthesiologist of that time when it started. As you said that the societies should be involved. They didn't involve us as society, but as senior most anesthesiologists, they involved us, and the guidelines were prepared. The most important thing that Health Care Commission is doing in Punjab is that they are making healthcare establishment responsible for everything. Selection of the consultants, that is the responsibility of the hospital, because if the consultant is not capable of delivering a proper service to the patients, should not be allowed to work in that healthcare establishment. So consultant comes later on. The first thing that Healthcare Commission is going to punish, sorry, it's a wrong word, punish is that they involve in the inquiries or other things is the administration of the healthcare establishment. And I think they are right in this way. I'm not talking about the government hospitals, but in private sector. It's important to have properly trained people who should be following all the rules and regulations which have been made by the law enforcing agencies to be followed in these healthcare establishments. Because if we run, this is the difference between quackery and a professional institutions. So I just wanted to say these things, that in Punjab it has been enforced for the past almost now 12, 13 years. And they give scoring on all these things, and the most important thing is the documentation. Whether we are following all the protocols, they have to see that proper documentation has been done or not. And they have to visit a hospital thrice at the max to give maximum marks to the hospital to function. Otherwise, they can come and see in the hospital. Thank you.
Yes,
Okay, thank you so
I
much.
think whatever you have said, Punjab is doing since 2010, and we have started doing this from 2019. So the time lag for us is like just 4 years, we are in our infancy. But having said that, जो आपने बात कही है, वो तो बहुत हमारा simple process ही ये है कि when there's a healthcare establishment, it has to define its scope. What services will be delivered in this healthcare establishment? Second, based on the scope, what will be the HR required to conduct this scope? What will be the qualification of the HR to conduct this scope? Second, what will be the equipment to compatibly deliver healthcare according to the scope? Now, these are three things we just look at. This is a very important point. But having said that, madam, we are also talking about beyond Hyderabad. We are talking about Chhachro, we are talking about Mithi, we are talking about Nagar Parkar, we are talking about Umarkot. जब हम इस जगह की बात करते हैं तो ये चीज़ें थोड़ी सी ग्रे एरिया हो जाते हैं बहुत सारे. तो हमें उनको किस तरह से, लेकिन हम वहाँ हेल्थ केयर सर्विस को बंद नहीं कर सकते. आज वहाँ एक आदमी जिसने किसी 5 साल या 3 साल ट्रेनिंग करके एनेस्थीसिया दे रहा है, और अगर वो एनेस्थीसिया नहीं दे तो पेशेंट मर जाएंगे वहाँ. वो बहुत ज़रूरी है. पूरे सक्खर डिवीज़न में 5 क्वालिफाइड गायनेकोलॉजिस्ट हैं. अगर आज मैं क्वालिफिकेशन के बेस पर गायनेकोलॉजी प्रैक्टिस बंद कर दूं तो सक्खर में 5000 डिलीवरी महीने में कैसे होंगी? तो मतलब कहने का मतलब ये कि ये वो डायलेमा है. आप जिस जगह की बात कर रही हैं वो एक प्राइवेट टर्शरी केयर अच्छा स्टेट ऑफ द आर्ट हॉस्पिटल जिसकी आप बात कर रही हैं. दिस इज एन आइडियल सिचुएशन, बट व्हाट्स द रियलिटी? द रियलिटी इज वेरी वेरी मैं क्या बोलूं उस पर.
So in that case, if that is the reality, how do we bring them in the system in order to make health care available for those people where standard of care cannot be achieved? Sir, उनको क्या करें?
ये ग्रे एरिया, वाइट एरिया, ब्लैक एरिया की बात हो रही है.
सर ये तो पता नहीं कौन सा कलर है.
देखिए हमारे यहाँ तजाद बहुत ज़बरदस्त है, इसलिए कि यू बाई हेल्थ, तो उसके लिए प्राइवेट सेक्टर हॉस्पिटल है. उसके बाद सरकारी हॉस्पिटल जिसमें कि 2-4 वैरायटी है. बहरहाल हेल्थ केयर कमीशन बनाया इसीलिए गया था टू लुक आफ्टर द स्टेक होल्डर्स. स्टेक होल्डर्स मरीज़ की शक्ल में है, जिन पर ज़्यादती होती है तो वो ना होने पाए. हेल्थ केयर प्रोवाइडर जो मुख्तलिफ़ किस्म के हैं, डॉक्टर से लेकर के मुख्तलिफ, उन पर ज़्यादती ना होना पाए. और हेल्थ केयर इस्टेब्लिशमेंट है जो अस्पताल की तोड़ फोड़ होती है. और ये बहुत ही डिफ़िकल्ट एरिया है एट वन टाइम, क्योंकि जब ये मरीज़ हर किस्म के होते हैं और जब उसकी जेब से पैसा निकलता है तो उसको बहुत तकलीफ़ होती है. और जब उसका फ्री में इलाज होता है फिर भी कुछ मसले मसाइल में होते हैं. उसके बाद जैसे कि कभी ने बोला कि एक 5 स्टार हॉस्पिटल कराची में है, 4 स्टार 3 स्टार, उसके बाद 0/0 स्टार 200 मील दूर पर है. और वहाँ भी हमारा मरीज़ ऑपरेट हो रहा है. वहाँ टेक्नीशियन एनेस्थीसिया दे रहा है, स्पाइनल एनेस्थीसिया दे रहा है, और दूसरा डॉक्टर जो है MBBS, बैचलर इन साइंस एंड बैचलर इन मेडिसिन, वो सर्जरी कर रहा है. अगेन यू कांट डिनाई द फैक्ट तो इनका टास्क बहुत डिफिकल्ट है कि हाउ टू प्रोवाइड सर्विसेज टू द पेशेंट देयर एंड हाउ टू प्रोटेक्ट द राइट ऑफ द पेशेंट एंड द डॉक्टर एंड द एस्टेब्लिशमेंट। ये बहुत ही एक गंभीर हकीकत है और उसके लिए वो तो बहुत शुक्र अच्छी बात है कि हमारे मुल्क में अल्लाह ताला के बाद डॉक्टर होता है और मरीज़ 99.9% बहुत ही ग्रेटफुल होते हैं। और हमारे डॉक्टर ये बहुत ऊंची शय है, वो जब सब कुछ ठीक हुआ था तो कहता है कि मैंने किया, कुछ गड़बड़ हुआ थी कहता है अल्लाह ताला की मर्जी थी। तो बहरहाल तो वो एक बहुत बड़ा प्रोटेक्शन छतरी हमारे पास है कि हम ज़रा सा पासान उधर कर देते हैं, लेकिन हमेशा ऐसा नहीं होता, ख़ास के शहर में। इस वक्त मैं ख्याल में 300 केस उन्होंने बताया, 10-15 केस तो मुझे पता है जिसमें कि नेग्लिजेंस का एलिमेंट है नहीं है, आई डोंट नो, लेकिन यकीनन होगा। और नेग्लिजेंस बंदे की नेग्लिजेंस होती है, उस वो जगह वहाँ ऑक्सीजन ख़त्म हो गई अब एनेस्थीसिया मशीन में तो बेचारा एनेस्थेटिस्ट क्या कर लेगा। इस तरह से और भी बहुत सारी चीज़ें, ब्लड अवेलेबल नहीं, 5 ब्लड देने के बाद 6वां 7वां नहीं है, रिसिटा क्रीटा मर गई, वो भी मसला मौजूद है। इस किस्म की चीज़ें हैं जो कि मरीज़ बहुत ही सही कहता है कि उसके साथ ये ज़्यादती हुई। हेल्थ केयर कमीशन बड़ा अच्छा रूल है कि भाई आपको अगर ग्रीवेंसेस हैं किसी मरीज़ को, पहले वो अस्पताल के पास जाए, अगर वो मसले को हल नहीं करते हैं फिर वो हेल्थ केयर कमीशन के पास जाए, फिर वो मसला हल नहीं करते हैं देन ही गोज़ टू द कोर्ट। तो हेल्थ केयर कमीशन बहुत सारे मसले हल कर देता है, लेकिन यहाँ डायलेमा डिफरेंट किस्म का है और नेग्लिजेंस की बात हो रही है तो उसको डिफाइन करना क्यों हुआ, कैसे हुआ, एक डिफ़िकल्ट जॉब है, स्पेशली इन दिस ऑल दिस जोन्स, रेड, ब्लू, ग्रीन, ग्रे, आई डोंट नो। थैंक यू।
Dr. Robina, in all this discussion, there is I don't know whether it is a hardcore legal terminology or it is more of an ethical terminology. There's a duty to provide, and duty to provide all the facilities for the physicians to function in a safe environment is the responsibility of the institution, government, and there is some role of professional societies in that as well. So how do you see that happening in general?
बिस्मिल्लाहिर्रहमानिर्रहीम, अस्सलाम वालेकुम। एज अ एडमिनिस्ट्रेटर मैं ये कहूँगी कि हमारे पास जो एडमिनिस्ट्रेटर की रिस्पॉन्सिबिलिटी है वो ये है, जैसे आपने कहा कि हमारे पास OR में हर चीज़ हम प्रोवाइड करें। वहाँ पे अगर जितने भी इक्विपमेंट्स हैं तमाम फंक्शनल हों, पैरामेडिकल स्टाफ और टेक्नीशियंस तमाम वेल ट्रेंड हों, स्किल्ड हों। और इसके अलावा एनेस्थेटिक्स पे जो मैं बात करूँगी तो मैं ये समझती हूँ कि सिविल हॉस्पिटल कराची जो है वो तो नर्सरी है एनेस्थेटिक्स की। माशाल्लाह टीपू साहब ने जिस तरह से इसका आगाज़ किया और अब मैडम सफ़िया उसको संभाल रही हैं, तो पूरे सिंध में तमाम एनेस्थेटिक्स ट्रेंड होकर यहाँ से जाते हैं और फिर एज आ इंचार्ज, एज आ हेड ऑफ़ द डिपार्टमेंट हमारे पास जो भी एनेस्थीसिया को डील करते हैं ये उनका काम होता है कि किस केस के लिए उनको कैसा एनेस्थेटिक्स भेजना है। केस पर डिपेंड करता है कि उन्हें वेल ट्रेंड और कितना एक्सपीरियंस चाहिए, वो इस हिसाब से वो खुद मैनेज करते हैं। बाकी कहीं कोई कमी होती है तो उसको एज ए एडमिनिस्ट्रेटर हम प्रोवाइड करते हैं। और दूसरा, जहाँ तक मैं थोड़ा सा डॉक्टर सादका जाफरी के क्वेश्चन के रेफरेंस से बात करना चाहूँगी कि वहाँ पे जितने भी केसेस आते हैं, देखिए सिविल हॉस्पिटल कराची में 50 to 60 इलेक्टिव सर्जरीज डेली होती हैं और 25 के करीब हमारे पास इमरजेंसी सर्जरीज होती हैं, गायनीस के अलावा है। जब ये सारी सर्जरीज हो रही हैं और अल्हम्दुलिल्लाह पिछले 2 साल में मैंने ऐसा कोई केस नहीं देखा कि जिस पे किसी एनेस्थेटिस्ट को ब्लेम किया गया हो। और जहाँ तक ट्रॉमा सेंटर का ताल्लुक है, मैं समझती हूँ मेडिकल लीगल ऑफिसर जो है उसकी बहुत ज़िम्मेदारी है कि वो केस को किस तरह प्रेजेंट करता है। जब उसने वहाँ पे एग्जामिनेशन किया या जो भी उसकी रिपोर्ट उसने बनाई है, वो रिपोर्ट ऐसी होनी चाहिए कि फैक्ट्स की बुनियाद पे कि वो जो डॉक्टर या एनेस्थेटिस्ट को अगर उनका कोई कसूर नहीं है तो उनको सेव करे। और तमाम मेडिकल लीगल ऑफिसर्स पुलिस सर्जन कराची के अंडर में आते हैं, उनकी ज़िम्मेदारी होती है। और जहाँ तक डिपार्टमेंट का ताल्लुक है, हम पूरी कोशिश करते हैं कि अपने डॉक्टर्स को जिस तरह के लीगल मशवरे हम प्रोवाइड कर सकते हैं। हमने कई जगह बात की, अब जैसे कि सिविल हॉस्पिटल कराची जो है वो बोर्ड के अंडर में आता है, डाओ के बोर्ड के अंडर में आता है। हम बोर्ड में भी मैंने एक क्वेश्चन रेज़ किया कि हमारे पास जो हमारा लीगल डिपार्टमेंट हमने बनाए हुए MS लीगल, उसमें सिर्फ जो एक डॉक्टर होता है जिसने कभी LLB भी साथ में कर लिया, वो जाके केस प्रेजेंट करता है, लेकिन उसको इतने रूल्स का पता नहीं होता, इतना उसको कायदे कानून का इल्म नहीं होता। तो उसके लिए हमने उससे दरख्वास्त की कि हमको एक लॉयर दिया जाए, जिसके लिए माजरत कर ली गई क्योंकि हमारे पास अलहदा से कोई बजट नहीं है। हमने इसके लिए सेक्रेटरी हेल्थ से भी दरख्वास्त की, लेकिन कोई बजट नहीं है हमारे पास कि हम एक लॉयर हायर कर सकें। तो उसके लिए मैं समझती हूँ हेल्थ केयर कमीशन से ही दरख्वास्त करूँगी कि हमारी हेल्प करें, और एक लॉयर हर हॉस्पिटल को ये प्रोवाइड अगर कर दें, या कम से कम कुछ हॉस्पिटल जैसे टर्शियरी केयर हॉस्पिटल हमारे लिए या ट्रॉमा के लिए सर्विसेज है 3-4 हॉस्पिटल साथ में, अगर हमें प्रोवाइड कर दिया जाए तो उनकी बड़ी मेहरबानी होगी, और हमें डॉक्टर्स को बचाने में जिनकी गलती नहीं है मैं समझती हूँ कि बहुत मददगार साबित होंगे. थैंक यू.
Any questions from the audience? And then I'll wind up. Dr. Saida.
Sorry,
जी बताइए.
मैं ये कह रहा था कि ये डॉक्टर शाइस्ता के जो मसले हैं और जो नेग्लिजेंस के मसले हैं, गन शॉट वुंड्स के मसले हैं, तो मेडिकल सोसाइटीज़ को, एनेस्थेसिया सोसाइटी को ये रिकमेंड करना चाहिए कि इस लॉ में ये चेंज करें कि फर्स्ट अपीलेट अथॉरिटी हेल्थ केयर कमीशन को बना दें, ताकि उनके सामने हियरिंग हो जाए, वो फैक्ट जानते हों, और उसके बाद अगर कोई लीगल पॉइंट रेज होता है उनके ऑर्डर से, तो देन दे कैन गो टू द कोर्ट. तो एक तो कोर्ट से आप बच जाएंगे, एक वो डॉक्टर जो है जो जानता है कि क्या चीज़ है और वो फैसला दे सकेगा बग़ैर बायस्ड होने पे. तो आई थिंक कि ये अगर कर लिया जाए तो आपके मसाइल भी हल हो जाएंगे. पहले आपकी अपील जो है हेल्थ केयर उस कमीशन में सुनी जाएगी, वो शायद अभी कराची में ही है, और फीमेल डॉक्टर्स वहाँ प्रेजेंट भी हो सकेंगी कंफर्टेबली. तो ये कर दिया जाए तो बहुत फ़र्क पड़ जाएगा टू हैंडल द मेडिकल लीगल केस.
Thank you very much, Dr. Saida. And then last comment, and then we'll wind up.
हज़ारों ख्वाहिशें ऐसी कि हर ख्वाहिश पे दम निकले. Actually, the state of anesthesia presently, it is a healthcare emergency. We need to realize that it's a healthcare emergency. Patients are dying for no fault of their own, and the anesthetists are killing for no fault of their own. The hospital owners are just trying to, why are we talking about Chachro and Batani Bambor and all? We should talk about Malir and Korangi and the outskirts of Karachi. The inquiries that I have sat in, all of them, most of them belong to Karachi. And it is unbelievable that record ka to koi naam nishan khair hota hi nahi hai. And if you ask them, they say, हाँ वो तो हाँ नहीं लिखा, हाँ लिखा. I mean, we need a jolt. We need a jolt from this state that we are in. I think the Healthcare Commission can do it. If we take it up after this conference as a responsibility on our shoulders, I'm ready to take it. And I'm sure there are others sitting here who will do it. That we have to, some basic minimum, as he said, कि हमारे आधे से ज़्यादा सेटअप्स बंद हो जाएंगे अगर हम ये कहें कि वहाँ पे सिर्फ क्वालिफाइड एनेस्थेसियोलॉजिस्ट जाएगा. ये नहीं हो सकता, हमारे पास नहीं है इतने क्वालिफाइड. मगर हम ये ज़रूर कर सकते हैं कि हम कुछ लोगों को सेफ एनेस्थीसिया प्रोवाइडर ट्रेनिंग दे दें और फिर उनको लिमिट करें किसी तरह. उनके ऊपर ये लिमिट लगाएं कि नहीं वो ये कर सकते हैं और वो ये नहीं कर सकते. I think हमको थोड़ा सा ब्लेम अपने ऊपर लेना पड़ेगा कि हम लोग we just discuss it. I'm glad we have taken this up as a over there also is just written medical legal implication. What about that heartache that is caused to the patient's family? That could have been my relative, and even if it is not my relative, why should it be caused to anybody?
Exactly. Why should anybody suffer? Last comment, and then we'll on.
With the current experience that I'm having in UK, it reminds me of a song, an old song, some people may have heard about it. Sorry seems to be the hardest word. Those are the lyrics of the song. And it's mandatory upon us to say sorry to the patient when something goes wrong and document that in the patient's notes, and also write to the patient in the form of an official letter that this is what, for example, if a tooth gets damaged during intubation, we go and say sorry afterwards that this happened and it could have been prevented, but we tried our best to prevent the damage, and then we have to write to them as well. So that is one thing. Now this system has effectively shown, and there is ample evidence to say, that because of the saying sorry to the patient, the level of litigation has gone down. The patient calms down and they don't even think of going to the lawyer. That's one thing. The second point, I'm not aware what the practice is here, is protocols and guidelines. when hospitals and institutions have policies, protocols and guidelines, and if they have been followed effectively by the treating team, then the chances of litigation or effective litigation against the hospital or the doctor is reduced.
Thank you. 1 minute. हाँ बस
डॉक्टर शब्द जमानी फ्रॉम मेडिकल हॉस्पिटल। बात यह है कि डॉक्टर सैदा ने कहा कि हमें ब्लेम लेना पड़ेगा अपने ऊपर किसी न किसी सूरत में। सबसे बड़ा मसला ये है हमारे यहाँ कि हम लोग पेशेंट को फ्री ऑफ असेस नहीं करते हैं। आप प्राइवेट हॉस्पिटल चले जाइए किसी भी, बहुत कम आपको मिलेगा कि एनेस्थेसिस्ट ने पेशेंट को पहले देखा हो, और पहली मुलाकात जो पेशेंट की होती है एनेस्थेसिस्ट वो ऑपरेटिंग रूम के अंदर होती है, और आखिरी मुलाकात भी ऐसे ही। तो अगर हम लोग फ्री ऑफ असेसमेंट को अगर की बना लें, प्रॉब्ली दैट इज लाइफ टाइम।
Right, thank you very much.
I know in the periphery what happens. There are so many unqualified anesthesiologists, despite of the fact that qualified anesthesiologists are there. They are not being called. They are because of some money reasons. So I think there should be some Google mapping for that. Who is living there? Who could be reached? And the hospital should be asked why did you call the qualified despite of the fact they are there. So this is a very important thing. I know that this is going on. I know the hardcore, the reality of the area. That's what I want to make my small input.
So thank you very much. So
डॉक्टर हमीद एक लास्ट डॉक्टर हमीद मैं यहाँ से लास्ट एक वो है कि नेग्लिजेंस की डेफिनेशन कि नेग्लिजेंस इज समथिंग इफ इट इज रॉन्ग और सम क्वालिफाइड पर्सन इज डूइंग रॉन्ग. If some unqualified person is doing something wrong, that's negligence or it's a criminal act.
Yeah, exactly. That is negligence. That is negligence. If you are not allowed to do something, even you do it right, nobody catches you. But if you do it wrong, that's negligence. Okay, so the little literature that I have read on this subject, I'm not talking about the detail. The role of societies, professional organizations is very important in this area. जैसे डॉक्टर सईदा ने कहा कि हमें कुछ जिम्मेदारी लेनी होगी, हमें ब्लेम भी लेना होगा और हमें जिम्मेदारी भी लेनी होगी. So unless we put our foot down, come up, partner with Sindh Healthcare Commission, whoever, अस्पताल के मालकान, अपने कॉलीग्स को जहाँ मैंने सीधा पढ़ाते हैं वहाँ मैंने ये भी पढ़ाएं, कंसेंट तरीके से लेना है, रिस्क मैनेजमेंट करनी है, तो probably ये चीज़ें आगे जाना शुरू होंगी. With this, I thank you all the worthy panelists for this useful contribution, and I would like to invite Dr. Shahida Khaja for distribution of certificates. Thank you. Okay. Professor Naveed Masood. Professor Naveed Masood, Professor Amjad Ali, Professor Shahab Naqvi, Professor Tipu Sultan, Dr. Ehsan Siddiqui, Justice Athar Saeed, and Dr. Rubina Bashir.
I would request Dr. Hamidullah to please collect his certificate from Dr. Shahida Khwaja. Thank you everyone for your attention and participation.
Assalamu alaikum everyone, and a very warm welcome to the third session of the 41st PSA annual conference, in which we will be having an insight on the emerging trends in anesthesia. I'm Dr. Sidra Nazir, final year anesthesia resident in AKUH. I'll be moderator for this session. Without any further delays, I would like to call upon the chairpersons for this session. First, I would like to call Dr. Shaida Khwaja to please head on to the stage. Dr. Shaida is a professor, chairperson, Call Associates, Department of Anesthesia, Critical Care and Pain Management at National Hospital and Medical Center, DHA Lahore. She is a retired professor from Allama Iqbal Medical College, Jinnah Hospital, Lahore. She is among the pioneers in starting epidural services for obstetric analgesia in Lahore in 1986. She has special interest in propagation of standardized anesthesia care, safety of patients, and handling of patients with affectionate manner. Next up, I would request Dr. Nasreen Laik to please get onto the stage. Dr. Nasreen is a professor, head of the department and chairperson of Anesthesia and Medical Training Institute, Lady Reading Hospital from 2016 till date. She is appointed as the supervisor cardiothoracic anesthesia in 2014. She has done thousands of cardiac open heart surgeries, vascular surgeries, and closed heart surgeries in the only public sector cardiac hospital in KPK. She has trained hundreds of trainees in the field of anesthesia. She has managed and treated acute and chronic pain patients in Lahore. She has done a lot of research work and has 30 publications in HEC, PMC, and impact factor journals to her credit. Professor Nasreen is also current president of Pakistan Society of Anesthesiology. Now I would hand over the floor to both the esteemed ladies.
Thank you so much. The first speaker of the session is Dr. Ehsan Wakar. He is from Shaukat Khana Memorial Hospital. His designation is Consultant in Anesthesia and Critical Care, Associate Medical Director, Oncology Services. Present place of work is Shaukat Khana Memorial Cancer Hospital and Research Center. Working experience is received specialty training from BARTS and the London School of Anesthesia. Remained head of the Department of Anesthesia for 7 years before taking up other administrative responsibilities. Academic record as researcher and clinician. Research experience started at William Harvey Institute, London. He has been successful in publishing over 20 projects in peer-reviewed journals. So he's going to talk about his favorite topic, which he's going to tell us. Thank you.
Assalamu alaikum. So I thank the organizers for giving me an opportunity to speak on this topic, because this is something which is very close to my heart and something that I've been at least trying in my own capacity to try and show that colleagues in the department and everywhere else do have an idea about this. So we are going to talk about human factors in anesthesia safety. This is where I work. So this is what the problem looks like. It's an iceberg. We think we know about this problem. We don't really. The problem is much deeper than we think. And in the next 15 minutes, we're going to explore how to go about this. I do not have any conflict of interest. I'll start off with a story. So this is a 61-year-old female. She's a consultant radiographer by profession. In UK, you do have radiographers as consultants. So she was for abdominal pain. She was going to have a laparoscopic appendectomy. The nurse practitioner starts off by intubating her. She could not. The consultant anesthetist was asked to take over, who then goes on to intubate esophagus. Patient arrested. Cardiac arrest team came in. 15 minutes into the cardiac arrest, they realized that the tube was actually in the esophagus. 5 days later, this patient dies because of hypoxic brain. So what the coroner found out was very interesting, 5, 6 extremely pertinent observations. One, there was a fixation on anaphylaxis. The consultant anesthetist is extremely experienced, very well accomplished person, got fixated that this is anaphylaxis. Completely forgot that this could be esophageal intubation. Inside the theater, there seemed to be a hierarchical structure where the juniors or other colleagues were not easily allowed to speak under the circumstances. Despite the fact that the coroner thought that this consultant anesthetist was very mild-mannered, gentle, and a reflective witness. But still, this mild-mannered, gentle, and reflective witness did not have that culture in the theater for others to speak up. There was panic and chaos in the anesthetic room. Whenever there is panic and chaos, order would be compromised. And whenever there is order compromised, small things would get missed. And then there was a failure to confirm tracheal intubation. The simple things, the end-tidal carbon dioxide, bilateral chest auscultation, nothing was done. It was considered that it has to be in the trachea. One very interesting thing was variable configurations of waveforms in the anesthetic room. So I remember very precisely in 2002 February when I started as a senior house officer in Cardiff, the first thing that fascinated me in the anesthetic rooms was these lovely monitors. And these lovely monitors had beautiful waveforms, and these waveforms had beautiful colors to them. And every theater had a different waveform and a different color. And I was told at that time that every consultant anesthetist likes to have their own colors, have their own configuration systems. So at that time, I was very impressed. 21 years down the line, we learned that that is exactly wrong. It should be uniform, because what happened was that the respiratory waveform was actually thought to be the end-tidal carbon dioxide by the consultant anesthetist. So it has to be uniform. So, as Mark Antony said, friends, Romans, countrymen, lend me your ears. These are the human factors that have contributed to the tragedy. If these human factors were controlled or controlled in a better manner, hopefully this tragedy would not have taken place. So this was something that was recognized in the 1950s and 60s. This is not a new concept, that 65 to 87% of anesthesia-related deaths were due to human errors. Out of those, 7.5% reported were due to gross anesthetic mismanagement. This was recognized way back. And what are the timelines? If you look at this 70-year-old journey, so this is the initial most evidence started to come to us in 1950s and 60s. Probably the watershed moment is the Bromley case in 2005. 2 consultant anesthetists, 1 ENT consultant, all got fixated on intubating the patient, forgot that this patient needed to be oxygenated first. Patient died. A 30-year-old girl came for a minor ENT procedure. Her husband happened to be somebody in aviation, Martin Bromley. And Martin Bromley took it upon himself, he took it as a challenge, and he kept on investigating and he kept on pressing the hospital administration to find out the actual reasons why this happened. And that is how, and this is the same sort of a time where University of Aberdeen published their anesthesia non-technical skills article. And both married together and formed a perfect partnership, and people realized that the human factors and the anesthesia non-technical skills are important for us. In 2011, the same chap, Martin Bromley, formed this group, Human Factor Group. So he founded an organization and termed it Human Factor Group, and he said that this is something that is going to improve anesthesia safety. And then other evidence started to come in. Till the time, Simon Stacey and his team have come up with those 2022 DAS guidelines. And this is the latest, and we'll talk about it right at the end. So what we want to do is to minimize risk. We want to manage risk. In order to manage risk, we have to think about the human factors that are involved in all this. So the actual control model has a design, a barrier, mitigation, education, and training. There is a huge difference between what is the actual ideal situation and what is the actual situation on the ground. Somebody from Healthcare Commission was here who was talking about that laws we have do not have anything to do with the real life. And that is what the situation here is as well. So if you look at this, the design part is the most important part. That has the broadest base available to us. But that is the most effective part. Moving on to the barriers, the mitigations, and the education and training is right at the top and is the smallest part of this hierarchy. But that is the least effective of that. What have we done? So this is the ideal. What have we done? We've flipped it. Whenever we talk about a disaster, whenever we talk about a tragedy, we think that the design is the least important bit, very small bit, going on to the barriers, the mitigations, and education and training of the individual still remains the major focus that we have. That less educate the individual, less talk about the individual, but we don't talk about the designs, we don't talk about the organizational issues that exist. So anesthesia non-technical skills, this is something that we've been teaching in our department for 7-8 years. Dr. Saad, who is responsible for our educational training in the department, he always allocates me the ANTS topic. So there are more than 76 tools available for assessment when it comes to the human factors. We always considered, used to consider before I approached this, that ANTS is the most important part of non-technical skills. But life has moved on beyond ANTS. We have people who still have not really overcome the barrier of ANTS. But the people have moved on even beyond ANTS. People are talking about all these factors that combine to form human factors. So this is the ANTS bit, the task management, the team working, situational awareness, and decision making. So we talk about this, we should be talking about in the debriefings every morning. We should be talking about this at the debriefing at the end of our list. This is what we should be talking about. This comprises the ANTS. The decision making, this is a tool directly taken from aviation industry. Anesthesia has not come up with this tool. Aviation industry has been using this tool since 1980s. And this is what Martin Bromlett said, that this is what we should be employing. That there is a problem, how do we approach it? So what is the diagnosis? So he said DODAR. DODAR is the acronym for this. So what is the diagnosis? What is the problem? So let's define the problem. So very clearly definition of the problem. Then what are the options? The options available are that certain actions that we are going to take that would have some benefits. They would have some risks. There are alternatives available to our action and the implications of doing nothing. Let's not do anything, let's just wait. So all these things are part of the options that you have. You have to employ this option. And then you have to decide, what are we going to do? You must decide. Not deciding is not an option here. So the decision has to be clear. And once the decision has been made, you assign tasks. You do this, let's go on with it. And then the review. Once you've decided that I'm going to avail option A, that still doesn't mean that you're not going to review your original decision. You still need to review that. Moving on to the team strategies. So this consultant walks into the anesthetic room or the operating room, whether this is an anesthetic consultant or a surgical consultant, huge stature. So as soon as this person walks in, everybody says, oh, sir aa gaye, madam aa gaye, khamosh ho jaye, khamosh ho jaye. So nobody's talking now, everybody's quiet, everybody's looking at this huge stature person. Now this is not going to help mitigate risk. This is not going to help the situation. Civility saves lives. It is the civilization amongst how we behave with each other and how we behave with our seniors, with our colleagues, with our juniors, that is going to improve patient safety inside the operating room. So the team members, what is my responsibility as a team member? It is my responsibility to keep my skills up to date. Yes, hospital is responsible for training me, but then I need to realize that this is something that I'm lacking, this is my weakness, I need to overcome my weakness. Then I need to cooperate with my team. As I said, the seniors, the juniors, the colleagues, everybody needs to work in sync. And then verbalize. So we all know what is closed loop communication. This is how we need to talk to people. And then the halt. So if you're hungry, you're angry, you're late, you're tired, halt, just stop. It's 4 a.m. in the morning, you're all four. You're hungry, you're angry, you're tired, you're late. And is it really necessary to do what you are trying to do here? Just stop, just think about it. Start thinking. And this is how you're going to optimize your personal performance. What do the team leaders do? They need to know their team. They need to analyze their team. Start taking pressure on, as a team leader, start taking some pressure. And this helps the team perform better. Kitna time lagta? Sorry? 12 minutes ho gaye. Oops, sorry. Okay. Okay. And the team members, remember, any team is as good as its weakest link. So think about the team. Think about the weakest part of your team, because that is what you need to work upon. So what are the strategies? This is how communication works. Probably the Pakistani model is a bit different, but if you're not speaking, you're still communicating. If you're thinking of speaking, you're still communicating. And when you are actually speaking, which we all perceive as communication, use some objective tools. And if you're not speaking, think about the nonverbal cues. Then we think about the practical strategies. If something is going wrong, box breathing. So take big breaths. The idea is you reduce your sympathetic stimulation, and this allows you to objectively focus on things. Then there is a mental rehearsal, task visualization. Think about them, think. And there is a mental model. Before you go into a task, think how you're going to do it. This is an important slide. So something is going wrong. Example is difficult intubation. Inside theater, what do? You assert yourself. You don't want to say Maula Jat style, make a sab thair jao. Like at the same time, there is this tool available to you where you first say, I'm concerned that you're again and again trying to intubate this patient. Remember DAS guidelines, after 2 intubations, move on. This patient is not moving on. So then you say, I'm uncomfortable that you're still trying to intubate. And then you move on to say, okay, does not feel safe to me, this is unsafe, think what you're doing. And then you say, I'm asking you to stop. So this is the graded tool of assertiveness. We want to mitigate. There is a death in the theater, so what do? How do we investigate? We employ human factors. We employ human factors to investigate what went wrong. And this is how all the critical events need to be investigated. Royal College of Anaesthetists says, whenever there is harm to the patient, don't do operation in that, or at least that team should not be involved in another operation on the same day, if at all possible. Obviously, with staffing levels that we have, this may be too rich for us. This is another tool that UK has. This is developed by their armored forces. This is how they investigate their trauma deaths. This is important. This is important that between 2015 and 22, 60% of the events, the never events, actually happen in operation theaters. So what this tells us that the operation theater has a huge potential where something can go wrong. And this is one tool that can be used to analyze things. You want to analyze outcomes, you want to think about your work systems and then your processes. Only then you come to the outcomes. Think about simulation. Okay. Level of stress, something that we don't really talk about. Stress increases up to an optimal level. You're in the zone of flow, where you can still function. Stress increases further, you're in the zone of frazzle, your structure starts to crumble. And then comes the zone of freeze, where you stop functioning. As the level of stress goes this way, you stop functioning. So what do we do if that happens? Call for help. Reevaluate what you're doing, regain self-composure, and regain situational control. In the end, it is the 12 recommendations that has been given by the 2022 DAS guidelines. So what they talk about is design. What they're saying is that while you're buying medical equipment, think about human factors. While you're thinking about drug ampules and packaging, think about human factors. Involve human factors and experts early. Safe working environment. Ask the human factor people who are experts in this to come and examine your work environment and see where the chinks in the armor are. Remove the barriers. So the operating theater lists 2 types. One, complex surgery. The other one is too many surgeries. Both need specialized Both need different set of problems. So allocate resources accordingly. Then the cognitive skills. We've already talked about develop guidelines, develop policies, develop these checklists, algorithms, and then the non-technical skills. If there is an adverse event, think how you're going to investigate it. Investigate it through the eyes of the human factors. The organizational strategies to improve staff well-being. Think about staff well-being. Appoint a human factor lead in Department of Anesthesia. This is the recommendation that has come from 2022 guidelines. We never thought that we should have a human factor lead in our departments, but this is what has been recommended. The same goes for patient safety leads in each hospital. In the end, again, the problem is much deeper than we think. At the top, we only see the tip of the iceberg. Thank you very much.
Thank you, Ehsan. Our next speaker is Professor Sadka Aftab. Dr. Sadka Aftab presently working as Professor of Anesthesiology and ICU at SMBB-IT Karachi. She started post-graduation program for FCPS and MCPS in 2019 at SMBB-IT. She is chairperson of postgraduate committee at the same hospital, ex-chairperson and professor DUHS, started cardiac anesthesia in 2000 in Civil Hospital, Karachi. She is examiner and paper setter for IMM, FCPS, MCPS at CPSP.
Thank you. My topic is competency-based medical education. How to ensure in anesthesia training and local perspective. What is competency-based medical education? The core component include out-based approach and workplace-based training, skill and the knowledge. Individualized, integrated, learner center and time independent. आवाज़ नहीं आ रही? टाइम नहीं काउंट करना. So, and these are the components of competency-based medical education. All right? It's not coming. Basically, it is workplace training, provide skill and knowledge. क्या हो गया? क्या करें? इसे कोरिलेट नहीं कर रहा. ये कौन सा है? ये वाला, ऊपर वाला, ये वाला. अच्छा. So the component of competency-based medical education include workplace training and knowledge. An outcome-based approach, integrated, individualized, learner-centered, and time-independent. There is a model, I think we have got a one. Sorry. The basic difference between the traditional medical education. It is teacher-centered, and this is learner-centered in the competency medical education. It is time-based, and it emphasizes on the ability of assessment throughout posting. Summative assessment is there because it involves supervisor only, and formative assessment involves focus on outcome. And there is no feedback in traditional medical, but in case of competency, feedback is a process of training. Only knowledge is acquired in a traditional medical education, but in competency-based, apart from knowledge, there is soft skill, teamwork, communication, behavior. And the topic is only taught in the class, in the traditional. But in this case, teacher only facilitate. So curriculum drives it in traditional medical, while it drives the curriculum. There is 7-20-10 model. 10% is only read, but 20% is what is heard, and 70% involves the heard, seen, and done. That is, participate in the workplace. There are three components of this competency-based medical education: competency, milestone, and interstitial for professional activity. Competency basically involves patient care, system-based practice, professionalism, communication, practice-based, and medical knowledge. The milestone, when the candidate has got only knowledge, it observes. But when it knows how much regarding then direct supervision, it is performed. Then indirect supervision, independent unsupervised, and then in the level 5, then it learns to perform and assist other persons. So the interstitial professional activity involves knowledge, skill, and attitude. The stages of learning: active learning, discussion groups, team-based, and case studies, problem-based learning, role-playing, focus on cognitive psychometer, long learn, and teaching methods are much advanced, that is e-learning and communication technology. Simulation skills should be there, and classroom, lecture, hand experience, and also the apart from bedside, community-based research should be there. The assessment is being done on work based by the observation and the verbal feedback. Assessment involves standard of quality. Qualitative approach is judgment, feedback, and documented. So there is actually involvement of a trainee in this system. So the assessment is being done when the candidate has got only knowledge by written test, and then later on by the case presentation, then OSCE and observation, work-based assessment is being done. Now professional is also included in this system. That includes initially only related to knowledge, later apply knowledge, and then on skill and behavior, and then clinical setting, and then again later stage when it is performing independently, teaching the other persons. In India, they implemented this competency-based in undergraduate, and that is being assessed by the feedback, by the changing to the submitted assessment, that is individual supervisor, change to the outcome. Self-assessment, work-based assessment was done. Now the question is that how to ensure in anesthesia training. There's a debate who people to deliver, how process should be done, what technology should involve. So first thing is that faculty should be developed. And also the curriculum should be established and that should be reviewed again. Implementation of faculty development should involve knowledge, skills, and monitoring evaluation of faculty by training, feedback, and ongoing improvement. So this process in the anesthesia, we need to teach, assess, provide feedback to residents. The traditional teaching in anesthesia involves fixed duration, does not directly measure the skills. But in competency-based medical education, there is a direct demonstration of independent practice. Supervisor or mentor should be present in OR and calibrated to level of training experience, independent of fixed training period, and resource time should be includes digital and simulation skill. And there was an article in which they prepare anesthesiology faculty for the competency-based medical education, and they conclude that faculty should be developed and it should be monitored and it should have got teaching assessment by ground rounds and all this. The advantage of faculty development is that it promotes just changes in behavior, attitudes, and also increase motivation for teaching, develop knowledge, skill, regard to the teaching assessment strategies, and inter-reliability assessment. So it has very advantages. Regarding another article, History and Challenges, they say that we have to design a curriculum and it has to be in depth and they should develop trained observers, resident progress, and logistic challenge for catering management of program directors. And residents should achieve early expert status. Another article, they conclude that we need to collaborative approach to create evidence required to implement competency-based medical education wisely, cost-effectively, and to have positive impact on patient, trainee, healthcare system. So the 6 domains are there if we are implementing in anesthesia training. That is patient care, that includes perioperative monitor, regional crisis, ICU, medical knowledge, basic knowledge, and system-based practice, practice based on learning improvement, professional and intercommunication skills. This is another article which compare where they implement the competency base in the Europe and USA and Canada, and they found that 93% of competency were common. The only difference was that in urine, non-technical skill was there, and in Canada there was specific anesthesiology. In the USA, they have got professional and behavior practice as well. So competency-based training in anesthesia has it delivered on promise of better education. More work is needed to build an early success and to determine whether this can produce more competent anesthesiology, benefit patient and society. Now, regarding local perspective in training in Pakistan, after Teaching Institute is being aggregated by the CPSP, they required to have a program director, faculty, support staff, and maintains high training standing. That includes up-to-date curricula that it should be regular review, state-of-art teaching, training program. Trainer should be allowed to perform procedure independently under supervision of supervisor. Now, the competency-based assessment is being done include a feedback and an audit. That is, initially when the candidate has got a knowledge, that is by written test, theory exam, problem-based questions. Later on, when it starts to perform, then by the objective structured clinical practical examination, mini clinical evaluation, direct observation of procedure skill, work-based assessment should be done. Challenges in implementation in anesthesia training is that we have got a lack of support from administration, absence of a vision and resistance to change and plan to bring reform in curricular delivery. Infrastructure, learning resources are not available, untrained teaching staff is there, poor coordination between undergraduate and postgraduate curriculum. No comprehensive plan is there to streamline the candidate assessment. Faculty members are also resistant and reluctant to changing and expanding role with introduction of competency-based medical education. Lack of incentive is not available for the faculty. Formation of milestone and lack of time is one of the factors among the faculty. Lack of clarity about faculty and the postgraduates, no involvement in formation, no guideline assessment for anticipated professional activities there. No guideline from regulatory body for mandatory implementation, financial support, cost of design, development, implementation of faculty development activity is not there. So to summarize, community-based medical curriculum approaches the responsibility of training program in anesthesiology to train capable specialists able to practice independently. Competency-based medical education requires changes in the way medical education is delivered. Training standards include up-to-date curricula with regular review, a state-of-art teaching and learning method and robust assessment strategies should be there. Revolutionize approach to training by making expectations more concrete, visible, and relevant for trainee. Faculty will need to acquire new skills in teaching and assessment in order to navigate the transition. Such competencies are structured to graduate anesthesiologists with the competency to ensure safe and effective anesthesiology practice and according to the need of society and the patient. Any question? I did the short presentation. Actually, we are having problem from administration. They want start MS, MD program. We are only involved in FCPS, and I think how can we develop curricula, how we can bring these MS, MD equal to the FCPS. And some specialties being exempted part 1 by CPSP. Actually, they don't recognize MSMD in the Middle East. Nowhere it is recognized. So they think that it will stay in Pakistan.
Another thing is they are going to start in super specialities as well, in pediatrics and critical care and cardiothoracic. So if you want to, we need to do something about it. Either we close them or we must get them recognized. Because those children, we are getting children. In every induction, there are 2 or 3 MS students who are coming for training. So either we should collectively decide what to do with that, or so that the students should not, or those students who have done it, so it's not their fault. So they should either they should get recognized or we should do something.
I think we'll go into this discussion at the end of the session because we are already running late. So all the speakers are requested to please wind up their presentation in the shortest possible time. Thank you so much.
Okay. Thank you, Sadka. Our next speaker is Dr. Asma Abdul Salam. She is General Secretary, Pakistan Society of Anesthesiologists, Karachi chapter. Program Director Anesthesia at Ziauddin Hospital, Karachi. Pioneer in anesthesia postgraduate training program, including academic sessions, workshops, and CMEs. She has special interest in chronic and acute pain management, Established first pain management services at Ziauddin Hospital, Karachi. Director, Karachi, basic courses for nurses and doctors, and conducted more than 20 courses across Sindh during COVID pandemic. She is director and organizer of many courses and workshops on pain management.
Thank you so much, ma'am, for my introduction, and I will try to be as quick as possible. So the topic today is integrative pain care and what the hype is all about. So before I start my presentation, I have nothing to disclose, or there is no conflict of interest to declare. So what basically is integrative pain care? Is it non-invasive pain management technique? Is it non-pharmacological pain management strategies? Or is it alternative to opioid? That's a big question which arises when we hear about integrative pain care. So basically, complementary and the alternative medicine, these are the terms which are used for medical treatments which are not part of the usual medical care given by the licensed healthcare professionals. But otherwise, complementary medicine is a medicine which accompanies the standard medical treatments, and alternative treatments or the medicine is a substitution of something in place of usual medical treatment. And when we combine the complementary and alternative medicine all together, that's called integrative pain care, which is used as a part of the total care approach along with the standard medical practices. So most of our faculty are also the member of International Association for the Study of Pain, and according to this IASP, it defines the integrative pain care as a temporally coordinated, mechanism-guided, individualized, evidence-based care with the integration of multiple pain treatments interventions. So basically it is a customized care, as everything is going towards the customized care of the patients. So it is the patient-centered model. So when we see in our chronic pain clinics, we see most of the patients where they come in with multiple comorbidities, and associated with chronic pain are anxiety, depression, insomnia, fatigue, which are also barriers to the management of pain. And we look at the pain, whether it is acute or chronic, it is a multifactorial condition which has biological, social, psychosocial, and social contributors. How much each domain contributes to a particular patient's pain, it varies from one patient to another and over a period of time as well. So chronic pain, as I said, is also required integrated, multimodal, and interdisciplinary treatment, all components of which should be evidence-based. Considering the overgrowing burden of the chronic pain, it is also clear that the current models of the care used for managing and treating pain are ineffective in addressing the clinical problem, especially when we have to deal with severe chronic pains in which we have to also use opioids. Opioids as a primary method for chronic pain control has resulted in negative and suboptimal pain management practices. So IASP as the global year, this year 2023, in the light of the opioid crisis that has affected people in many countries, got up with the aim of this year's campaign to increase the awareness of clinicians, scientists, and also patients about the use of an integrative pain care approach, which emphasizes on the non-drug self-management care. So where it all started? It basically started back in 2015 when NIH, which is National Institute of Health in America, they conducted a survey in which 92 million US adults were found to be prescribed of opioids, and out of those 11.5 million adults, they misused those opioids. And in those stats, along with the growing epidemic of the overdose deaths because of the legal or the illegal use of opioids, it prompted some of the most prominent medical organizations of the America, like American Society of Physicians and also Center of Disease Control and Prevention, which we all know as CDC now. They supported the greater use of non-pharmacological therapies for chronic pain, moving away from opioids as a first line of defense. And they also started this HEAL initiative, even though the integrative pain care treatment, it starts back to early 2000s, where the Academic Consortium for Integrative Medicine and Health was held, and after which almost 70 academic institutions, they joined the consortium. So in 2018, it again resurfaced, and the Joint Commission revised the pain standards, and that's how we are now using integrative pain care, and we are talking more about integrative pain care. So just a quick review of the pain pathology for my junior colleagues, that as we know that the pain starts from the transduction, where any noxious stimulus, it hits the receptor, and then transmission and modulation and perception, they occur. So when we talk about the at the nociceptor level, where the modulation of the nociceptor activation following tissue injury inflammation occurs, the modes of integrative pain care which affects that point is cupping, acupuncture, massage, herbal medicine, and inflammatory diet and fasting. However, when we talk about the transmission process, there the modulation of the neuroplasticity and inhibition of the interneurons occurs in the spinal cord. There cupping, acupuncture, acupressure, and massage again occurs. But when we talk about the up in the perception and the modulation in the brain as well, the modulation of the cognitive, affective, and emotional evaluation of pain. At that point, mind-body techniques such as relaxation, yoga, tai chi, and other kinds of massage, they act at that level, as well as acupuncture also acts at the release of the endogenous agents such as opioids and derivative neuropathic factors and the cannabinoids in the brain. I'm sorry, I can't see it over here. So that's how it has been categorized mainly into 4 types. And if we talk about those types, mainly they are mind, body, brain, and then there, if I say it's the naturopathic, and then manipulative and body-based therapies, and lastly it's written natural products, but I'm sorry, it's not that apparent here. And these are the pictures which have been shown. I've just attached them for your interest. So most of the recommendations of the integrative pain care, they start with education and reassurance of the patient. And then patients, you have to notify their activity in the absence of the red flags. It should be individualized, comprehensive approach, which should be evidence-based. And after that, the type and intensity of the treatment should be determined using clinical presentation of the patients and patient preferences, along with their comorbidities and available screening tools, whichever are available with you. So with that, there are interprofessional communication and coordination is a must in this approach. Along with that, regular evaluation at regular intervals of time is also very important. So this was a quick review from another source. And if you see this diagram, it shows it is the core of integrative pain care. So what exactly is integrative pain care? So actually there are 6 A's. In 6 A's, you have to assess, you have to advise, you have to acknowledge, you have to check the activate, you have to allow your patients, and then you have to ally with your colleagues. And among them, the best modality which comes, one of the modality which comes is behavioral and the psychological approaches, which includes cognitive behavioral therapy, MBSR, biofeedback, hypnosis, psychological, spiritual support, and group medical visits. And then the physical modalities includes massage, manual therapy, manipulation, tai chi, yoga, and group exercises. Then the biological therapies, they include different natural products, which includes alpha-lipoic acid, coenzyme Q10A, which is antioxidant, and which also reduces the nutritional deficiencies and also decreases the stress responses. Then there comes omega-3, curcumin, melatonin, which acts on the intrinsic central antinociceptive part of the brain and also modulates the pain signals. That's how the pain has been reduced. Then there are other modality as well, which is also known as biostimulation therapies, which includes repetitive transcranial magnetic stimulation, transcranial direct current stimulation, which is written here as DCS, supraorbital stimulation, auricular nerve conduction, or TENS, which we commonly use in chronic pain. All of these enhances the brain metabolic activities, thus decreasing the pain modalities. So this was another article, this was an article which was published in 2017, and they had included pharmacological and interventional therapies as well. But ISP has excluded the pharmacological technique because they wanted to go opioid free. And that's why I have just, encircled it in red. Even though NSAIDs is also prescribed in that regime of multimodal analgesia, but even though NSAIDs and the other medicines are not addictive, NSAIDs, they usually cause other side effects like GI bleeding and, acidity, and there are other adverse effects associated with them. So is there any advantage of this integrative pain care? Yes, it decreases the pain severity, it decreases the cost of hospitalization, it decreases opioid consumption, and obviously there are no major side effects associated with it. But yes, there are challenges which are associated with them, that patients, they have high expectations of complete pain relief in the minimal time, minimal cost, and minimum effort. And along with that, the patients, they also become anxious that that's not maybe the right treatment they are being given. And at the clinicians and the patient satisfaction to achieve with the time constraint is very important, which one might lack in achieving. Along with that, education is most important. So what exactly is the situation of Pakistan when we talk about integrative pain care? Complementary and integrative therapies, they have existed in some form or another for hundreds and hundreds of years in Pakistan in the form of herbalists, Unani medicine, bone setters, and I've heard recently a name known as Kumhars. So they all do these kind of pain treatments. But there are no formal watchdog bodies and agencies or audit commissions to set up to monitor the quality of the healthcare which has been delivered to the patients in the form of these herbalists and other medications, and also there is a lack of research. So with this, I come to the end of my presentation with the quote by Victoria Mays, who actually started integrative pain care, that we have to train the health professionals about all the other ways in which their patients might manage pain differently. So that's the hype, and that's all about integrative pain care. Thank you.
Thank you, Asma. Our next speaker is Dr. Amir Furqan. He has done FCPS anesthesia, FCPS cardiac anesthesia, MCPS, and HPE. He is Assistant Professor of Anesthesiology in Chaudhry Parvez Elahi Institute of Cardiology in Multan, Chief Editor, Medical Journal of South Punjab. He has more than 100 national and international publications and has special interest in regional anesthesia, research, and medical education. Please, Dr. Amir Furqan is here.
Thank you so much, ma'am. Bismillah ar-Rahman ar-Rahim, and good afternoon. And I'm especially thankful to PSA Karachi for inviting me and give me an opportunity to share my thoughts. So, topic is facial pain block in operation room. So, this is a continuation of previous talk. When you have no solution for pain, we have a solution. Just put the xylocaine and block the nerve. So, इधर वर्क कर रहा है, उधर नहीं कर रहा है, इस पे नहीं कर रहा है, इस पे okay, thank you so much. So despite going for literature, I just tried to search out some literature regarding the facial pain blocks, but it's now still an emerging trend. Very limited literature and few case series are available there, so I just designed a small survey and share this link in different groups of anesthesia related people. And fortunately I got 451 responses, and these responses are giving insight of facial pain blocks and their understanding in our anesthesia practicing community. The responses which we receive, almost 36.2% were trainees, they responded us. And then consultant working in teaching hospital, 44.7%, and working in non-teaching hospital, they are 19.1%. So the first question was, what awareness, what knowledge or what understanding they have about the facial pain blocks. Among them, 20.4% saying, heard about facial anesthesia, no. Ab suna hai humne. And 51% say, have knowledge about facial pain blocks, but not practicing. So this is a majority. And 28.6%, they are practicing the facial pain block in operation theatre according to our question. And the purpose for using these blocks, first one, the analgesic purpose, and 42.9% saying, no, they're the reverse, they're the both. 51% saying they are using it for analgesic purpose, and 40.9% saying they are using it for both purpose, that is analgesia and anesthesia. These things have to think about that, what sort of operation they are using facial pain blocks. And 6% purely they are saying they only use for anesthesia purpose. And then the next, how much effectiveness they've observed regarding the facial pain blocks when they use in their daily practice, that is a 97.9%. Then mostly everyone is satisfied according to this observation. And most frequently, blocks which our communities are practicing, almost whole of the list is hitting, and among them the pectoral plain block 1 and 2, they 14% are saying they are using, and then serratus anterior plain block 10% are they saying they are using the serratus anterior, and then erector spine is 22.4%, intercostal block 22%, and then the paravertebral 14, tab block, the majority. They are saying that majority are using tab block. Then quadratus lumborum and parasternal blocks. 8% saying they are also using this. I think they are belonging to cardiac anesthesia or cardiac specialty. So this is about some awareness and practice among our own community. ये सर्वे हमने अपने ग्रुप्स में शेयर किया था पाकिस्तान से रिलेटेड एनेस्थेटिक्स. तो why these are getting popularity? The reason for that. Pain तो हम पहले भी डील कर रहे थे. But I think there are two basic reasons. One is this debate which was started from the previous talk, that the opioid sparing. And these days I just observed it's a hot talk in our different WhatsApp groups. Even senior level people are involved in that talk, whether we should spare the opioids or we should continue with the opioids. तो majority हम ये समझ रहे हैं कि opioids को अब हमें छोड़ देना चाहिए, उसकी बहुत सारी reasons है. तो जब छोड़ेंगे तो कौन हमारी help करेगा? That the most helpful tool is then go with these facial pain blocks. और इसको easy कर दिया these innovations and these tools जो इस वक्त इतने handy हैं कि you just put in your pocket, connect with your mobile device, put on a patient and just start the block and there is no pain. So these are two basic reasons which I believe that is helping this trend to be emerging in anesthesia practice. Mechanism of action, very easy to understand, and most of us believe on this, that this mechanism is actually working underpinning the effect of this facial pain blocks, and literature saying that is a lot of controversies regarding the mechanism of action, how these facial pain blocks works. But first one is neurovascular bundles always run in facial planes. This is the basics of anatomy. हम फर्स्ट ईयर MBBS से पढ़ रहे हैं. तो अगर वहाँ पे हम लोकल एनेस्थेटिक को डाल दें, इंजेक्ट कर दें, So it's a very understandable thing that will block the nerves there. दूसरी reason, that is the intravenous regional anesthesia mechanism. We put the local anesthetic in intravenous system and that diffuse out and give us the anesthetic and analgesic effect. The same effect must having function regarding this facial plane blocks. So these are the two basic understanding regarding the facial pain blocks and their mechanism of action. Different blocks. इसकी अगर लिस्ट पे थोड़ा सा गौर करें तो आपको बॉडी का कोई ऐसा हिस्सा नहीं मिलेगा जहाँ पे आप ये यूज़ नहीं कर सकते. फेशियल प्लेन ब्लॉक्स एंड देन द स्पेसिफिक ब्लॉक, उसकी थोड़ी सी अंडरस्टैंडिंग वो ये है कि इफ़ यू हैव सम स्पेसिफिक आइडेंटिफाइबल नर्व, you label that block with that specific nerve. For example, radial nerve. Although radial nerve and medial nerve also run between the facial planes, लेकिन हम उनको facial plane की classification से थोड़ा सा हटा देते हैं, इसलिए कि वो specific nerve है. Facial pain blocks हम उसको कह रहे हैं जिसमें कोई specific nerve नहीं है, nociceptives हैं या terminal branches run कर रही हैं और उनको block कर रहे हैं. So this is the base underneath concept of facial plane. Thoracic region में PEC1 and PEC2 for breast surgeries, any intervention on anterior of chest, and then serratus anterior block for lateral side of chest we can use for analgesia for ribs, and it has some deeper penetration as well. इसको मैं personally use कर रहा हूँ cardiac center में for patient going for minimal invasive cardiac surgery, जिसमें वो इंटरकोस्टल रीजन में थोरेसिक जो है वो इंसिजन होता है, तो उसके लिए हम इसको यूज़ कर रहे हैं. एंड आई जस्ट पुट द कैथेटर देयर और उसके लिए इन्फ्यूजन चला देते हैं एंड वी हैव वेरी कन्विंसिंग रिजल्ट. इसके लिए हम डाटा कलेक्ट कर रहे हैं, इंशाल्लाह हम वो सून वो हम शेयर कर देंगे. तो उसमें हमने तो ये देखा है कि पोस्ट ऑप में हमें कोई एडिशनल एनाल्जेसिक नहीं देना पड़ता. अभी इंडक्शन में हमने उसको स्पेयर नहीं किया. इंडक्शन तो हम मॉर्फिन फेंटानिल के साथ ही लेके चल रहे हैं इंट्राऑपरेटिवली, लेकिन पोस्ट ऑपरेटिवली हमें ज़रूरत नहीं पड़ी नेलब्यूफेन की या इवन पैरासीटामोल की भी ज़रूरत नहीं पड़ी. तो इसका टॉपअप दे दें और इन्फ्यूजन चलती रहे, दैट्स ओके. दैन इंटरकोस्टल ब्लॉक बहुत पुराना है, फेमिलियर है, पहले लैंडमार्क बेस लगाते थे, अल्ट्रासाउंड ने इसको और ईजी कर दिया. एंड देन द पैरावर्टिब्रल ब्लॉक एंड एरेक्टर स्पाइनीज. एरेक्टर स्पाइनी इज यूनिलैटरल एपिड्यूरल, इसने रिप्लेस कर दिया ऑलमोस्ट पैरावर्टिब्रल ब्लॉक्स को और इंटरकोस्टल को, इट हैज स्प्रेड. और मैकेनिज्म वही है कि आप प्लेन्स में आ गए, देन द लोकल एनेस्थेटिक विल डिफ्यूज अप एंड डाउन. दिस वन इज ए न्यू मोडेलिटी एंड इस पे अभी कोई डाटा इतना कन्विंसिंग डाटा नहीं है कि आप स्टर्नल रीजन की पेन को या स्टर्नल इंसिजन को स्टर्नोटमी के लिए कोई ब्लॉक लगा सकते हैं. तो ये कार्डियक वालों के लिए एक चैलेंज था. अब लिटरेचर इस पे कुछ केस सीरीज़ आ रही हैं, हम भी इसको यूज़ कर रहे हैं, लेकिन इसमें अभी प्रॉब्लम ये है कि बाईलेटरल करना पड़ता है, आप यूनिलैटरल नहीं कर सकते. तो बाईलेटरल कैथेटर डाल के उसमें दो अप्रोचेज हैं, एक इंटरकोस्टल पेक्टोरो इंटरकोस्टल प्लेन ब्लॉक एंड देन द ट्रांसवर्सस थोरेसिक मसल के ऊपर इंटरकोस्टल एंड ट्रांसवर्सस थोरेसिक मसल के बीच में जो प्लेन है उसको यूज़ करते हैं. तो ट्रांसवर्सस थोरेसिक मसल के लिए थोड़ी सी और हमारी लिमिटेशन है व्हेन वी आर डीलिंग विद कैबेज. तो उसमें वो मेमोरी आर्टरी जब हार्वेस्ट करते हैं तो लेफ्ट साइड पे फिर हमें वो प्लेन नहीं मिलती, फिर हमें ऊपर जो है वो पेक्टोरो इंटरकोस्टल फेशियल प्लेन पे आना पड़ता है. इट हैज़ सम कन्विंसिंग टाइप ऑफ इफेक्ट एज वेल. इसमें हमने ये देखा है कि पोस्ट ऑप में जो एनाल्जेसिक रेस्क्यू एनाल्जेसिया है उसकी रिक्वायरमेंट कम करता है. देन द एब्डोमेन tab block and its variations, subcostal and classical lateral, posterior, and then the ilioinguinal and iliohypogastric, that's the modification of tab. So, thank you so much. Question are up.
Thank you, Dr. Amir. Our next speaker is Professor Rafia Tabassum. He is FCPS Anesthesiology, MCPS, HPE, Diploma in Anesthesia, PGD Bioethics, CHPE. She is Professor and Chairperson, Department of Anesthesiology, SICU and Pain Center at People's University of Medical and Health Sciences. Dr. Rafia.
Assalamu alaikum and very good afternoon. Today I'm going to talk about what's new about the pre-operative fasting guidelines, and I hope at the end of this presentation you will learn a lot. So this is the new campus of my institution. The main focus of my today's presentation is basically upon exploration of the various revolutions which are going on in the fields and identification of the various pre-operative fasting guidelines. And meanwhile, you will also learn about the updated guidelines provided by various statutory bodies. So I have no personal or professional conflict of interest to declare. I'm going to start my presentation with a very, very common scenario which you see in your clinical practice. A 19-year-old man is scheduled for ureteric stent replacement under GA, which on the following day, ward nurse placed a strict nil per os after midnight order. During rounds the following morning, the patient reports that he wants to eat. At 9 a.m., the nurse informs that the procedure will take place at 3 p.m. But due to certain emergencies and other unplanned delays, the stent placement occurs at 5 p.m. The patient and family, they express their displeasure about the prolonged fasting and ask why this has happened. So what is pre-operative fasting? Basically, it is a prescribed time. That is, occur, of course, before the procedure, before the patient undergoes anesthesia, whether it's general, regional, or some sedative procedure. During this period, the patient is asked to restrict from the oral intake of the solid as well as liquids. And if we see all over the world, then there are different policies in different countries, in different institutions for the pre-operative fasting. But whatever the policies, whatever the recommendations are, basically it is going to affect the perioperative outcome and patient comfort. Because prolonged periods of fasting, it produces so many unpleasant symptoms in the patient. It is going to increase anxiety, pain, malaise, thirst, hunger, and there is increased risk of post-operative nausea and vomiting also. Why the statutory bodies, they are focusing on renewing and they are revisiting these recommendations again and again? There are certain rationales, because when we talk about pre-operative fasting of 2 hours, basically it is not limited to 2 hours. We all know that. When the patient undergoes surgery, the time may be 6 to 8 hours of fasting additional, which actually constitute a total of 16 hours or more. And the second rationale is that why we used to keep unnecessarily fasting from the clear liquids, and while thinking that it is going to increase the gastric volume. But if the patient receives clear fluid as close to surgery or before undergoing anesthesia, it is not only paradoxically decreasing the gastric volume, but it will also increase the pH. And on the other hand, if the patient is taking clear fluids, and there is regurgitation and aspiration, it is unlikely to result in morbidity or even mortality. So that's why there are so many guidelines which are came into being over the last 10 years. European Society of Anesthesiologists gave guidelines about the adults and the pediatrics. They divided the population into 2 subgroups also, and they were the obese persons and the pregnant ladies. They gave guidelines about the solid food, liquids, breast milk, infant formulas, and clear food also. They gave a detailed recommendation about the use of the aspiration prophylaxis. When came the American Society of Anesthesiologists guideline of 2017, it's a very, very comprehensive document, which not only focuses upon the pre-operative assessment of the patients, identifying the history, and through the examination, what are the patients who are at increased risk of aspiration during the anesthesia and surgery. They also focused and actually recommended that there should be fasting for the breast milk, how much time should be spent. And they said for the clear fluid, there should be 2 hours fasting, for the breast milk, 4 hours, and the non-human will for 6 hours. If the patient has taken fried fruit or some other heavy diet, then 8 hours or more they are comfortable. ASA document is basically most focused on the use of the various drugs, and which include the aspiration prophylaxis along with the prokinetic agents. When we talk about the Indian Society of Anesthesiologists recommendation, so basically if we look into our subcontinent, India and Pakistan, we consume a variety of food items. And they have their own time period for the gastric emptying. So Indian Society of Anesthesiologists, they have given their own recommendation, and they divided the population into various groups. They give recommendation for the bariatrics, obstetrics, pediatrics, adults, and even they include a small section for the gastric ultrasound. So their main salient features were that the pediatric population can take the clear liquids or water 1 hour before the surgery. And the adult who are undergoing surgery, they can consume about 450 ml maximum volume 2 hours before surgery. The maximum volume for the pediatric population was 3 ml per kg. Then came the European Society of Anesthesiologists and Intensive Care recommendations, especially which are for the pediatrics. And they said that peds population should be allowed to take clear liquids 1 hour before surgery, 3 hours for the breast milk, and for the light breakfast or the non-clear fluid, 4 hours they are sufficient, and for the solid 6 hours. It also emphasized the use of the gastric ultrasound, and they also focus on the measurement of the antral cross-sectional area. Basically, this qualitative analysis led people to think and led the statutory bodies to think that what they can think more about it. And then just last month came 2023 guidelines from the ASA again. It is nothing, basically, it is a modular update of the 2017 guidelines. It reaffirms most of the recommendations which were present in the 2017 guidelines about even the drugs also, but they have added certain things. So if we talk about this, the basic purpose or aim of this is to improve the patient care and patient comfort. And what they have said in these recommendations, that they can be adopted as such, or they can be modified, or they can be rejected depending upon the clinical needs or the institutional policies. It means they are very liberal. They are not making it an absolute standard for the whole world. And from where these guidelines or recommendations they have been come, basically they are from the literature, from the expert opinions, and also the available data from various parts of the world. They have given only 5 recommendations. And I'm going to discuss one by one a little bit about them, but basically these were the things which were missing from their 2017 guidelines. And that's why they thought they must give some new recommendations. So recommendation 1 is whether the healthy adult, they drink carbohydrate containing clear liquids until 2 hours before elective procedure, whether they are going GA under regional anesthesia or procedural sedation. What is a healthy adult? Healthy adult which has no comorbid. What kind of comorbid? Basically, which increase the risk of pulmonary aspiration during anesthesia. So these, we all know that they could be gastroesophageal reflux disease, it could be hiatus hernia, some Xanthus diverticulum or gastroparesis, diabetic patient, use of opioids. We are talking continuously about we are leaving the opioids. It can cause even the problems. And the pregnant patients, of course, obese patient, there may be emergency surgeries in, which are concerned with the intestinal obstruction. So lots of things. If we all exclude those things, then it becomes a healthy adult who is undergoing elective surgeries. So these recommendations for the healthy people and for the elective procedures only. The carbohydrate may be simple or complex. Simple, we all know simple means the water that contains fructose or glucose. It may be simple juice from the pulp is drawn, and they may be sport drinks, or even when maltodextrin-like chemical substance they are added, they are known as the complex carbohydrates. Recommendation 2 is there is insufficient evidence to recommend protein-containing clear liquids, preferentially over other clear liquids to offer before the elective procedures requiring whatever kind of anesthesia. Because all the trials, all these studies, they have taken into consideration all the protein-containing fluids, they were also containing carbohydrate compounds. So there was no trial, no study in which there was a comparative analysis of the protein-containing solutions with the pure carbohydrate-containing solutions. Third recommendation was about the use of the chewing gum, that if the person is taking chewing gum to reduce the anxiety or to reduce the level of hunger or thirst, then it should be removed. But it has no effect on the gastric volume. It should be removed because it may become a foreign body. When I talked about the European Society of Anesthesiologists 2022 guidelines, they say ask every child whether he or she is having chewing gum in mouth. So it must be removed. The fourth one is again about the pediatrics, in which they see that there is insufficient evidence regarding the benefits or harm to recommend pediatric population to drink drinks 1 hour versus 2 hours before the elective procedures. And why this has happened? Because they found no difference at all in the rate of aspiration or regurgitation, in the level of the thirst or hunger, or even the gastric pH in the various studies which are conducted in 1 hour versus 2 hours. The last recommendation was to avoid prolonged fasting in the children, because it can cause problems with them. Whatever the period of the fasting, it should be shortened, it should be reduced. And all over the world, if we see, whether it's European Union or it's USA, Australia, New Zealand, all over the world, basically they are recommending the fasting time for the pediatric population should be reduced as much as possible. No child should get refused only because he is not NPO. So consensus guidelines are there, controversies do exist, but all over the world this is going on. So their fasting cards are used. I'm going to conclude my presentation by saying that the whole paradigm is being changed from the unrestricted drinking or the standard level or policies for the fasting, they are being changed. Now they are talking about the unrestricted drinking and liberal fasting policies all over the world. And this can only be achieved by updating our policies and by educating our healthcare professionals, even the pre-operative personals who are seeing these kids. And in addition to that, as I shown you different color cards, the patient education is must. Patient should know what kind of surgery he is undergoing and how much time that surgery needs to deal with the fasting periods. These are my other references. Thank you very much.
Thank you, Dr. Rafia. Our next speaker is Dr. Azhar Rahman. He is assistant professor at Aga Khan University, Karachi. Pioneer ERAS program for general surgical patients started in 2017 at AKU. He has 1 publication and 2 under process in this area. Dr. Azhar.
Assalamu alaikum. So I have no conflict of interest to declare. Every year, a large number of patients have to wait for weeks and months for their elective procedure to be done worldwide. Situation is more graver in low middle income countries, especially in public sector hospitals. Our national data has shown that mean waiting time for elective surgery was 2 to 6 months. This includes the colorectal surgeries and or elective orthopedic surgeries. The Canadian data shows that the median wait time from initial surgical consultation to resection time was 31 days. Now, different countries from the Europe, the data has shown that the waiting time for knee replacement and hip replacement varies from 68 days to 400 days. Out of so many reasons, one important factor is bed occupancy, especially in our country, for delaying elective major surgery. To cope up with these issues in early mid-90s, Professor Henrik introduced a fast-track recovery, which he termed enhanced recovery after surgery, to make the journey of major colorectal surgery smoother. So the question is that what is ERAS? ERAS is basically a patient-centered, evidence-based, multidisciplinary team approach in order to reduce the patient's surgical stress, to optimize the physiological response, and to facilitate recovery, and early discharge and return to normal function. So for the implementation of ERAS, the first step is to make a ERAS team, which should be headed by either by an anesthesiologist or by a surgeon or by a senior nurse. The other members that should include in this team a nutritionist, a physiotherapist, pain management team, operating room staff, and audit team. Once the team is formed, it is their responsibility to develop the protocol for the specific surgery by looking at the resources that are available and the evidence that is present. And then discussion of the concerns of various members should take place. And finally, when the protocol is finalized, it should be applied on the patient care. And after having certain number of cases, they should receive the feedback from the healthcare providers, from the patient, and audit of the practice should be done to bring some other changes if required. So what ERAS did, it was a paradigm shift in perioperative care of the patient. It re-examines the dogmas and replaces them with evidence-based best practices. It is a comprehensive protocol that covers all areas of the patient journey. So basically, there are three main pillars of the ERAS: evidence-based perioperative care processes, then multimodal and multidisciplinary teamwork, and continuous audit. Here you can see a generalized algorithm of the ERAS that could be implemented on any type of surgery with a few changes. So for a successful ERAS program, it is important that the patient involvement, active involvement is mandatory, and multidisciplinary collaboration is very important. So there are a few recommendations in the preoperative phase, in the intraoperative phase, and postoperative phase. In preoperative components, it is recommended to have a targeted patient education. Medical and nutritional optimization is recommended. Anemia optimization. Blood glucose levels should be optimized. Smoking and alcohol cessation. And shortened fasting. Carbohydrate load is recommended, and antibiotic prophylaxis if required. In intraoperative phase, it is recommended to use the short-acting anesthetic agents, use of multimodal analgesia, lung protective ventilation if the procedure is undergoing under general anesthesia, use of antifibrinolytics, avoidance of hyperthermia, infection reduction bundle, and goal-directed fluid therapy. In post-operative phase, the recommendations are use of multimodal analgesia, goal-directed fluid therapy, early extubation, early mobility, and early detection of delirium and its management, tight glycemic control, avoidance of hypothermia, DVT prophylaxis, and early drain and fall removal. This is another figure showing the ERAS key components. It includes surgical components as well. So the journey of ERAS begins with the preoperative information and education and counseling of the patient. Preoperative education has been shown to reduce the patient anxiety, pain, nausea, and vomiting, and increases the patient satisfaction. It is recommended that all patients undergoing elective surgery should be counseled. Detailed information should be given to patients before the procedure about surgical and anesthetic procedures. Shared decision-making is encouraged. Patient expectations during course of hospital stay, specifics of how ERAS is implemented should be discussed. Daily targets for patient to achieve should be set up. Clear, specific instructions about mobilization, diet, and exercise should be discussed. Patient should be provided with a verbal and written information, ideally in the form of a brochure having checkboxes in it. Then comes the role of prehabilitation. Prehabilitation is the process of enhancing an individual's functional capacity to enable him or her to withstand a forthcoming stressor such as a major surgery. Prehab is a multimodal approach encompassing the medical optimization, preoperative physical exercise, nutritional support, stress and anxiety reduction. Preoperative training as a muscle strengthening exercise. If a patient can do it easily, then a daily walk of at least 1 to 2 kilometers is recommended by the RAS, or alternatively bicycling of 30 to 45 minutes. Deep breathing exercise is very important, and it is recommended to do the incentive spirometry 3 times a day, at least 25 breathing exercise each time. Smoking should be stopped if possible 4 weeks before the surgery. That will not only improve the oxygenation but also improve the ciliary function as well. ERAS also strongly recommends the carbohydrate loading preoperatively. So a complex carbohydrate drink, 400 ml in volume, having 50 grams of carbohydrate, should be given 2 hours before surgery for elective patient. That not only decreases insulin resistance but increases the carbohydrate uptake, its utilization and storage. It also decreases the protein breakdown and catabolism. The studies have shown that the preoperative carbohydrate loading decreases 20% in length of hospital stay, 50% decrease in insulin resistance, and 50% less loss of lean body mass. And overall, there is a decrease in the patient discomfort, thirst, hunger, anxiety, and fatigue. The recommendation regarding the nutrition strategies in ERAS protocol is to avoid long periods of preoperative fasting. Clear liquid should be given 2 hours pre-surgery, carbohydrate-rich drink, reestablish oral intake as early as possible, tight glycemic control, early postoperative mobilization to strengthen the protein synthesis and muscle function. Preoperative clear liquid is allowed 2 hours. Maintenance, a balanced crystalloid 1 to 2 ml per kilogram per hour should be given. Ongoing losses should be replaced immediately, and overall a normal volemia should be maintained. Intraoperative fluids guided by flow measurements to optimize cardiac output and esophageal Doppler device to gather targeted fluid on individualized basis should be used if it is available. CVP is not recommended for the routine fluid guidance, as we know that it can give the trends of the fluid, but it cannot correctly guide us. If the patient is normovolemic but getting hypotensive, vasopressors are recommended rather than giving the fluid boluses. Enteral route for fluid postoperatively should be used as early as possible. Intravenous fluid should be discontinued as possible. Now, for a successful ERAS program, the readmission should not exceed more than 10%. And pain, postoperative pain, is one of the reasons for the readmissions. And in ERAS program, it is recommended to have a minimized opioid use by using the multimodal analgesia regime. So the pain management begins in the preoperative phase. It is recommended to use the acetaminophen per oral or intravenous. COX-2 inhibitors can be used along with NSAIDs, or gabapentin per oral can be given. Intraoperatively, IV ketamine, IV lidocaine can be used, regional anesthesia wherever possible, in combination or alone. Thoracic epidural analgesia can be given for midline laparotomies. Magnesium IV can be given, dexmedetomidine can be given. Opioids, if have to be given, it should be short-acting. Postoperatively, again, acetaminophen, COX-2 inhibitors, and NSAIDs should be considered. So overall, for a successful ERAS program, a trimodal approach is recommended, which includes the adequate use of fluid, a good analgesia, and hemodynamic stability. This paper is showing the guidelines that were published last year in May. This is showing the ERAS recommendations for the few surgical procedures for low middle income countries. It is quite useful. So what are the new recommendations? In the last 1 year, they have emphasized a lot on the prehabilitation, preoperative HIV testing, if the patient is coming from the high-risk area, delirium screening and prevention, COVID-19 screening for the patients who have symptoms, thromboembolism prophylaxis is recommended, immunonutrition, and standardized post-operative monitoring guideline. Patient-reported outcomes is recommended, and interactive audit system rather than a traditional audit system is recommended to avoid any bias. So we hear a lot about the ERAS, but if we look at the ground realities, very few centers are doing the ERAS. So there are certain roadblocks for routine implementation. On the top of it is the lack of dedication and enthusiasm. There are too many components to work on it together, lack of standardization, limited resources in developing country, which is a very major factor, logistic issues, social constraints, and adherence and compliance to protocol is very difficult. And most studies incorporated only a portion of the ERAS elements, that's why they're not successful in it. Actually, we started the ERAS program in our hospital for general surgical patients in late 2016. After a few months, we did the audit, and we are waiting for the publication with the title of Perioperative Practices and Their Outcomes in ERAS program in a tertiary care hospital. The overall result, it was successful for the laparoscopic surgery, but not for the open surgery. And the main reason was the failure of surgeons to adhere the recommendation, that is, they were doing the surgery with large incisions, traditional incisions, and were unable to reduce the number of drains and tubes. These are the recommended websites. If anyone is interested, can go on these websites. Thank you.
Thank you, Dr. Azhar. Now the last speaker is Professor Naila Asad, Head of Department of Anaesthesia, Services Institute of Medical Sciences, Lahore. She is convener, MS Anesthesia, and advisor Synopsis Review Committee at University of Health Sciences, Lahore. She has editorials in journals of anesthesia and many national and international publications. Dr. Naila.
Thank you, ma'am. Assalamu alaikum. Bismillahirrahmanirrahim. First of all, I would like to thank the organizers for inviting me for the talk on opioid-free anesthesia. मुझे पता है सबको भूख लग रही है क्योंकि मुझे भी लग रही है, तो I think I'll do as fast as I can. Now, everybody knows that opium has been used as part of sleep-inducing sponges in olden times. They were called spongia somnifera for surgical procedures to control pain. And then in 1847, we came up with the ether, chloroform, which was replaced by halothane, isoflurane, and then desflurane, and we have sevoflurane. And in 1930, balanced anesthesia was given along with thiopentone sodium, which is an intravenous induction agent. The turning point came in 1960s with the synthetic opioids. Why? Because we wanted to block the autonomic nervous system, maintain intraoperative analgesia, along with hemodynamic stability, and to provide post-operative analgesia. Now, already you know about these side effects, what they cause. As Dr. Amer told you that he's using regional to avoid these side effects. A saint is a sinner too. You all know that. Opioid overdose deaths have quadrupled since 1999, and on an average, 91 Americans die each day from an opioid overdose. And half of opioid overdose deaths involve a prescription drug. So this is what do we need to know? We need to know about the opioid crisis, epidemic crisis. This is the number which was published by sources Drug Use and Healthcare in 2020, in which they said that 70,630 died from drug overdose in 2019, 10.1 million misused the prescription of opioids, and 1.6 million had an opioid use disorder. and 48,006 deaths were attributed to overdosing of synthetic opioids, and along with 1.6 million who misused prescription of pain relieving, and the others were with the heroin. Coming to the current scenario, which is changing trends towards opioid-free anesthesia, as Dr. Amir said so, it's a combination of various opioid-sparing techniques which leads to no administration of intraoperative systemic, neuraxial, or intracavitary opioids. And why do we need that? We need that to fight the opioid crisis, to avoid the side effects of opioids, decrease their use, their requirement, to enhance fast track and quality of recovery, post-operative analgesia to reduce the length of stay, to minimize post-op cognitive dysfunction. And what are the drugs we use? These are the drugs: gabapentinoids, NMDA antagonist, locoregional anesthesia, lignocaine, anti-inflammatory drugs, alpha-2 agonists. What is the challenge? The challenge is we have to devise regimens, we have to optimize drug selection to provide optimal doses for intra-op and immediate post-op analgesia to provide improved recovery. Now, there are certain populations in which we can use, in which these are being used as obesity, obstructive sleep apnea syndrome patients, cancer surgery, colorectal ERAS, chronic pain syndromes, and opioid addiction. Now, this study was done to find, and they found out that laparoscopy, they found that the duration in the PACU that was significantly reduced in OFA group when compared to remifentanil anesthesia. But they did not find any difference in the time to extubation. And then the vascos, after 30 minutes of surgery, they were found to be significantly less in opioid-free anesthesia group, and the rescue analgesics were given in lesser number of patients. Then a study done with the erector spinae block in mastectomies. This was done it was compared with normal saline infusion, and in this they used dexmedetomidine, ketamine, and magnesium sulfate. What did they find? They found that the opioid-free anesthesia group that had decreased vascos, which were decreased till 2 hours after surgery, and the time for first rescue analgesia was increased, as well as the rescue analgesia was less given in group M. The patients were very much satisfied in group M. They were about 54.5% when they compared to the normal saline group, in which it was 15.2%. Then this was done in transthoracic esophagectomy. Dexmedetomidine was given along with ketamine and lignocaine. This was compared with fentanyl opioid. And they also found a significant difference among the groups till 4 hours. The opioid-free group, that was, it was significantly, vascos were less in them, and the hemodynamics were more stable, along with duration of ICU stay was less. But there was no significant difference in the extubation time. Then in another study by Abul Sood et al., they did it on breast cancer pain scoring system and immune response. They used thoracic paravertebral block with levobupivacaine, and this was given as incremental doses when the heart rate or arterial pressure increased. And this was compared with nalbuphine. They found that the vascos at rest and at arm were significantly less in opioid-free anesthesia. And the tumor necrosis factor alpha was at 24 hours and 7 days post-operatively from the basal level was increased. And the IL-10, that was also decreased. These are pro-inflammatory they decrease the pro-inflammatory cytokines basically. So neuropathic pain, which was assessed by a DN4 questionnaire, that showed significantly lower scores. And the post-op nausea vomiting was also significantly less with opioid-free anesthesia, and the patients, the degree of satisfaction was more with opioid-free anesthesia. Now, we don't have in favor of all the studies were not in favor of opioid-free anesthesia, but there are certain which are not. And this was done with the magnesium sulfate, ketamine, and lignocaine dexmedetomidine induction, and the maintenance with clonidine, magsulf, and lignocaine compared with fentanyl. They did not find any significant difference in the PACU in pain scores, and also they did not find much difference in PONV. And another study which was done in invasive lumbar spine surgery, they did not see any significant difference in the opioid consumption in PACU, as well as no difference in worst PACU NRS scores. But they did find that the morphine was given to less number of patients in OFA group. Now, this study was done and they found that opioid-free balanced anesthesia was with dexmedetomidine resulted in a greater incidence of post-operative serious side effects and adverse events which were compared with balanced anesthesia with remifentanil in patients who underwent intermediate or major non-cardiac surgery. This was they saw post-operative hypoxemia more in dexmedetomidine group rather than with remifentanil. And then we had, though the morphine consumption was less in dexmedetomidine group, but the time to extubation was earlier in remifentanil group. And the con to it is that it is, this study, this was an editorial which Philip L. he wrote that he said it's too early to adopt opiate-free anesthesia today. He says that the concept of pure OFA is without sufficient evidence to become routine practice. Propofol, ketamine, benzodiazepines, and gabapentin, they also have their side effects, addictive potential, and little data in the literature and no high-quality evidence is collected that switching from a multimodal analgesic regimen to OFA offers any benefit to the patient which would justify these complicated and expensive regimens. So I would conclude with all these pros and cons that it's a safe and effective approach, and it might change our practices in the years to come because we can change them to local regional. But we need focus studies in specific surgeries and patient populations because we need to identify which population to use and which surgeries to take and which adjuvants have to be taken because are they adjuvants to be procedure specific or patient specific, and then nociceptive monitoring intraoperatively. That needs to be required, otherwise we can't go for it. Thank you. I hope I didn't take much time.
Thank you so much for the brilliant presentation by the speakers on the topic of emerging trends in anesthesia. And at the same time, I apologize for abandoning the question answer session. We move on to the certificate distribution. And special thanks to Dr. Arsalan and Dr. Sidra for facilitating the session. Thank you.
I would like to call speakers for receiving their certificates. Dr. Ehsan Wakar. I would like to invite Dr. Fazal Hamid Khan to please proceed on to the stage for certificate distribution. Professor Sadka Aftab, please proceed to stage. Dr. Asma Abdul Salam. Dr. Amir Furqan. Dr. Rafia Tabassum, Dr. Azhar Rahman, and last but not the least, Dr. Naila Asad. Now I would request Dr. Fazal Hamid to please distribute certificates to the chairpersons as well. Dr. Shaida Khwaja and Dr. Nasreen Laik. Thank you so much for the patience. All of the faculty and consultants can proceed to the governor room for the lunch, and the participants and residents to the foyer. Thank you so much, and we'll be looking forward for the second day. We'll be meeting tomorrow at the breakfast session at 8 o'clock.
specialty of plastic surgery. He gave us
in Pakistan. I know. Maybe next time.
Life का switch on. Life का switch on. Life का switch on.
Life का switch on.
Ultra beats on the track.
Wayo ya wayo ya